Okay, so welcome, future doctors. Countdown has begun, and this is your moment to shine. And I am here to ensure that you walk into the examination hall with your head held high and with confidence. My objective would be to mainly help you narrow down to those correct options. So, obviously, the common slogan is very much there. But in the next few minutes, when we dive into this topic, I'll focus on three things. One is high yield topics for the current exam. We'll also talk about proven strategies which are important to handle those tricky questions. So I'll tell you those keywords which are important. And the third aspect would be, like I said, positive mindset. I mean, that's the ultimate goal of all of us. So, uh, fine, guys. I think just give me a confirmation with respect to the audio and the visual part, and then we can get going for today. And meanwhile, our focus would be like I'll go through the various topics like cardio, neuro, endo. We'll go about each one of those topics in a stepwise fashion so that you can revise all of those issues in the shortest possible time frame. Okay, ji, fine. So the first and the foremost thing that I want to bring to your attention is these questions which would always be coming on the topic of cardiac tamponade and constrictive pericarditis. And you guys can quickly comment in the exam for the auscultatory finding of constrictive pericarditis because in MCQ, this is one of the common topics that is always be asked. So yes, guys, Ram Ram, this is for FMG exam. That is our focus. That is the slogan. That is the mantra today to be super confident to ace the final exam. So, fine. Let's focus on the job at hand, and I would like you to let me know. Like ये तो आप सबको पता ही है ना. Tamponade में there would always be a muffled heart sound because there is fluid outside the heart. The usual causes can be like TB or it can be lung cancer. But he will then ask you regarding what is the auscultatory finding because that's the main aspect in the question. And I think I was waiting for the correct answer. Ram Ram to everybody. Very good. The correct input there would be pericardial shudder or pericardial shock. So what you need to look at any question that would be giving you an X-ray and then he's gonna give you history of like tubercular pericarditis. Then there can be two possibilities. ट्यूबरकुलर पेरिकार्डिटिस का अगर इलाज नहीं करते हैं तो वो कार्डियक टैम्पोनेट में डिटेरिएट हो जाता है और इलाज के बाद में देयर इज अ कैल्सिफिकेशन दैट इज प्रेजेंट सो वन एंड द फॉरमोस्ट इज लाइक यू विल हैव टू लुक फॉर दिस ऑस्कल्टेटरी फाइंडिंग ऑफ पेरिकार्डियल शॉक या फिर वो पेरिकार्डियल शॉक ना लिख के सिर्फ बोल देगा लाउड डायस्टोलिक साउंड तो प्लीज डू नॉट कंफ्यूज दिस विद लाउड डायस्टोलिक मर्मर आई एम टॉकिंग अबाउट लाउड डायस्टोलिक साउंड मर्मर जो होता है डायस्टोलिक वो तो माइट्रोसिनोसिस में होता है बट दिस वुड बी अ डायस्टोलिक साउंड ऑफ वुड बी अ पेरिकार्डियल शडर the BP in both of them would be low, but if he says crashing blood pressure, then crashing blood pressure is always a feature of cardiac tamponade because there would be like a lot of fluid outside the heart, crushing the heart from outside. So the main aspect is always check out the heart sounds, blood pressure, and then the JVP findings for the topic of cardiac tamponade and constrictive pericarditis. Because when it comes to back stride, the left side will be easy for you. You know, non-pulse muffled heart sounds ठीक है, but you also need to remember non-pulsatile elevated JVP एक तो उसने ये पूछा हुआ है and then he's also asked with respect to the JVP funding in this case which I think somebody had already commented in the chat. It would be steep X and absent Y and I would like everybody to hit in the comment box. Let me know guys what is the JVP finding with respect to constrictive pericarditis. Yes, guys, waiting. I want these prompt answers that should be coming, and I want that the next 3 hours should be very, very productive, guys. I am gonna help you revise the core aspects. As I said, high yield topics to maximize your output. So just focus on the aspect here. No, guys, I have already written that absent Y before you for cardiac tamponade क्योंकि इसमें filling नहीं होता है. But in constrictive pericarditis, there are rapid ventricular filling. So in rapid ventricular filling, there would be a steep Y descent. Why there is a steep Y descent is because in constrictive pericarditis, there is a rapid ventricular filling, whereas why would you be having an absent Y descent in cardiac tamponade is because there is a absent rapid ventricular filling. So first and foremost, what I want you to be very thorough is the three examination findings that I said. Any question that deals with tubercular pericarditis in a patient, there can be two possibilities. If it's not treated, then you'll deteriorate into tamponade. And if it's gonna be like treated with ATT, then subsequently calcification outside the heart can occur, and that would be constrictive pericarditis. The pulse finding in both of them is common. The pulse finding, do not use pulse to differentiate between the two, क्योंकि दोनों में जो पल्स होती है वो कॉमन होती है, दैट इज गोना बी पल्सस पैराडॉक्सस। तो पल्सस पैराडॉक्सस को अपना जो बेसिक बॉल पॉइंट है या जो बॉल पार्क पॉइंट है उसको नहीं बनाना है। यू यूज ऑस्कल्टेटरी फाइंडिंग, ब्लड प्रेशर एंड जेवीपी फाइंडिंग्स, एंड देन वाटर बॉटल हार्ट एंड मनी बैग अपीयरेंस से तो रिलेटिवली इजी हो जाएगा। एंड व्हेन इट कम्स टू constrictive pericarditis, then you will not be having a water bottle heart, but you would be having a calcification outside the heart। तो एक तो यार ये सारे इश्यूज जो हैं, अब भाई बंद करो यार ये सारा, इज इट लाइव, इज इट नॉट लाइव, ना यू नीड टू फोकस गाइस। तो कैल्सिफिकेशन अराउंड द चेस्ट एक्सरे वुड बी प्रेजेंट इन दिस पेशेंट। द लर्निंग पॉइंट फ्रॉम दिस पर्टिकुलर स्लाइड इज कि आपको पल्स फाइंडिंग से डिफरेंशिएट नहीं करना है, ईसीजी फाइंडिंग से डिफरेंशिएट नहीं करना है, बिकॉज पल्स फाइंडिंग्स और ईसीजी फाइंडिंग यार वो दोनों कॉमन होती हैं। दोनों में लो वोल्टेज ईसीजी। इफ कार्डियक टेम्पोरल में इट इज बिकॉज देयर इज वाटर आउटसाइड द हार्ट, and in constrictive pericarditis, why it's a low voltage ECGs, because there is calcification outside the heart. So do not use those for differentiation. But yes, like somebody mentioned, small signs. So if that is given, that is a excellent input that I can write here, because I wrote pulsatile elevated JVP. Now that does not fall with inspiration. So what he can also write is small sign with respect to constrictive pericarditis, which would not be present in patients of cardiac tamponade. So this is like, man, LRR is like ultra long. This is a much more shorter revision program, right? So just listen to the core aspects that I'm speaking before you, and then subsequently, as far as the treatment is concerned, please comment in the chat box. For pericardiocentesis, what would be the approach that you will be using? I mean, from where would you be introducing the needle? Pericardiocentesis के लिए जो approach होता है, that would be from which area? I mean, which intercostal space would you be putting the needle from? Options are second intercostal space, fifth intercostal space, seventh intercostal space, and you can take one option as like Xiphi sternum. So yes, guys. Electrical alternance is again a feature that is fluctuation, but then electrical alternance again is not a very good way for differentiation. Like I said, pulse finding जो है उसको use नहीं करना है, and ECG finding is not to be used. Guys, यहाँ पे जो answer है, that is not gonna be answered as fifth intercostal space. I want you guys to focus very very clearly. मैंने बोला कि भाई कहाँ से needle डालेंगे. So the site of putting the needle is not gonna be given as fifth intercostal space. It will be a Xiphi approach. क्योंकि what you have to understand is कि भाई there is fluid outside the heart, तो intercostal space से क्यों जाएंगे? मतलब lungs के थ्रू जाने की जरूरत नहीं है ना। So it is Xiphi approach, and then you will be going ahead with pericardiocentesis. और यहाँ पे एक और पॉइंट कहना चाहता हूँ कि if there is gonna be trauma which is responsible for cardiac tamponade, then do not answer pericardiocentesis। अगर वो सवाल में बोलता है कि पेशेंट को penetrating injury to the chest था, छाती में चाकू मार दिया, and there is a penetrating injury to the chest, and he says what is the best way for management of cardiac tamponade, then the answer would be given as a emergency resuscitative thoracotomy। Yes guys, if it is blood outside the heart, तब आपने pericardiocentesis नहीं बोलना है। The reason for that being that even if you will remove that blood, more blood will come. So if he specifies in the question that it is a trauma case with respect to cardiac tamponade, then your answer would be given as emergency resuscitative thoracotomy. And for pericardiocentesis, as I told you, the approach would be a Xiphi sternal approach. And the right hand side, obviously, this would be a stripping procedure that would be done because there is calcification outside the heart of the patient. So stripping procedure would be primarily done. The bottom line to be understood is right side of the discussion is calcification, where limitation of filling of blood is occurring. Whereas in cardiac tamponade, there is no filling of blood because the heart is totally getting crushed. So both questions could be beginning with discussion of, because that was what happened last time. They gave a question beginning with patient suffering from extrapulmonary TB. And then he asked you to differentiate. So the answer turned out to be constrictive pericarditis, primarily because of the aspects that I have mentioned here. So you need to get a clear differentiation. And please remember once again that for pneumothorax, it is fifth intercostal space. For thoracocentesis, it is eighth intercostal space. But for pericardiocentesis, it is not intercostal space. भाई अगर हार्ट में जाना है तो हम उसमें इंटरकॉस्टल लंग से नहीं जाएंगे. सो व्हाट यू आर गोना डू इन दैट केस इज यू गोना बी इंट्रोड्यूसिंग अ नीडल फ्रॉम द Zephyr approach. So that would be one aspect to be remembered. And then one liner we will do. What is the best clinical pointer to differentiate between cardiac tamponade and tension pneumothorax? In cardiac tamponade also, the BP will be unrecordable. In tension pneumothorax also, BP will be unrecordable. Both will be having findings of obstructive shock. In cardiac tamponade also, elevated JVP would be present. And tension pneumothorax also, there would be pressure on the great veins like SVC, IVC. So JVP would be elevated. So since these two findings are common between the two, he has said what is the best way for differentiation, and your answer would be in tension pneumothorax there would be presence of absent breath sound. So yes, that is a very good input there, that if the main pointer for differentiation between the two would be that breath sounds will be perfectly normal with respect to cardiac tamponade, but when it comes to breath sounds for tension pneumothorax there would be absent breath sounds. So that would be an answer to the one liner that I mentioned. But this is one slide, guys, that you need to have a photographic memory, because this is like, this is like a standard question that is always asked in the exam. So once you get these two aspects right, what I'll move on is to my subsequent slide, where we'll talk about the various types of cardiomyopathies. The leading cause of hypertrophic cardiomyopathy is genetic. Right, you all of you know it is autosomal dominant, and there would be a defect of beta myosin gene, that would be MYH7 gene. Beta myosin is the one which would be affected in this case. So the name of the gene I'll just write it because genetics is always asked. So it would be MYH7, and that would be ascribed to chromosome number 14. So it's a genetic disorder. But when it comes to dilated cardiomyopathy, the main reason would be a toxin, and the toxin most of the time would be alcohol, or it could be a sequelae for viral myocarditis. So you need to remember the common causes of dilated cardiomyopathy. There are three to be remembered: long-term alcohol intake, viral myocarditis, and after that, the third important one from the MCQ perspective is he will give you a child who's having Duchene's muscular dystrophy. When it comes to restrictive cardiomyopathy, the leading cause to be remembered in those cases would be amyloidosis. And restrictive cardiomyopathy is the rarest type of cardiomyopathy, but has the commonest cause of amyloidosis. Once you get the common causes right, what should be written in the question that would tell you that it is hypertrophic cardiomyopathy? He will talk about a pulse finding. Quickly comment in the chat box what is the type of pulse that would be seen in hypertrophic cardiomyopathy, and what is the type of pulse that would be seen in dilated cardiomyopathy. For dilated cardiomyopathy, it begins with a D, and the type of pulse that would be seen would be called as dicrotic pulse. And for hypertrophic cardiomyopathy, there was one question on this in the last time's paper. I think it was not exactly a question, but this was one of the options, that pulses variance would be encountered in patients of hypertrophic cardiomyopathy. So one, you need to remember the differentiation in the pulse, and the remaining findings in both of them would be common. No shortness of breath, pulmonary edema, that would be a standard presentation with both of them. Like both of these questions will talk about shortness of breath in a patient. Both of these can present with, they can be subsequently, like in hypertrophic cardiomyopathy, also pedal edema can develop. So the point is like initial line of the question would be same. Breathing difficulty will be explained in both of them, but and the risk of sudden death is also present in both of them. The reasons can be different. Like in hypertrophic cardiomyopathy, it can be a ventricular fibrillation, and in dilated cardiomyopathy, it can be an atrial fibrillation or a ventricular fibrillation. So both can die suddenly, but then the pulse is a differentiating feature. Whereas for restrictive cardiomyopathy, the main aspect in the question would not be pulse, but what you will use for identification would be presence of Kussmaul sign. And because the compliance of the right side of the heart will be affected, so there would be a pedal edema. And because the compliance of the left side of the heart would be affected, so there would be a pedal pulmonary edema component present. So you can differentiate between the aspects that I mentioned here. And another hint can be like he can give you a gross specimen, or he can give you echocardiography. On echocardiography, if he says global, all the four chambers of the heart are relatively enlarged. You can notice that global enlargement is there. All the four chambers of the heart are showing an enlargement. But as far as the thickness of the cardiac muscle is concerned, the thickness of the cardiac muscle is reduced, then it's going to be dilated cardiomyopathy. Whereas in hypertrophic cardiomyopathy, he will mainly give you this finding of asymmetrical septal hypertrophy. But then what you can understand here is that the septal hypertrophy is a very good pickup point in a question, especially gives a specimen or mentions regarding the thickness of the muscle being increased. Whereas when it comes to restrictive cardiomyopathy, the main echocardiographic finding will be jumbo atria. आप जैसे इस डायग्राम में देख रहे हो कि it is gonna be like very stiff ventricles present. So because of the stiff ventricles, the atria को ज्यादा जोर लगाना पड़ेगा. So they would be like dilated atria present. बच्चे banana shaped ventricle is a very good answer that you guys are giving. पता क्या है वो banana shaped ventricle लिखेगा नहीं because it will become easier for him ना. वो easier for you guys. तो बहुत बारी that classical terminology like banana shaped cavity of the ventricle is not given. So even if it is like not given, you should be in a position to identify the differences that I've highlighted between the specimens here. Like we have done it like 15 seconds for each of them, but this is like a quick recap for the various cardiomyopathies that can be asked to you. And now we will focus on congestive heart failure. Yeah, atrial enlargement, बच्चे. It would not be atrial hypertrophy, it's a atrial dilation. इसको मैंने hypertrophy नहीं बोलेंगे, it's a atrial dilation that would be present, and that's because stiff ventricles है ना, तो atria को ज्यादा जोर लगाना पड़ता है, तो that is why you would be having like stiff ventricles present. Aortic बच्चे Austin Flint murmur जो है ना, that is a feature of basically aortic regurgitation. So at the moment, let's not get into that. Okay, the next image that you can see is very classical for a bat wing pulmonary edema. Again, a very standard scenario. वो कैसे बोलेगा? वो बोलेगा कि एक पेशेंट को हाइपरटेंसिव क्राइसिस है और उस हाइपरटेंसिव क्राइसिस वाला ये जो पेशेंट है ये हाइपरटेंशन का दवाई तो खाता नहीं है, हाइपरटेंसिव इमरजेंसी है और उसकी वजह से उसका लेफ्ट वेंट्रिकल फेल हो गया. प्लीज कमेंट इन द चैट बॉक्स व्हाट इज द ड्रग ऑफ चॉइस ऑफ कार्डियक hypertensive emergency. I repeat that once again. What is the drug of choice for cardiac hypertensive emergency? What I mean by cardiac hypertensive emergency is that it is contributing to left ventricle failure, and that is why in the X-ray of the patient there is a bat wing pulmonary edema. तो blood pressure को कम करने के लिए क्या करेंगे? Yes, guys. Options I'll say options are like sodium nitroprusside, labetalol, nitroglycerin. I'll repeat them once again. Labetalol, nitroprusside, and nitroglycerin. Select one as the best drug for management of this patient. For cardiac emergencies, guys, एवरी टाइम देर इज अ दो अलग अलग है, एक है कार्डियक और एक है न्यूरोलॉजिकल हाइपरटेंसिव क्राइसिस. इस पे बच्चे हमेशा क्वेश्चन आता है कार्डियक हाइपरटेंसिव क्राइसिस एंड न्यूरोलॉजिकल हाइपरटेंसिव क्राइसिस. ये मतलब कोई ऐसा एग्जाम होता है चाहे वो मतलब चाहे एफएमजी है, नीट पीजी है, इनिसेट है, नर्सिंग के एग्जाम्स हैं, सारे एग्जाम्स में कार्डियक हाइपरटेंसिव क्राइसिस और न्यूरोलॉजिकल हाइपरटेंसिव क्राइसिस पूछता ही है. कार्डियक मतलब बीपी इतना बढ़ गया कि उसको लेफ्ट वेंट्रिकल फेलियर हो गया, पल्मरी एडिमा हो गया. तो पल्मरी एडिमा के लिए बच्चे क्या लिखोगे? तो आपका आंसर होगा नाइट्रोग्लिसरिन. इमरजेंसी की बात कर रहे हैं. बीपी ऑफ दिस पेशेंट इज अल्ट्रा हाई, राइट? 220 बाय, लाइक आई एम सेइंग, ब्लड प्रेशर इज गोइंग टू 220 बाय 130 millimeter of mercury or even higher. Like this is like crazy values, 220 by 120, and there is presence of end organ damage in a patient. So with those ultra high values, the drug that you will be giving for the patient is nitroglycerin. और जो न्यूरोलॉजिकल होता है उसके लिए जो ड्रग चॉइस होता है निकाल्डापिन होता है. दिस इज लाइक अ मस्ट नो एमसीक्यूज फॉर यू गाइस, यू जस्ट कांट अवॉइड दिस. इसको तो फार्मा में भी पढ़ाते हैं. एंड आई रिपीट दिस वंस अगेन फॉर कार्डियक हाइपरटेंसिव क्राइसिस. जब बीपी बढ़ गया यार, उसको हार्ट फेलियर हो जाएगा ना, तो हार्ट फेलियर वाले को नाइट्रोग्लिसरिन दे देंगे. और अगर न्यूरोलॉजिकल हाइपरटेंसिव क्राइसिस है तो उसमें जो फर्स्ट आंसर है दैट वुड बी गिवन एज निकाल्डापिन. Having said that, what you will do in this case is LMNOP. So for emergency purposes, for hypertensive crisis, when the person goes into pulmonary edema, तो उसके लिए दवाइयां तो देनी है. तो हम लास्टिक्स देंगे, मॉर्फिन देंगे. वो आपको मैंने बताया हुआ है कि इतने सारे पेन किलर हैं फिर भी मॉर्फिन यूज करते हैं क्योंकि वो हार्ट की ऑक्सीजन कंजम्पशन कम करता है, वो वेगोटोनिक एक्शन करता है. दैट इज व्हाई मॉर्फिन इज व्हाट इज यूज्ड. उसके बाद में नाइट्रोग्लिसरिन है, ऑक्सीजन है और पोजिशनिंग है. और पोजिशनिंग में वी विल इंश्योर दैट द पेशेंट्स हेड इज हायर as compared to the legs of the patient ताकि venous return to the heart can be basically reduced. तो LMNOP is the treatment that would be done for all cases of acute हार्ट फेलियर. वो एक्यूट हार्ट फेलियर लिखे, एक्यूट कंजेस्टिव हार्ट फेलियर लिखे, एक ही बात है. और बीटा ब्लॉकर्स जो होते हैं वो एक्यूट हार्ट फेलियर में कॉन्ट्राइंडिकेट होते हैं. बच्चे अगर निकार्डापिन, ओके, व्हेन टू आंसर लबीटालॉल, दैट इज फॉर एक्लैम्सिया. इफ ही सेज एक्लैम्सिया and he says hypertensive crisis, then the answer would be given as labetalol. These are like three important hypertensive crisis wale emergencies. So that is when you have to answer labetalol. Eclampsia answer, the single best answer hai, that is only for eclampsia. Okay. Hi Naresh. Okay, ji. When to give sodium nitroprusside? Okay, so भाई ये तुम लोगों को मुझे बताना है आज। आप लोग मुझसे पूछ रहे हो सर कब बोलना है, आप बताओ ना कि सर सोडियम नाइट्रोक्साइड देंगे हाइपरटेंसिव एन्सेफेलोपैथी में। बीपी अगर इतना बढ़ गया कि आदमी के ना ब्रेन की ब्लड वेसल स्पैज्म में चलेगी, स्ट्रोक नहीं कह रहा हूँ, स्ट्रोक में तो ब्रेन की ब्लड वेसल बर्स्ट कर जाएगी, ब्रेन हैमरेज हो जाएगी, वहां तो निकार्डिपिन यूज करते हैं। लेकिन जब बीपी बढ़ता है तो व्हाट ब्रेन विल डू इज इट विल कॉज अ स्पैज्म ऑफ द ब्रेन ब्लड वेसल्स टू प्रोटेक्ट द ब्रेन वैस्कुलेचर। एंड बिकॉज ब्रेन ब्लड वेसल्स कॉन्स्ट्रिक्ट करेंगी तो उसकी वजह से क्या होगा कि भाई इश्कीमिया हो जाएगा और बंदा अनकॉन्शियस हो जाएगा। सो इफ ही सेज हाइपरटेंसिव इमरजेंसी और हाइपरटेंसिव एनसेफेलोपैथी, दैट इज व्हेन द ड्रग ऑफ चॉइस दैट वुड बी गिवन फॉर दिस पेशेंट is no, nimodipine नहीं देते भाई, nimodipine is used in subarachnoid hemorrhage, it is not used for stroke patients of hemorrhagic stroke, so read it very thoroughly. सोडियम नाइट्रोक्साइड ये जो मैं अभी लिख रहा हूँ, ये इसका ये मस्ट नो फैक्ट्स हैं, ये कभी आपकी कैरियर में कभी गलत नहीं होने चाहिए, एग्जाम तो सेकेंडरी हो जाता है। सो इट इज गोना बी लाइक कार्डियक इमरजेंसी, नाइट्रो कार्डियक हाइपरटेंसिव क्राइसिस, मतलब बीपी बढ़ गया और हार्ट फेलियर हो गया, नाइट्रोग्लिसरीन। अगर स्ट्रोक है तब हम निकार्डिपिन यूज करेंगे, एक्लैम्सिया है तो लविटालॉल, और उसके बाद में हाइपरटेंसिव एन्सेफेलोपैथी तो सोडियम नाइट्रोक्साइड। एक्लैम्सिया में सीजर्स के लिए देते हैं मैग्नीशियम सल्फेट, वी डोंट गिव इट फॉर लाइक कंट्रोल ऑफ ब्लड प्रेशर कंट्रोल इज लविटालॉल इन एक्लैम्सिया। Why do you give magnesium sulfate? Magnesium sulfate is to reduce the neuronal excitability that is used for treatment of seizures. आप पढ़ो फिर से eclampsia के टॉपिक को गायनेकोलॉजी में। There are two things in eclampsia. One is high blood pressure. Second is seizures. For the seizures part is what you are using is magnesium sulfate in the patient. So great, guys. These are like LMNOP in acute heart failure. Beta blockers are not used. Let me know the drug of choice for chronic heart failure. Moving on to the right hand side of the table, quick answers there. What is the drug of choice for chronic heart failure? उसको लिखेगा कैसे, वो हाई फाई बनाने के लिख देगा हार्ट फेलियर विद reduced ejection fraction। उसको थोड़ा सा हाई फाई बना के he will write like this: congestive heart failure with reduced ejection fraction। Okay. Okay, Shiv, what happened? Let me know. Drop me a mail at marvamedicine at gmail.com, whatever is the issue. Yeah, ischemic stroke में बच्चे, what we do is we try to go in for permissive hypertension because we don't want the brain perfusion to decrease immediately. So we usually keep the blood pressure less than 185 by 110, as will come up in the question subsequently. Very good. The drug of choice for chronic heart failure is ACE inhibitor. That's the first line drug that would be started. So here what you will do is you will be using A plus B plus double A. And what I mean by the word double A is aldosterone antagonist. So the aldosterone antagonist that you can be using is like spironolactone. We can be using eplerenone. We can be using finrenone. There are so many, you know, mineralocorticoid receptor antagonists present because in all patients of cardiac output, इन ऑल पेशेंट्स ऑफ कंजेस्टिव हार्ट फेलियर कार्डियक आउटपुट कम हो जाता है ना, और कार्डियक आउटपुट कम होता है तो फिर देर इज लाइक डिक्रीज जीएफआर दैट विल कॉज रैश एक्टिवेशन। एंड बिकॉज ऑफ रैश एक्टिवेशन वी विल ऑलवेज टेल दिस पेशेंट्स कि भाई नमक कम खाना है, पानी जो है लिमिटेड पीना है, बिकॉज अदरवाइज दे एंड अप विद एक्सटेंसिव अमाउंट ऑफ एडिमा। सो फॉर मैनेजमेंट ऑफ पेशेंट्स ऑफ chronic heart failure the main drug is ACE inhibitor along with this beta blocker, and then we use aldosterone antagonist। बच्चे डायूरेटिक्स वुड नॉट बी रिकमेंडेड, लाइक डायूरेटिक वर्ड की जगह पे ना आप बोलना मिनरलोकॉर्टिकॉइड रिसेप्टर एंटागोनिस्ट। मैंने रीजन बताया ना, क्योंकि एल्डोस्टेरोन बढ़ा हुआ है उसका, तो इस वजह से हम इस पेशेंट में व्हाट वी विल डू इज एल्डोस्टेरोन रिसेप्टर एंटागोनिस्ट व्हिच इज ऑब्वियसली अ डायूरेटिक, बट डायूरेटिक बोलने की जगह पे आप एमआरए बोलना, मैग्नेटिक रेजोनेंस एंजियोग्राफी। somebody said कि why would we be I mean why would you I think I missed that query कि आर्नी कहाँ पे देंगे। तो बच्चे आर्नी तब देते हैं जब एस इनहिबिटर्स जो है ना पेशेंट टॉलरेट नहीं कर पा रहा होता। आर्नी इज यूज्ड व्हेन पर्सन इज नॉट एबल टू टॉलरेट एस इनहिबिटर्स। सो अभी करते हैं आर्नी की बात। लेट मी नो। ओके, आई एम कमिंग टू आकाश टू आर्नी, बट लेट्स जस्ट फिनिश दिस ना। क्रॉनिक हार्ट फेलियर में आपको ए प्लस बी प्लस एम आर ए मैग्नेट दैट इज मिनरलोकॉर्टिकॉइड रिसेप्टर एंटागनिस्ट यूज करना है। एंड वेरी गुड धीरज, आई वॉज वेटिंग फॉर दिस, इट केम लेट। That is SGLT2 inhibitors are to be used in all patients of chronic heart failure because ये diabetic patients को तो मदद करते ही हैं, but they will also be causing a decrease in I mean they will help in urinary loss of sodium। SGLT2 इनहिबिटर जो दवाई थी वो हमने बनाई तो डायबिटीज के कंट्रोल के लिए थी, लेकिन वो दवाई क्या करती है, वो यूरिनरी लॉस ऑफ सोडियम करती है, और इस यूरिनरी लॉस ऑफ सोडियम की वजह से क्या होगा कि जो सिस्टोलिक बीपी है वो कम हो जाता है, और सिस्टोलिक बीपी कम होगा तो फिर हार्ट के ऊपर स्ट्रेस कम हो जाएगा। इस वजह से हम SGLT2 इनहिबिटर्स को यूज कर रहे होते हैं। तो आप पहले तो आपको ये एस्पेक्ट याद रखना है कि भाई SGLT2 इनहिबिटर्स आर टू बी यूज्ड इन क्रॉनिक हार्ट फेलियर। अब जो क्वेरी आ रही है बच्चों की वो है कि सर कब हम बोलेंगे कि आर्नी देना है। तो बच्चे आर्नी कब देते हैं, व्हेन पर्सन इज हैविंग हार्ट फेलियर विद प्रिजर्व्ड इजेक्शन फ्रैक्शन। प्रिजर्व्ड इजेक्शन फ्रैक्शन की डेफिनेशन होती है इजेक्शन फ्रैक्शन मोर देन 50%। हम तो रेड्यूस्ड इजेक्शन फ्रैक्शन की बात कर रहे थे ना, HF रेफ की बात कर रहे थे, रेड्यूस्ड इजेक्शन फ्रैक्शन की। तो हार्ट फेलियर विद प्रिजर्व्ड इजेक्शन फ्रैक्शन में आंसर आर्नी होता है। सो बी वेरी वेरी केयरफुल अबाउट द टेक्निकल थिंग्स दैट यू हैव टू आंसर। और जो मैंने यहाँ पर लेफ्ट में दवाइयाँ लिखी हैं, कार्डियक हाइपरटेंसिव इमरजेंसी, न्यूरोलॉजिकल हाइपरटेंसिव इमरजेंसी, एक्लैम्सिया का हाइपरटेंशन, एंड देन हाइपरटेंसिव एन्सेफलोपैथी, दे आर लाइक मस्ट नो फैक्ट्स विद रिस्पेक्ट टू हाई ब्लड प्रेशर इन अ पेशेंट। PDF यार, ये इसके ना ग्रुप के डिस्क्रिप्शन डिस्कशन में ना, डिस्क्रिप्शन में देखोगे तो टेलीग्राम ग्रुप होगा, उसमें बाद में आ जाएगा। Okay, very good. So I had very good answers here. Let's have, I would like everybody to hit the comment box here. I want to know from you what is the reason for the C wave. A wave मैं लिख रहा हूँ वो relatively easy होती है. Everybody is able to answer. A wave is atrial systole. X भी लिख रहा हूँ because that is again people are able to answer, that is atrial relaxation. So X में atrial relaxation याद कर लेना, and atrial diastole और A wave का atrial systole. Let me know in the comment box. I want everybody to hit the comment box and let me know the reason for the C wave. And your answer would be कि सर जी C wave मिलेगी IVC में, आइसोवॉल्यूमेट्रिक कॉन्ट्रैक्शन में। और ये जो आइसोवॉल्यूमेट्रिक कॉन्ट्रैक्शन होगा, दिस वुड बी बेसिकली द बल्ज ऑफ द ट्राइकिस्पिड बल्ज। सो गुड गाइस, आई मीन C वेव पे यूजुअली वो क्वेश्चन डाल देता है। उसके बाद में फिर हम V और Y की बात कर लेते हैं। तो जो V वेव होती है दैट इज बिकॉज ऑफ रैपिड एट्रियल फिलिंग, बिकॉज अल्टीमेटली जो एट्रिया हैं वो फिर से रिलैक्स करना शुरू कर देंगे, दे हैव टू गेट फिल्ड विद ब्लड फ्रॉम द वेनस रिटर्न। टेस्टिंग टेस्टिंग, आई थिंक वो वापस आ गया होगा। ओके, आई थिंक द साउंड वुड बी कमिंग। अभी आ रही है? आई थिंक इट वुड बी बैक। Yes, guys, just quickly let me know if the sound is back, and on my end it is perfectly fine. अभी देखो यार, and let me know. Okay जी, fine. So I think the sound is back now, and what I was saying was कि कार्डिक एक्शन पोटेंशियल को क्विकली 15 सेकंड्स में करते हैं। द कार्डिक एक्शन पोटेंशियल वुड बी, जैसे ये फेज 0 होता है, फेज 1 होता है, देन इज फेज 2 एंड देन इज फेज 3। तो आपको बस इतना याद रखना है कि जो फेज 0 एंड 1 है दैट इज गोना बी रिलेटेड टू सोडियम एंट्री, दैट इज सोडियम इन्फ्लक्स, एंड द सोडियम इन्फ्लक्स विल स्टॉप। देन इज फेज 2 जो होता है कार्डिक एक्शन पोटेंशियल का, दैट इज रिलेटेड टू कैल्शियम, that is L type voltage gated calcium channels. And then phase 3 is going to be related to potassium efflux. So just a quick recap here कि भाई जो cardiac action potential है, resting membrane potential will be -90, and what I just said was that each of these waves would be these phases are related to the following electrolytes. And then phase 0 and 1 is related to QRS complex in the ECG. Phase 2 is related to ST segment in the ECG, that is the isoelectric segment, and the T wave is related to phase number 3. सी वेव क्यों होती है बच्चे, तो क्विक रिकैप कर लेते हैं। सी वेव का मैं डायग्राम यहाँ पे बना देता हूँ सो दैट यू कैन अंडरस्टैंड दिस बेटर। बाकी मेरे हिसाब से तो इसमें ज्यादा कुछ है नहीं है। यू कैन सी कि वेंट्रिकल जोर लगा रहे हैं, तो इस वजह से aortic और पल्मोनिक वेल्व तो बंद है, सो देयर इज अ बल्ज ऑफ द ट्राइगेस्पिड वेल्व एंड माइट्रल वेल्व इन अपर डायरेक्शन। तो ये जो बल्ज है ना ऊपर की तरफ में, दिस इज रिस्पॉन्सिबल फॉर पॉजिटिव डिफ्लेक्शन विच वुड बी रिस्पॉन्सिबल फॉर दिस पॉजिटिव अपवर्ड डिफ्लेक्शन। तो आई थिंक दैट इज सी वेव एंड दैट्स रिलेटिवली easier to comprehend. ओके जी, ग्रेट ग्रेट ग्रेट। आई थिंक आकाश यू वर क्विक इन आंसरिंग दैट। ये याद कर लेना यार, फेज 0 and 1 रिलेटेड टू क्यूआरएस, फेज 2 इज रिलेटेड टू एसटी सेगमेंट जिसको आइसोइलेक्ट्रिक सेगमेंट बोलते हैं, एंड देन इज गोना बी फेज 3 दैट इज पोटेशियम इफ्लक्स विच इज रिस्पॉन्सिबल फॉर द टी वेव. Once you get this, then a quick recap for what we have already discussed, that is absent accent steep y descent. Waiting for your inputs here, guys. Which condition have you read where there is a absent x descent and then there is a steep y? Yes, guys. And then I'll subsequently discuss this MCQ where steep x follow common thing will be there. Which condition have you read where there is a absent x and a steep y descent? Quickly, guys. क्योंकि स्टीप एक्स और एब्सेंट वाई भी कर लोगे, स्टीप एक्स और स्टीप वाई भी कर लोगे, बट विच वन इज हैविंग एब्सेंट एक्स? एंड यस, वेरी गुड। आई थिंक Dipesh and Divyam were the first ones to answer. That would be tricuspid regurgitation because TR में सारा blood ऊपर चला जाएगा ना, so X would be absent and there would be a big CV wave followed by a steep Y descent. So tricuspid regurgitation has absent X and a steep Y descent. उल्टा है ये वाला, अब याद करो, स्टीप एक्स एंड एब्सेंट वाई, दैट इज गोना बी कार्डियक टैम्पोनार्ड इन अ पेशेंट। सो थोड़ा सा प्रैक्टिस करना है बच्चे। लाइक द फर्स्ट वन कैन बी गोइंग रॉन्ग इन द पेपर, वो जानबूझ के, ये मैंने जानबूझ के डिस्कस किया आपके साथ में आज। दैट इज गोना बी एब्सेंट एक्स एंड स्टीप वाई डिसेंट। यहाँ पे याद रखना स्टीप एक्स और एब्सेंट वाई, लिख के प्रैक्टिस करना है इसको। स्टीप एक्स एंड एब्सेंट वाई दैट इज गोना बी टैम्पोनार्ड, फिर उसको रिवर्स कर दो, दैट इज गोना बी ट्राइकुस्पिड regurgitation. And then is steep x and steep y, that would be constrictive pericarditis. जितने लोगों का तीनों सही हुआ प्लीज कमेंट इन द चैट बॉक्स, यस यस लिखो फटाफट से। आई एम वेटिंग फॉर योर कमेंट्स इन द चैट बॉक्स। जिनके तीनों सही हुए हैं प्लीज कमेंट इन द चैट बॉक्स, यस, जस्ट वेटिंग। और अगर नहीं हुआ है तो फिर आपको प्रैक्टिस करनी है, लिख के प्रैक्टिस करनी है इसकी। ऑल थ्री ऑफ देम, यस गाइस। ओके, नॉट अ प्रॉब्लम, नॉट अ प्रॉब्लम। इफ यू गॉट इट करेक्ट, एब्सोल्युटली फाइन। अगर गलती होगी है तो लिख के प्रैक्टिस करो, छोटा सा तो है यार, बस ये तो पॉइंट ही तो याद करना है। स्टीप एक्स और एब्सेंट वाई, और रैपिड वेंट्रिकुलर फिलिंग नहीं होती है तो एब्सेंट वेंट्रिकुलर फिलिंग होगी तो इसलिए एब्सेंट वाई हो गया। एक में एक्सेलरेटेड वेंट्रिकुलर फिलिंग होती है इसलिए स्टीप वाई डिसेंट हो जाता है। और टीयर का तो मैंने डायग्राम मेन में बताया हुआ है, सो जस्ट हैव टू रिवाइज इट, बट देन यू हैव टू गेट दिस। ओके, नॉट अ प्रॉब्लम। अगर नहीं भी हुआ तो नॉट एन इशू। चलो नेक्स्ट करते हैं। कैनॉन ए वेव्स दैट वुड बी सीन इन पेशेंट्स ऑफ कंप्लीट हार्ट ब्लॉक, वेरी गुड। कैनॉन ए वेव्स को हम फ्रॉग साइन भी बोलते हैं, एंड द फ्रॉग साइन वुड बी सीन इन अ पेशेंट ऑफ कंप्लीट हार्ट ब्लॉक। और कंप्लीट हार्ट ब्लॉक के साथ में दूसरा जो याद करना है आपको, वेयर यू वुड बी हैविंग कैनॉन ए वेव्स प्रेजेंट, वुड बी वीटी, दैट इज वेंट्रिकुलर टैकिकार्डिया। उसके बाद लार्ज ए वेव्स हैं तो दे वुड बी सीन इन स्टेनोटिक लीजन्स ऑफ द राइट साइड ऑफ द हार्ट। तो स्टेनोटिक का एग्जांपल हो जाएगा ट्राइकस्पिड स्टेनोसिस एंड पल्मोनिक स्टेनोसिस। एंड देन इसको स्मॉल साइन, सो को स्मॉल साइन तो आसान ही है, वो तो सी डबल आर से आप जानते ही हो, कॉफ्स रिस्ट्रिक्ट राइट हार्ट का निमोनिक है। सो अल्फाबेट सी वुड बी फॉर कॉन्स्ट्रिक्टिव पेरिकार्डिटिस, अल्फाबेट आर वुड बी फॉर, आप लोग कमेंट करो, यस गाइस, हिट द कमेंट बटन, व्हाई वुड alphabet R be present here? Meanwhile, I'm going to write the third R before you, that is right-sided congestive heart failure, because the compliance of the heart is reduced. No, that is the reason that the JVP would be elevated in this patient. Alphabet R would be for a cardiomyopathy that we discussed. That's the rarest one. So I hope you were able to figure this out, that three conditions where we get a small sign is going to be constrictive pericarditis, restrictive cardiomyopathy, and right-sided heart failure. And this was a all except MCQ. So we are going to get it in this, but we are not going to get it in cardiac tamponade. Reason why we don't get small sign in cardiac tamponade is because in cardiac tamponade the JVP becomes non-pulsatile. तो अगर pulsation ही नहीं होगा तो rise पता ही नहीं चलेगा ना। In cardiac tamponade, why we do not get is small sign is because there is gonna be a non-pulsatile elevated JVP. So I think these are like standard datas which you just have to practice with respect to the JVPs. And now we will focus on must know ECG findings. Yes, guys, I'm waiting for you to comment here. J wave or Osborne wave would be seen with बस फटाफट फटाफट कमेंट करते जाओ. When would you be having a presence of J wave or a Osborn wave? I'm gonna draw it before you as well. Prolonged PR interval. This is Q. This is the wave that I've shown before, and the heart rate of the patient has also become slow. So what you're noticing is a wave in the downswing of the R, and this is okay, great. So J wave is encountered in hypothermia, and the core temperature of the patient would be less than 35 degrees Celsius. You're all aware of the fact that the ideal site for checking the core temperature would be the lower esophagus. However, if a lower esophagus is not given, then our answer would be given as rectum. The preferred site is lower esophagus. If not given, it would be answered as rectum for the core temperature. Next is delta wave. So I'm going to sketch the delta wave before you. You can notice that this time the appearance is different in the upswing of the R wave, and delta wave is what we will be seeing in Wolff-Parkinson-White syndrome. Then is ST segment changes. ST segment changes के लिए there are only four conditions. It's a big mnemonic in the main section, but what I've done is focused on the core aspects here. First is ECG finding of hyperkalemia can be ST elevation. How to remember it? कि there is gonna be potassium में arrow ऊपर जा रहा है तो ST elevation हो जाएगा. Obviously initially we will be having tall tentative wave. There is myocardial infarction भाई भगवान के पास जा रहा है तो वहां पे तो वैसे ही ST elevation जो है वो पर्सन में प्रेजेंट हो सकती है. सो आई जस्ट ड्रॉन द एस्टी एलिवेशन दैट यू कैन गेट इन मायोकार्डियल इंफार्क्शन. That is person is going to God. Those are like the kinds of ST elevation that can be seen. Then is acute pericarditis, and then is gonna be only angina having ST elevations. Only angina having ST elevation is prinzmetal angina. That is why it is called as variant angina. So these are like four must-know causes for your FMG exam for ST segment elevation, and these would be compared with ST depression. ST depression would be seen in all other varieties of angina. As you can see in this representation, what I've shown is the ST depression component. That would be unstable angina and chronic stable angina. All anginas have ST depression. Mnemonic is damn hot. If you want to remember it, D is for digoxin, not for toxicity. Not for toxicity. Digoxin toxicity से तो ventricular Benjamin होता है ना बच्चे. But it is digoxin, then is gonna be angina, then is gonna be myocardial infarction of which variety? Non-ST elevation MI. तो MI दोनों में आएगा. ST may be or non-ST elevation myocardial infarction may be, and then is hypokalemia where arrows going down. So I think that if you just practice the superior वाला data ना, if you get causes of ST elevation right, तो just English से उल्टा कर दो ना, hyper का hypokalemia कर दो, ST elevation MI का non-ST elevation MI हो जाएगा, prinzmetal angina की जगह पे unstable और chronic stable angina हो जाएगा. तो simple man, I mean there is no stress with respect to ST elevation or ST depression in the ECG. Okay जी. नेक्स्ट इज टी वेव की abnormalities. तो यहाँ पे दो आती हैं. एक का नाम होता है टॉल टेंटेटिव वेव जो कुछ लोग कमेंट कर रहे थे, एंड द सेकेंड वन इज गोना बी हाइपर एक्यूट टी वेव. आप कमेंट बॉक्स में मेंशन करो कि हाइपर एक्यूट टी वेव कहाँ मिलेगा. जैसे टॉल टेंटेटिव टी वेव जो होता है वो तो हाइपरकलीमिया में मिलता है. हाइपर एक्यूट टी वेव्स कहाँ पे मिलेगा? योर आंसर वुड बी गिवन एज मायोकार्डियल इन्फार्क्शन. एंड देन यू कैन ऑल्सो बी हैविंग इज अ टी वेव इन्वर्जन. तो टी वेव इन्वर्जन कहाँ पे होगा? तो उल्टा कर देना हाइपोकलीमिया के साथ में. जैसे टॉल टेंटेड टी वेव इज गोना बी हाइपरकलीमिया, द रिवर्स ऑफ दैट वुड बी टी वेव इन्वर्जन फॉर हाइपोकलीमिया. Then he has asked what is the management for dangerous hyperkalemia, and the drug of choice for this would be answered as calcium gluconate. But calcium gluconate will not help in lowering of potassium. So if he says what is the next step to be done in a patient, then answer is insulin drip in 25 to 50% dextrose. Dextrose देने से फायदा क्या होगा कि dextrose will sugar will go inside the body, so it will force the pancreas of the person to produce endogenous insulin, and that endogenous insulin भी तो मदद करेगा उसकी. भाई जो डेक्सट्रोज है वो उसकी एंडोजेनस इंसुलिन भी रिलीज करेगा. और इंसुलिन क्या करता है? इट विल कॉज रीडिस्ट्रीब्यूशन ऑफ पोटेशियम. इट सेंड्स पोटेशियम इनसाइड द सेल्स. फिर वो पूछ सकता है कि भाई कितना फॉल करवाएगा जब आप पोटेशियम जब इंसुलिन ड्रिप दे रहे हो, रेगुलर इंसुलिन दे रहे हो, तो कितना फॉल करवाएगा? तो आपका आंसर होगा 0.1 से 1 मिलीक्विलेंट पर आवर का जो फॉल है दैट वुड बी सीन विद insulin drip. And the type of insulin that would be used here is regular insulin. It can be given intravenously and is much more convenient to give. Then is furosemide. तो furosemide तो कैलियूरिया करेगा. It will be causing urinary loss. and then we do salbutamol nebulization also. So salbutamol again क्या करेगा कि it will send potassium inside the cells. So 2 and 4, point number 2 and 4 कैसे असर करते हैं? Both point number 2 and 4 they cause a redistribution of potassium, whereas when it comes to point number 3 it will cause a urinary loss of potassium. And if person is having refractory hyperkalemia in spite of medication, then what we will do, so your answer would be done answered as hemodialysis would be done in those circumstances where the drug strategy is not working. You can see that here I did not speak regarding especially I would say the resins that we use or novel potassium binding agents. So what you can guys can help me is you can tell me about those newer drugs which are available, which can bind to potassium in the intestine, जो कि chronic hyperkalemia में भी help करेंगे और acute में भी दे सकते हैं, but then they'll take some time to act. So waiting for your guys here, guys, like novel potassium binders, मतलब intestine से potassium की binding कर रहे हैं. So I'm waiting for your answers. Tell me those drugs which are gonna help in absorption or which will inhibit the absorption of potassium from the intestine. And there are three of them that you need to remember. One is sodium polystyrene sulfonate, then is patiromer. So that is a good answer. Very good, very good. Tosif, Dr. Patel, Priyanka, yes, and sodium zirconate also that Priyanka mentioned. So cool, guys. I mean, you are on the spot for answering this, but obviously, as you can understand, they will not have an immediate action. They'll take some time to act, and that is why calcium gluconate is the initial treatment, followed by insulin, because insulin will cause a substantial fall in the value potassium to the magnitude of up to 1 milliequivalent per hour. So we are sorted for those common ECG findings, and because they love to ask regarding the electrolyte imbalance of hyperkalemia, I covered it because it is associated with cardiology because the ECG finding of tau-tented T wave and ST elevation was discussed. Okay, guys. So the next topic that we'll quickly revise is infective endocarditis. Yes, calioxate is a good answer. Let me know the organism responsible for infective endocarditis, whereas we will talk about those modified Duke's criteria for infective endocarditis, including the 2023 update. Also, I'll discuss just in case they plan to ask this, which is the bacteria responsible for native valve endocarditis. What you mean by endocarditis is there is going to be like vegetations on the heart surface, and these vegetations will then embolize into systemic circulation. So yes, guys, waiting for your answers here. What is the leading cause for development of native valve endocarditis? Great. For community acquired, the answer would be given as streptococcus. And in case he says hospital acquired, then your answer would be given as Staphylococcus aureus. So very good answers there, cool. And when he says SABE, that is subacute bacterial endocarditis, then your answer would be given as Streptococcus viridans. In case you are forgetting, that is pretty natural to forget, but then you just need to be persistent and keep on listening to all these kind of discussions. No, there is so much of data on YouTube that actually person does not need to do anything. No, it is just listen to the information there. For SABE, it is Streptococcus viridans. Then is IV drug user when there is right-sided endocarditis. The organism in this case would be answered as Staphylococcus aureus, not as epidermis. Let me know the organism for prosthetic valve endocarditis. Like this patient, he was a case of rheumatic heart disease with severe calcified mitral stenosis. So because it is calcified MS, I told this person that we cannot do a balloon valvotomy. You know that for severe mitral stenosis हम balloon dilation करते हैं. तो मैंने पेशेंट को बोला कि भाई नहीं हो सकता आप, क्योंकि calcification हो गई है तो हमें आप में artificial heart valve लगाना पड़ेगा, prosthetic heart valve. For early onset, very good in the first 2 months. 2 to 12 months. This is again a repeat question of your exam, no? That they've asked what is the organism responsible for prosthetic valve endocarditis in the first 2 months, 2 to 12 months, and then more than 12 months. Then in the first 2 months, your answer would be given as cons, that is Coagulus negative Staphylococcus, that is Staphylococcus epidermis. And for organism after 12 months, your answer would be given as Streptococcus viridans. So that is again a quick revision for prosthetic valve endocarditis. अगला बताओ CIED क्या होता है? CID की फुल फॉर्म बोलो. What is the full form of CIED? Infective endocarditis. Cardiac implantable. Yes. एपिडर्मिस बच्चे नहीं बोलना ना, बिकॉज एपिडर्मिस तो आता ही नहीं है ना, वो तो कॉन्स बोलता है ना एमसीक्यूज में. डजंट से एपिडर्मिस, इट सेज कोएगुलेस नेगेटिव स्टेफाइलोकोकस. देन इज कार्डियक इम्प्लांटेबल इलेक्ट्रॉनिक डिवाइसेस. जो सीआईईडी होता है उसको बोलते हैं कार्डियक इम्प्लांटेबल इलेक्ट्रॉनिक डिवाइसेस. और इस कार्डियक इम्प्लांटेबल इलेक्ट्रॉनिक डिवाइसेस में जो पेसमेकर की वायर है उससे इंफेक्शन आ गया, एंड द ऑर्गेनिज्म रिस्पॉन्सिबल फॉर दिस वुड बी अगेन स्टेफाइलोकोकस ऑरियस। सो स्टैफ ऑरियस कहाँ कहाँ पे आंसर है उसको देख लेते हैं। स्टैफ ऑरियस इज आंसर फॉर आईवी ड्रग यूजर, इट इज फॉर कार्डियक इम्प्लांटेबल इलेक्ट्रॉनिक डिवाइसेस, it is answer for hospital acquired native valve endocarditis। and then he will also ask you कि native valve में कौन सा वाला valve usually involved होता है। तो native valve में जो valve usually involved होता है that is gonna be mitral valve is one in fact जो commonest lesion है native valve endocarditis में which is liable to get infected, वो चार अगर वैल्वुलर रीजन देता है एम एस एम आर ए एस ए आर, तो आपने मेनली याद करना है इट इज माइट्रल रीगर्जिटेशन विच इज मोर लाइबल टू गेट इन्फेक्टेड, क्योंकि दिस इज लाइक प्रेशर, हार्ट हार्ट में हाई प्रेशर की वजह से, हाई प्रेशर ग्रेडियंट की वजह से हायर चांसेस ऑफ गेटिंग इन्वॉल्व इज देयर। देन आर द क्राइटेरिया, जो डायग्नोस्टिक क्राइटेरिया होते हैं उसने पूछे हुए हैं। तो जो मेजर डायग्नोस्टिक क्राइटेरिया होते हैं वो तो रिलेटिवली इजी है कि द मेजर क्राइटेरिया वुड ऑब्वियसली भी ब्लड कल्चर एंड इकोकार्डियोग्राफी, तो उसमें तो कोई दिक्कत ही नहीं होती है। इट इज मेनली द माइनर डायग्नोस्टिक क्राइटेरिया दैट आर ऑल्सो टू बी रिमेंबर्ड। ब्लड कल्चर के लिए आपने याद करना है 3-2-1। 3-2-1 का मतलब होता है दैट इट इज 3 सेट्स ऑफ 2 बॉटल्स ईच। डू रिमेंबर इट इज एक एरोबिक बॉटल हो जाएगी, एक एनारोबिक बॉटल हो जाएगी। सो इट इज 3 सेट्स ऑफ 2 बॉटल्स ईच एंड दे आर टेकन एट अ गैप ऑफ लाइक वन, दे आर इट इज टेकन एट अ इंटरवल ऑफ 1 1 hour gap। Yes. It is 3-1 as a mnemonic to be remembered. 3 sets of 2 bottles each at an interval of approximately 1 hour. That is what you need to remember. और यहाँ पे हम different वेने पंक्चर साइट्स को यूज करते हैं। तो अगर तो वो क्वेश्चन में स्टैंडर्ड बोल रहा है कि भाई व्हाट इज द रूटीन सेट्स टू बी टेकन, देन आंसर वुड बी गिवन एज 3 sets of 2 bottles each at 1 1 hour gap। बट अगर वो आपसे स्पेसिफिकली मेंशन करते हैं, इसको सुन लेना ध्यान से, इफ ही स्पेसिफाइज द वर्ड 2023 अपडेट ऑफ इन्फेक्टिव एंडोकार्डाइटिस या 2023 update or Duke's criteria, and he says that how many sets would be taken for typical organisms। typical organism हो गया जैसे कि Staph aureus हो गया, Streptococcus viridans हो गया, then your answer would be 2 sets or 2 bottles each। remember my words there, 2 sets of 2 bottles each। और यहाँ पे you don't need to do separate venipuncture, it is in a single sitting, एक ही बारी में हम सारा ब्लड ड्रॉ कर लेंगे। सो लास्ट टाइम व्हाट वी वर डूइंग इज एक एक घंटे के गैप पे डिफरेंट वेनिपंक्चर साइट से सैंपल ले रहे थे। अब वो बोलता है कि बार बार लेने की जरूरत नहीं है, एक ही जगह पे एक ही बारी पे सैंपल ड्रॉ कर लो बाय चेंजिंग द ट्यूब। सो इट इज लाइक फॉर टिपिकल ऑर्गेनिजम्स इट इज 2 sets or 2 bottles, that is common organisms like Staph aureus and Staph epidermis। Once you get that right, blood culture then is echocardiography। for echo there would be presence of agitations, वो आप सबको पता ही है। तो माइनर क्राइटेरिया बोल देते हैं। माइनर क्राइटेरिया क्या क्या होते हैं, तो एक तो फीवर है, फीवर के बाद में नेक्स्ट चीज ये एक क्लिनिकल बेस्ड क्वेश्चन था, उसने बोला आईवी ड्रग यूजर है और उसको फीवर है, तो 2 पॉइंट्स हो गए। भाई फीवर जो है वो खुद में ही 101, उसने फीवर की वैल्यू लिखी हुई थी लाइक मोर देन 101 डिग्री फ़ारेनहाइट, और साथ में लिखा था आईवी ड्रग यूजर। सो देयर हैज टू बी सम प्री डिस्पोजिशन प्रेजेंट इन अ पेशेंट, देयर हैज टू बी प्रेजेंस ऑफ फीवर। और उसके बाद में देन देयर कैन बी एम्बोलिक मैनिफेस्टेशंस, there could be immunological manifestations in a patient। The embolic manifestations that can be given in a question can be like Janeway lesions, which are in like in the palms of the patient, or there can be like immunological features। The immunological phenomenon that would be seen in this patient can be ROG, that is R से होता है रॉथ स्पॉट, O से होता है ऑस्लर नोड्स, और G से हो जाता है ग्लोमेरुलोनेफ्राइटिस। मोस्टली द फाइंडिंग्स वुड बी सीन इन द हैंड्स ऑफ द पेशेंट। एंड द फिफ्थ क्राइटेरिया वुड बी ब्लड कल्चर विच इज नॉट मीटिंग द माइनर क्राइटेरिया। इसको ध्यान से सुन लेना, ब्लड कल्चर विच इज नॉट मीटिंग द मेजर क्राइटेरिया, जो मैंने ऊपर क्राइटेरिया लिखे हैं, जैसे एक ही ट्यूब पॉजिटिव आ रही है, ओनली वन सेट इज टर्निंग आउट टू बी पॉजिटिव, सो देन वी विल टेक इट एज अ माइनर क्राइटेरिया। डायग्नोसिस के लिए कितने चाहिए होते हैं, तो बोलना 2 मेजर क्राइटेरिया की रिक्वायरमेंट होती है। अब मेरी हेल्प करना, क्विक कमेंट्स बोलना, 1 मेजर के साथ में कितने माइनर चाहिए होते हैं, फॉर 1 मेजर हाउ मेनी माइनर वुड बी रिक्वायर्ड। वेटिंग, यस गाइस, इट इज 1 मेजर विद हाउ मेनी। Yeah, new onset murmur is a good point. We can use it for diagnosis of the patient, but most of the time we'll ask you about blood culture and echo only, बच्चे. So 1 मेजर के साथ में how many minor would be required? Yes, it is 1 मेजर with 3 minor criteria that is required for endocarditis. And the third possibility is that only 5 minor criteria would be required. So that would be an algorithm that is to be remembered for this. And good, I think I got very good inputs with respect to how many Duke's criteria should be present for diagnosis of this condition. Cool, very good. Let's now move on to the subsequent part, guys, where we are getting a quick look at the ECG spot diagnosis. This is showing tachycardia because the RR interval in the patient is substantially reduced. So there is a tachycardia present. And then you can see that this is the R wave, this is the S wave. It's a broad RS complex. So yes, I think most guys waiting for answers, it would be monomorphic ventricular tachycardia. The spot diagnosis of this particular ECG to be remembered is monomorphic. This is one of the common arrhythmias, guys, that can be given to you because ventricular fibrillation to कर ही लोगे ना. Ventricular fibrillation is like twitching activity. So ventricular fibrillation को solve करना will never be a challenge for you guys. But VT is one that you have to remember. This is a monomorphic VT, and most of the time patient would be pulseless. So you guys can quickly comment what is the treatment for pulseless ventricular tachycardia. Very good. Like they're gonna give you this and ask you what is the drug of choice for what is the treatment of choice for pulseless ventricular tachycardia, and your answer would be yes, yes, yes. No, guys, for pulseless VT you will not give amiodarone. No, if it is pulseless ventricular tachycardia, there is no role of amiodarone immediately. What you will do for pulseless VT is that you will be straight away going ahead with defibrillation. Uh, Treatment of choice for pulseless ventricular tachycardia is defibrillation. You will straight away defibrillate the patient. Yeah, when the case will come, what I need to do is initially, obviously, I'll do CPR in a patient, but the main treatment of the patient is what I said was, what is the treatment of this patient? Then the treatment would be given as defibrillation. That's the main treatment for PVT, that is pulseless ventricular tachycardia. Do not answer cardioversion, bache. It is defibrillation that would be done. And after defibrillation, he will then ask you, what will you be doing? Then your answer would be, I will be giving CPR to this patient at ratio 30:2. So usually what he is asked is that PVT patient was already defibrillated in the hospital. And what is the next step to be done? Answer is CPR for at 30:2. And this would be one cycle of standard 2 minutes, as you very well are aware of. Along with this, you will secure a IV line or will secure a intraosseous access as well. And in case you're finding that the patient is not improving, what you will do is you will give a next defibrillation. So there's a second defibrillation which is being given, and then you will say, what is the next best step for this person? Then your answer would be again CPR. The ratio would be 30:2, but this time that IV line that you had put, you would be using that IV line to give you will be using that IV line to give epinephrine to the patient or adrenaline. तो इसको याद कर लेना कि जो 3 बॉक्स में बनाऊंगा, उन 3 बॉक्स में से जो पहला वाला बॉक्स है उसमें आपको याद करना है आईवी एक्सेस. अगली बार उस एक्सेस से आपने एड्रेनलिन देना. द डोज ऑफ एड्रेनलिन वुड बी 1 मिलीग्राम. इट वुड बी डाइल्यूटेड टू 1:10,000. दैट इज लाइक वायल से जो लेंगे दैट वुड बी डाइल्यूटेड विद नॉर्मल सलाइन एंड देन वुड बी एडमिनिस्टर्ड टू द पेशेंट. एंड उसके साथ साथ में यू विल ऑल्सो इंट्यूबेट दिस गाय. What you will also do is that you now need to provide oxygen better to the heart. So intubation is to be done. That would be called as advanced airway. And in case there is no improvement, so what you will do next is that you will again defibrillate the patient. And defibrillation, this is the last shot that you are doing in the patient. That is, you are defibrillating for the third time. That's the last defibrillation that you're gonna do. And इसके बाद में हम फिर से CPR देंगे. And then the drug that would be used is amiodarone. गाइस, एडवांस कार्डियक लाइफ सपोर्ट का जो सबसे कॉमन वाला फ्लो चार्ट है उसको मैं यहाँ पे हाईलाइट कर रहा हूँ. सबसे पहले आपको क्लैरिटी रखनी है कि टोटल मिला के 3 DC शॉक हम दे रहे हैं. द पेशेंट इज नॉट इम्प्रूविंग, तो अगला स्टेप हर बार CPR CPR है. लेकिन एक बार ही हमने IV एक्सेस लिया, फिर उसके बाद में हमने IV एक्सेस से एड्रेनलिन दिया, इंट्यूबेट किया, और थर्ड बॉक्स में हमने उसको एमिड्रॉन दिया. एमिड्रॉन की लोडिंग डोज वुड बी गिवन टू द पेशेंट. These are the sequence for management of pulseless ventricular tachycardia, which has been frequently asked in the exam. So very good, guys. There is no rule of soda bicarbonate here. And amidron that would be given to the patient is 300 milligram. I don't think so that he'll get into the dose, but yeah, that was a good answer there. Now my question to you guys is, and I would like you to answer this here. DC shock that is given is not 360 joules. The DC shock that is given nowadays is only 200 joules biphasic, na? अभी जो डिफिब्रिलेशन होता है वो 360 जूल्स का नहीं होता ना. वो मोनोफेजिक वाले तो पुराने मॉडल होते हैं ना. अभी तो हम 200 जूल्स बाईफेजिक यूज करते हैं. जो मोनोफेजिक शॉक होता है दैट इज ऑलवेज 360, एंड द बाईफेजिक शॉक वुड ऑलवेज बी लाइक 200 जूल्स बाईफेजिक. एंड या वी कैन यूज लिग्नोकिन बच्चे, बट देन मोस्टली इट वुड बी एमिड्रॉन दैट वुड बी फर्स्ट प्रायोरिटी दैट विल बी आंसरिंग. एंड वंस वी गेट दिस डेटा राइट, क्वेश्चन फॉर यू गाइज इज कि जब इंट्यूबेट कर देंगे तो व्हाट विल बी द नंबर ऑफ ब्रेथ्स दैट यू विल गिव इन 1 minute. Options are like 6 breaths per minute, 8 breaths per minute, 10 breaths per minute. Select one. How many breaths per minute would be given to the patient? How many number of breaths would be given to the patient per minute once the person has been intubated, once we have taken what is called as advanced airway? Yes guys, waiting for your answers. advanced airway में 1 मिनट में कितनी बार सांस देनी होती है? Very good. The number of breaths that we'll be giving to the patient will be one breath in every 1 second, one breath in every 6 सेकेंड. तो अगर 6 सेकंड में एक ब्रेथ देनी होगी, तो अगर 6 सेकंड में एक देंगे तो 6 × 10 करो, तो बेसिकली 10 ब्रेथ हो गई ना. वन ब्रेथ. द करेक्ट आंसर इज 10 breaths per minute. द बेसिक पॉइंट इज वन every 6 seconds. It is one every 6 seconds that would be given to the patient. आप में से जो लोग आंसर कर रहे हैं 8, दैट 8 विल बी फॉर अगर मैंने इंट्यूबेट नहीं किया होता ना, जो मैं 30:2 वाली जो रेशो है ना, ये 30:2 वाली रेशो को अगर वो पूछता है कि भाई आप बैग एंड मास्क दे रहे हो या माउथ टू माउथ रेससिटेशन दे रहे हो, वहां पे 8 पर मिनट होता है. वो 8 पर मिनट कैसे है कि दिस 30:2. अब इसको ध्यान से सुनना. फॉर दोज ऑफ यू कुड नॉट फिगर इट आउट, ये जो 30:2 है ना, इसको 15 सेकंड में कवर करना होता है. 1 सेकंड में 2 चेस्ट कंप्रेशन देनी होती है, तो 15 सेकंड में बेसिकली आपको 30 चेस्ट कंप्रेशन देनी है. तो अगर आप इसको ऐड करते हो, इसको अगर मैं 60 सेकंड करता हूँ यहाँ पे, राइट, तो जो नंबर ऑफ ब्रेथ्स होंगी 4 गुना वो इंक्रीज हो जाएंगी ना. और जो सीपीआर की जो कंप्रेशन है वो 120 हो जाएंगी. मैंने 15 × 4 किया 60, 2 × 4 किया 30 × 4 किया. सो बेसिकली फॉर लाइक इफ इज सेइंग 30:2 पे कितनी ब्रेथ्स है, देन इट इज 8 पर मिनट. बट इफ ही स्पेसिफिकली सेज विद इंट्यूबेशन एडवांस्ड एयरवे जब सिक्योर हो गया है, उसके बाद में कितनी ब्रेथ देनी होती है, तो आपने याद करना है वन ब्रेथ एवरी 6 सेकेंड. सो दैट इज वन एमसीक्यू टू बी रिमेंबर्ड, अ इंपॉर्टेंट वन. अब कमेंट करना चैट बॉक्स में, व्हाट इज द साइट ऑफ इंट्रोशियस एक्सेस, क्विकली. इंट्रोशियस एक्सेस कहाँ पे लेंगे, कौन से बोन में लेंगे? वेरी गुड, 10 was the answer. Intraosseous access would be, yes, without intubation would be 8. Yes guys. जो इंट्रोऑशियस एक्सेस होता है वो कहाँ पे लेंगे, तो इट इज जस्ट बिलो द टिबियल ट्यूबरोसिटी. सो इट इज लाइक द लोअर एक्सट्रीमिटीज दैट वुड बी यूज्ड. और टिबियल ट्यूबरोसिटी मत बोलना, इट इज बिलो द टिबियल ट्यूबरोसिटी वेयर वी विल बी यूजिंग अ इंट्रोऑशियस एक्सेस इन द पेशेंट. यस बच्चे, बिलो नी वुड नॉट बी करेक्ट आंसर. टिबिया वर्ड विल नॉट बी करेक्ट. स्पेसिफिक आंसर बोलना है ना, वो ऑप्शन ही ऐसे देगा. अपर पार्ट ऑफ टिबिया, बिलो द टिबियल ट्यूबरोसिटी, लैटरल टू द टिबियल ट्यूबरोसिटी. सो इट इज बिलो एंड लैटरल. It is below and lateral to the tibial tuberosity where we'll be using. The exact site is okay. Non-specific answer is upper tibia, but it is basically below and lateral to the tibial tuberosity where the bone is relatively weaker, and that is where the intraosseous excess can be taken. So these are like 3 steps for PVT or ventricular fibrillation, any of the two that would be given. Amidron dose that would be given is 300 milligram, and that would be diluted with 5% dextrose. Great. Next, arrhythmia, spot diagnosis, please. Patient is an alcoholic. Can I have the answer, please? What is the arrhythmia what is the tachyarrhythmia that you are seeing in this case, in the second ECG, which you can see on the monitor or on the display? Okay, yes, guys, you can see that यहाँ पे irregular RR interval है ना, because this is a irregular RR interval in a patient and there is absence of P waves. So because of the combination of two things, that the P waves are absent and RR in this person is turning out to be irregular. So आप इसको बोलोगे that the person is having atrial fibrillation. Very good. And then he will ask you like in atrial fibrillation, what is the drug for rate control and rhythm control? आप लोग comment कर दो quickly chat box में, what is the drug for rate and rhythm control in this patient? फिर अगले पे चलेंगे. रेट कंट्रोल, द आंसर वुड बी गिवन एज एस्मोलॉल. इफ ही सेज एस्थमेटिक तो फिर आप चेंज करके सीसीबी कर देना. इफ ही सेज रिदम कंट्रोल इन अ पेशेंट, देन आंसर वुड बी गिवन एज एमेड्रोन. Along with this, oral anticoagulation needs to be done in all of these patients because atrial fibrillation patients can end up with possibility of stroke. So the drugs that are used for oral anticoagulation can be like warfarin, or it can be molecules like apixaban. So that's the main treatment in atrial fibrillation. That would be rate control, rhythm control, and oral anticoagulation so that we can prevent the chances of stroke. Very good. I'm having good answers there. Let's move on to the next one. In this question, what you can notice is a very characteristic ST segment elevation which has been asked in your exam. This ST elevation is present mainly lead number 2, lead number 3, and lead number AVF. So that's again a very cliche question of your exam. That would be inferior wall myocardial infarction. Standard diagnosis. मैं सारी ECG तो करने के लिए बोल ही नहीं रहा यार, मैं बोल रहा हूँ जो मेन है ना उनको एटलीस्ट फंडा क्लियर कर लो. This is gonna be answered as like inferior wall myocardial infarction, and this would be right coronary artery occlusion, because if the changes would be seen in the lateral leads, that is from V2 to V4, then it will become anterior wall myocardial infarction. चलो फटाफट मायोकार्डियल इंफाक्शन के लिए ट्रीटमेंट बोल दो. एसटी एलिवेशन एमआई के लिए क्या क्या दवाइयां देते हैं? व्हाट आर द ड्रग्स विच आर यूज्ड फॉर ट्रीटमेंट ऑफ एसटी एलिवेशन मायोकार्डियल इंफाक्शन? क्विक रिवीजन हेयर. बी से क्या करेंगे? बीटा ब्लॉकर्स यूज करते हैं. इफ ही जस्ट सेज ड्रग्स यूज, सो ये आंसर इज बीटा ब्लॉकर, क्योंकि हार्ट रेट कंट्रोल करेगा. अल्फाबेट ई विल बी फॉर इनॉक्सापैरिन. अल्फाबेट एस इज फॉर statins. T would be for thrombolysis. Like if I'm working in a place जहाँ पे फैसिलिटी नहीं है तो वहाँ thrombolysis कर देंगे. Then is obviously morphine, oxygen, aspirin, and nitrates. Those are like the treatment strategy that we'll be using for those cases who are having ST elevation MI. The mnemonic for this would be best known. थ्रोम्बोलाइसिस के लिए जो गाइडलाइंस हैं उसमें डोर टू नीडल टाइम को विद इन 30 मिनट्स रखना होता है. और अगर वो बोलता है कि पर्सन में विंडो पीरियड कितना है थ्रोम्बोलाइसिस का, तो कमेंट करना चैट बॉक्स में व्हाट इज द विंडो पीरियड फॉर थ्रोम्बोलाइसिस. ऑप्शंस आर 3 आवर्स, 6 आवर्स, 9 आवर्स, 12 आवर्स. क्विकली गाइस, 3, 6, 9, 12. यस, मैं अभी सिर्फ एसटी एलिवेशन एमआई का ट्रीटमेंट पूछ रहा हूँ. नॉट टॉकिंग अबाउट इंफीरियर वॉल एमआई, आई एम टॉकिंग ओनली अबाउट एसटी एलिवेशन एमआई. यस गाइस. Yes, the window period for this would be answered by you as 12 hours. Very good. The window period for this would be answered as thrombolysis का जो window period है वो 12 hours है. And no guys, it is not 4.5 hours. 4.5 hours is thrombolysis का. We'll discuss that in stroke. अभी neurolo वाला component आ रहा है. So this is basically 12 hours for window period for myocardial infarction. So it is like beta blockers, enoxaparin, statin, thrombolysis, morphine, oxygen, aspirin, nitrates that would be used for this patient. Answer is not 6 hours guys. The answer is 12 आवर्स. वो स्ट्रोक का है बच्चे. 4.5 और जो 6 है ना, अभी स्ट्रोक की बात आएगी. अभी मैं बात कर रहा हूँ एस्टी एलिवेशन एमआई का. बाकी एस्टी एलिवेशन एमआई का जो ट्रीटमेंट और चॉइस होता है, ट्रीटमेंट और जो चॉइस होता है दैट वुड बी गिवन एज प्राइमरी परक्यूटेनियस कॉर्नरी इंटरवेंशन. प्राइमरी परक्यूटेनियस कॉर्नरी इंटरवेंशन. और फिर उसने एक पूछा हुआ है कि अगर दवाई फेलियर हो गया, अगर दवाई से थ्रोम्बोलाइसिस मतलब ये क्लॉट जो है खुल नहीं रहा है, तो फेलियर और थ्रोम्बोलाइसिस में क्या करेंगे? तो फेलियर और थ्रोम्बोलाइसिस में अगर दवाई से नहीं खुलेगा तो हम जो फिर पर्सन में फिर पीसीआई करेंगे. लेकिन उस पीसीआई का नाम क्या होगा? तो उस पीसीआई का नाम फिर प्राइमरी पीसीआई मत बोल के आना, उसको बोलना रेस्क्यू परक्यूटेनियस कॉर्नरी इंटरवेंशन. रिपीट माई स्टेटमेंट. अगर दवाई से नहीं खुलता तो वी विल हैव टू रेफर द पेशेंट टू द कैथ लैब, एंड वहां पे जो प्रोसीजर किया जाएगा उसका नाम रेस्क्यू परक्यूटेनियस कॉर्नरी इंटरवेंशन होता है. तो एक प्राइमरी पीसीआई होता है और एक रेस्क्यू परक्यूटेनियस कॉर्नरी इंटरवेंशन होता है. तो बस वो पॉइंट आपको याद रखना है, प्राइमरी पीसीआई वर्सेस रेस्क्यू परक्यूटेनियस कॉर्नरी इंटरवेंशन. वेरी गुड. Next up, we'll do a quick recap with respect to aspects of neurology. जो मैंने अभी तक 8 स्लाइड में डेटास बताए हैं वो सारे मस्ट नो हैं. एंड नाउ वी विल फोकस ऑन लाइक कॉमन एस्पेक्ट्स ऑफ सेंट्रल नर्वस सिस्टम. अपर मोटर न्यूरॉन, लोअर मोटर बेसल गैंग्लियन, सेरिबेलम. इसका क्विक रिवीजन कर रहे हैं कि क्या क्या मैनिफेस्टेशंस प्रेजेंट होती हैं. तो अपर मोटर न्यूरॉन लीजन के लिए यूएसबी निमोनिक है. अपर मोटर न्यूरॉन लीजन का बेस्ट एग्जांपल है स्ट्रोक. या फिर एक और लिख देता हूं, दैट कुड बी लाइक सेरेब्रल मलेरिया. And in all cases of stroke, in all cases of cerebral malaria, USB as a mnemonic will be used. When I say USB as a mnemonic, मतलब tone यहाँ पे बढ़ जाएगी, and that increase in the tone would be called as spasticity. And alphabet B will be कि जो reflexes होंगे वो तेज हो जाएंगे because inhibitory control चला जाता है, तो brisk reflexes होते हैं. And the special finding that will be coming in this patient would be presence of Babinski sign. मतलब यूएसबी निमोनिक से याद करना है कि अपर मोटर न्यूरॉन लीजन में क्या क्या होगा. तो स्पास्टिसिटी होगी, ब्रिस्क रिफ्लेक्सेस होंगे और बेबिंस्की साइन आ जाएंगे. लोअर मोटर न्यूरॉन लीजन के 2 एग्जांपल याद करने हैं, एक पोलियो और दूसरा एमियोट्रोफिक लैटरल स्क्लेरोसिस. एमियोट्रोफिक लैटरल स्क्लेरोसिस वो जो एक साइंटिस्ट था ना स्टीफन हॉकिंग, उसको था. सो यहाँ पर क्या होगा कि मसल की टोन कम हो जाती है. जब मसल की टोन कम होती है तो उसको बोलते हैं फ्लैसिडिटी, फ्लैसिडिटी. और यहाँ पे एक स्पेशल फाइंडिंग आती है जिसमें मसल्स की ट्विचिंग होती है. को ट्विचिंग मैसेज में, जैसे यार कई बार आंख में नहीं होता, आंख फड़क रहा होता हमारा, राइट, इन दैट बोलते हैं ना आंख फड़क रही है एंड इट्स कंसिडर्ड टू बी बैड। तो वैसे ही मसल्स में ट्विचिंग हो रही है, तो दैट मसल्स की जो ट्विचिंग है दैट वुड बी कॉल्ड एज फैसिकुलेशंस। तो दो एफ्स हो गए, फ्लैसिडिटी एंड फैसिकुलेशन। एंड रिफ्लेक्सेस एब्सेंट हो जाते हैं, दैट इज ए रिफ्लेक्सिया। तो लोअर मोटर अपर मोटर का बेसिक डिफरेंस आपने याद करना है, जो मैंने यूएसपी निमोनिक एंड मतलब फास्ट बता रहा हूँ ताकि आप कोर कोर एस्पेक्ट्स को याद कर पाओगे, भाई अपर मोटर में क्या होना है, लोअर मोटर में क्या होना है, जिसमें स्पाइनल कॉर्ड इंजर हो सकती है। लोअर मोटर का एग्जांपल एक और लिख देता हूँ, गुलियन बारे सिंड्रोम ना। जीबीएस में डीमेलिनेशन होता है, पेरिफेरल नर्व्स इन्वॉल्व होती हैं, सो दैट वुड आल्सो बी लोअर मोटर इन्वॉल्वमेंट। देन वुड बी पार्किंसन डिजीज फॉर बेसल गैंग्लिया इन्वॉल्वमेंट, जिसमें टोन बढ़ जाती है, and that would be called as rigidity। पर रिफ्लेक्सेस नॉर्मल होते हैं, नॉर्मल होते हैं। और स्पेशल फाइंडिंग्स आते हैं, दे आर रेस्टिंग ट्रेमर्स। द ट्रेमर्स दैट यू विल बी encountering in these patients is resting tremors। उसके बाद में there can be bradykinesia। The special finding must have criteria for diagnosis of Parkinson diseases, must have criteria for diagnosis of Parkinson diseases। bradykinesia वो mnemonic होता है ट्रैप से ना, tremors, rigidity, akinesia और bradykinesia। So it would be like bradykinesia as reflexes that would be present। हाँ जी, पिल रोलिंग ट्रमर्स बच्चे, वेरी गुड, एंड इट कैन बी ब्राडिकाइनेसिया। सो ये पॉइंट्स याद करने हैं अलॉन्ग विद पोस्चरल इंस्टेबिलिटी, दैट इज अ स्पेशल फाइंडिंग फॉर पार्किंसन डिजीज। उसके बाद आता है सेरिबेलर डिजीज का मैनिफेस्टेशन। ट्रांसवर्स माइलेटिस में बच्चे दोनों आएंगे। आई थिंक पुनीत व्हाट यू आस्क्ड वाज कि ट्रांसवर्स माइलेटिस में क्या होगा। तो ट्रांसवर्स माइलेटिस में ना लोअर और अपर दोनों के फीचर आते हैं। एट द लेवल ऑफ द लीजन जो होता है दैट इज लोअर मोटर, एंड बिलो द लेवल ऑफ लीजन इट इज अपर मोटर न्यूरॉन की फाइंडिंग्स, मतलब लेग्स में स्पास्टिसिटी आ जाएगी। तो ट्रांसवर्स माइलेटिस में मत जाओ यार, आई मीन दैट विल मेक योर लाइफ मिजरेबल। अभी आप कॉमन आसान वाली जो रूटीन चीजें हैं उन पे आप फोकस करना। यस यस, फेस्टिनेटिंग गेट इज फाउंड इन पार्किंसन डिजीज। फिर अगर सेरिबेलम में डैमेज होगा तो सेरिबेलम का बेस्ट एग्जांपल तो ट्यूमर हो सकता है, एस्ट्रोसाइटोमा। bestest tumors like cerebellar astrocytoma in children। तो यहाँ पे भी टोन लेस हो जाती है। सो वन, यू विल ऑलवेज बी हैविंग हाइपोटोनिया। टोन दो जगह पे कम होती है, लोअर मोटर में भी और सेरिबेलम के डैमेज में भी टोन लेस होती है। तो हम बेसिक फिजियोलॉजी यहाँ पे रिवाइज कर रहे हैं। टोन दो जगह पे बढ़ती है, टोन बढ़ती कहाँ कहाँ पे है, तो टोन विल बी लेस इन द फॉलोइंग। Tone will be less in flaccidity and tone will be less for cerebellar damage, but tone will be increased with respect to spasticity and rigidity। तो एक तो पॉइंट याद करना है भी कहाँ पे टोन बढ़ रही है और कहाँ पे कम हो रही है। एंड देन रिफ्लेक्सेस, दैट्स एन इंपॉर्टेंट क्वेश्चन, वन लाइनर था, पेंडुलर नीजक्स। अब उसके मैं डिस्क्रिप्शन में नहीं जा रहा कि भाई पेंडुलर नीजक कैसे हम उसको, मतलब क्या क्राइटेरिया होंगे उसके। बट देन पेंडुलम के जैसे, क्योंकि टोन कम हो गई तो पेंडुलम जैसे लेग मूव कर रही है, सो वी कॉल इट पेंडुलर नीजक्स। And then the special finding of cerebellar damage would be two. One would be intentional tremors and second would be gait ataxia। मैंने यहाँ पर देखो, अगर आप इसको रैपिड रिवीजन फिजियोलॉजी से पढ़ोगे ना तो इट विल टेक यू मतलब एक दो घंटे। पर मैंने आपको यहाँ पे फास्ट चार बेसिक एस्पेक्ट्स बताए हैं। ये मस्ट नो फैक्ट है गाइस, मतलब अगर इसको ये क्लियर नहीं है ना तो फिर न्यूरो मत हाथ मत लगाना। मतलब बेसिकली लाइक इफ यू से कि सर ये वाले चार पॉइंट अगर अगर याद नहीं होंगे ना तो देन आगे न्यूरोलॉजी वाले कंपोनेंट में जाने का ज्यादा फायदा नहीं होगा। यस, यू विल हैव अ स्कैनिंग स्पीच इंटेंशनल ट्रेमर्स परफेक्टली फाइन, बट देन दीज आर लाइक दोज core वाले aspects which you need to remember for upper motor, lower motor, basal ganglia and then a cerebellar manifestation। Once you get this right, then comes the aspect of dorsal column क्या carry करता है। So dorsal column is responsible for carrying this sensation which is called as proprioception। Proprioception would be joint and position sense। Like you can close your eyes at the movement and you can still feel your ankle joint and knee joint now। So proprioception is carried by which area? Then your answer would be called as dorsal column, and it is responsible for carrying joint and position sense। What you can see in this particular patient is that I am trying to elicit Romberg test। I just ask the patient कि भाई eyes बंद कर ले, and the moment I ask the patient to close his eyes, he's falling to one side because this dorsal column is affected। So what I'm trying to describe before you is technically called as sensory ataxia। You see, whenever cerebellum is damaged, the technical word used is gait ataxia। सेरिबेलम डैमेज होता है तो बोलता है गेट अटैक्सिया, ड्रंकन पर्सन गेट आती है। अभी जो की वर्ड है वो है सेंसरी अटैक्सिया। तो मेनली सवाल में बोलेगा कि सेंसरी एटेक्सिया अगर कभी भी लिखा हो तो मतलब विच पार्ट ऑफ द स्पाइनल कॉर्ड इज डैमेज, तो आपका आंसर होगा डोर्सल कॉलम इज द वन दैट इज अफेक्टेड। एंड द टेस्ट डन फॉर दिस इज कॉल्ड एज रोमबर्ग साइन और रोमबर्ग टेस्ट। दैट पेशेंट इज क्लोजिंग हिज आईज एंड इज टेंडिंग टू फॉल टुवर्ड्स वन साइड। नॉर्मल तो नहीं होता ना, लाइक इफ यू आर गोना बी सिटिंग ऑन अ चेयर, इफ आई से ओके डॉक्टर जस्ट क्लोज योर आईज, वुड यू फॉल? नो। बट इफ योर डोर्सल कॉलम column is damaged because body position is not known, the person will show a tendency to fall. So only that statement is to be remembered. Sensory ataxia is seen due to, that means proprioception is lost. That means the damage is in the dorsal column. And one medical condition where dorsal column is always affected is a subacute combined demyelination of the spinal cord, SACD, that occurs because of vitamin B12 deficiency. So let's do a quick recap for this particular horizontal part of the table. B12 deficiency will cause demyelination of dorsal column, and damage to dorsal column will cause proprioception loss in the patient. Next is lateral spinothalamic pathway. Can I have in the comment box quick answers there? What does lateral spinothalamic pathway carry? Yes. Stereognosis is a feature that is seen as a cortical function. Like you can close your eyes and you can feel the shape of an object. Like if you hold any object, like if I'm holding a pencil in my hand, I can close my eyes and you can feel the pencil. That is a stereognosis. So that is going to be a function related to the parietal lobe of the brain. But at the moment, what we're talking about is position of the body. So that is dorsal column. And yes, lateral spinothalamic pathway carries pain and temperature. And the main thing to be remembered is the MCQ in your exam will always come for Brown-Séquard syndrome. And the highlight is that lateral spinothalamic or ventral spinothalamic pathway क्योंकि crossover करते हैं. So whenever he will teach you or ask you regarding Brown-Séquard syndrome, the main manifestation of Brown-Séquard syndrome would be there would be ipsilateral loss of proprioception. I'm not going into the diagram at the moment. I just want you to remember the key word. The key feature will be कि ब्राउन सिक्वार्ड syndrome में सेम साइड का proprioception जाएगा, but because of the fact that when it is gonna be lateral spinothalamic pathway that would be involved, because it shows a crossing over, so there would be contralateral at least 1 to 2 levels below. It is contralateral 1 to 2 levels below. There would be a loss of pain and temperature in a patient. So that is a simple diagram that I would like to make before you quickly, like wherever there is a hemisection of the spinal cord, on whichever side the injury is there, on that side, the position of the body will not be known. But opposite side of the body, one level, 1 to 2 levels lower, you will be having is only loss of two sensations that you can see is pain and temperature sensation that I've shown. That would be a feature that is seen with Brown-Séquard syndrome. Over and above this, additional features that can be asked is motor manifestation. The motor manifestation would be that in this leg, there will be a development of spasticity also because corticospinal pathway in the spinal cord is also cut. So there are three features in Brown-Séquard syndrome. First is going to be ipsilateral proprioception loss. Second is contralateral pain and temperature loss, that dot dot thing that is showed. And the third feature will be that person will be having same-sided. क्योंकि stroke में कभी भी brain में damage होता है ना यार, whenever you have damage in the brain, it always causes a contralateral spasticity. But whenever in spinal cord transaction is occurring, because crossing over has already occurred, so it would be a ipsilateral spasticity. So most of the time it is ipsilateral contralateral swap that would be occurring. So you need to get three aspects on the same side, joint and position sense, opposite side pain and temperature, and then because the corticospinal pathway is also cut on the same side, you would be having is ipsilateral spasticity. The reason for ipsilateral, I'll say again, is because the crossing over has already occurred over and now the injury is occurring in the spinal cord of the brain. Okay, cool. Wallenberg syndrome, yeah, contralateral pain and temperature, again, same reason, but at that time it would be with respect to the body, right? And face pay, all sensations would be lost. So yes, Puneet, you have a good point and a valid point with respect to Wallenberg syndrome. Okay, moving ahead next, Brown-Séquard is hemisection only. No? It's a lower motor neuron manifestation at the level of the lesion and upper motor at the below that. Yes, it would be spasticity, ipsilateral spasticity. Why? Because you're cutting the spinal cord. No, don't go into spinal cord injury. It is corticospinal. कभी भी इंजोर होता है तो spasticity होना ही होना होता है. Okay, so doctor, the majority of people would be preferring in Hindi section, so that's what we are doing. Otherwise, you have the English version, right? So you can listen from that. Ventral spinothalamic pathway. Yes, guys, quickly comment in the chat box what sensation is carried by ventral spinothalamic pathway. Waiting for your comments, guys. Wallenberg syndrome has multiple cranial palsies. Now, Wallenberg would be having like 5, 7, 8, 9, 10, 11. All cranials would be affected. Only 12th will not be affected. No, so cranial palsies would be given in the patient. Exactly. Ventral spinothalamic pathway में क्या क्या damage होता है? So it would be basically crude touch and pressure. So one, what you need to get right is these basic aspects related to the tracts that what they're asking. There are only 3 points only that you need to remember. One is that B12 deficiency, which is called as subacute combined demyelination of spinal cord, where you have sensory ataxia and Romberg sign is present with eyes closed. The word is eyes closed, not eyes open. Then is Brown-Sequard syndrome, where the ipsilateral contralateral things I explained. And ventral spinothalamic pathway, I mean, just a theory part to be remembered would be a crude touch and pressure that would be affected. That would again be a contralateral effect. Okay. Moving ahead in our discussion, why would you be having chorea in a patient? The area of the brain that is damaged. Quick comments there in the chat box. I would like everybody to comment. Chorea is due to lesion of which area of the brain? You would be having fast involuntary movements in the hand. It would be fast. It would be in the hand, distal involuntary movements. Yes, guys, quick comments in the chat box with respect to why would you be having chorea? Which area of the which basal ganglia is affected in chorea? Very good. The area of the basal ganglia that is affected is the caudate nucleus. Then ethiotosis will be a relatively slow, but this would be a distal involuntary movement, and which basal ganglia would be affected? Then your answer would be given as globus pallidus. On the other hand, hemibellismus is like an upgraded form of chorea, where you would be having presence of wide flinging movements in the arms. In hemibellismus, it is wide flinging movements in the arms and in the legs of the patient. And in hemibellismus, the area of the brain that is affected would be answered by US subthalamic nucleus. So one you need to remember, caudate, globus pallidus, and subthalamic nucleus. Yes, guys, I want you to be faster with your reflexes. What is the root value for the ankle jerk? Very good. Subthalamic is a good answer. Ankle jerk root value to be answered is, okay, maybe my chat rate is a little slower. Ankle jerk root value, guys. Yes, yes, yes. Hung up ankle jerk is a reliable examination finding of hypothyroidism. Yes, your answer would be given as S1 and S2. Yes. But if he says knee jerk root value, then what will you answer, guys? For knee jerk root value, quickly. You're right, Priya. You're right. Okay. Hung up ankle jerk I've solved for you. Two questions here. Pendular knee jerks and hung up ankle jerks is what I mentioned. Myxedema is fine, guys. Okay. Knee jerk root values would be given as L2, L3, L4. And as I've explained to your question that was discussed earlier, that would be called as pendular knee jerk. And every time you read the statement, it means that the damage would be at inhibitory control center that's responsible for balance. That would be cerebellar damage. So two very classical cliche questions, hung up ankle jerk, and then would be pendular knee jerk. Moving ahead, we now have questions on drug of choice, and I think more people can join in the chat here for prevention of febrile seizures. What is the drug of choice for prevention of febrile seizures? And I'll wait this time instead of me writing because that would make it one-sided. Best drug for prevention of febrile seizures. And then is for absence seizures also. So let's do these two questions quickly. Let's check out your reflexes. Okay. Yeah, options are like, would you give oral diazepam or would you give rectal diazepam? Here my question is, would you give rectal diazepam? Options are rectal diazepam, oral diazepam, select one. If it is oral diazepam, then you have to type in the word O. If it is rectal diazepam, just type in the alphabet R. I'm waiting for your answers. Between the two. Yes, we can use, okay. Okay, so correct answer for prevention would be given as oral diazepam. For prevention, the answer would be given as oral diazepam. Yeah, clobazam is used, but in the MCQ, he will try to trick you by writing rectal and oral diazepam both, no? So your answer would be given as oral diazepam for prevention. But if he says what is useful for acute episode, then for acute episode, we have like rectal diazepam, obviously. But wherever possible, if he gives in the option and he wants to make it easy, then your answer would be given as intranasal midazolam. Do take care of the fact that if he says acute episode, only then the answer of yours would be given as intranasal midazolam or rectal diazepam. Otherwise, for prevention purposes, it is oral diazepam that would be given. So in the exam, most people mess up between the two, and that is what was happening here also. Now is with respect to absence seizures. Yes, it is for prevention is oral diazepam along with paracetamol. Absence seizures is ethosuximide in children. But in atonic seizures, the drug of choice is sodium valproate. For GTCS also, it is sodium valproate. But if he talks about a female in a reproductive age group, and then he also says that this patient is scheduled to get married and there is risk of like her having neural tube defects, then to minimize the risk of neural tube defects, the drug that would be used would be levetiracetam, or we can be using lamotrigine as well. So do take care of the fact that if he specifically mentions female patient in the reproductive age group, then our answer would be given as levetiracetam and lamotrigine respectively. Good, very good. Okay, good. So I'm getting good response for these questions. Drug of choice for focal seizures, guys. Yes, drug of choice for focal seizure. If he says febrile seizure, I've already explained to you. If he's saying episode, then answer is intranasal midazolam. That is the preferred answer to be given. Otherwise, it is standard rectal diazepam only. For focal seizures, the drug of choices, there are many of them, right? But preferably we'll be using is carbamazepine. And then he can ask you about status epilepticus. He'll say, what is the initial treatment to be done? Here, patient would be having seizures for more than 5 minutes. Then the drug of choice in those circumstances for status epilepticus. It is CBZ as a first answer. No, the mnemonic is L-COP here. Like we use lamotrigine, we can use carbamazepine, we can use oxcarbazepine, we can use phenytoin in the patient. The mnemonic for that is L-COP, but then first answer is carbamazepine, right? Yeah, Steven Johnson can happen because of lamotrigine. It would not be skin peeling only, but it would be Steven Johnson is like a vesicobullous disorder, no? Yes, the first line answer would be given as IV lorazepam, and or we can give IV diazepam, whichever is available. And along with that, what you will also give to the patient is IV phenytoin infusion. So there are two things that you'll be doing. It is IV lorazepam with diazepam, and second would be IV phenytoin that would be used for management of status epilepticus initially. Midazolam is a little lower down the order if you check out the algorithm. So it would be better to answer it as lorazepam, diazepam followed by phenytoin. Okay. Next, we'll talk about transient ischemic attack in which we have a score by the name of ABCD2. And the parameters of this is the following ones: age, blood pressure, clinical features, duration, and diabetes mellitus. What they did was in the exam, in the older one, they changed it to history of stroke. So it's not a history of stroke. It would be clinical features of transient ischemic attack. That could be like aphasia, arm weakness, like weakness that is occurring in a patient. So ABCD2 score is done because we want to predict. I mean, the rationale behind ABCD score is to predict the percentage chances. It is not to diagnose anything. It is to predict the percentage chances of stroke occurrence in a patient. So once he just said, what is the reason for using ABCD to score? The answer is predict the percentage chances of stroke occurrence. And then in option number C, what you need to remember is clinical features or transient ischemic attack is the one that needs to be remembered. As far as management is concerned, there would be like a couple of drugs that would be used. I'll just mention the names of the drugs here. One is aspirin, that would be 75 milligram enteric-coated aspirin that has to be taken on lifelong basis for these patients. Along with the aspirin, the second medicine that would be used in these patients is ticagrelor. So aspirin and ticagrelor. Yeah, Priyanka, you're right for that percentage value, but at the moment it is DAPT, that is dual antiplatelet therapy, that would be used. Oral anti-clotting drugs are to be used, especially in those patients who are having atrial fibrillation because they can end up with stroke. So the molecule that we'll be using in atrial fibrillation patient to prevent the chances of stroke would be apixaban, and then we can be using atorvastatin. So there are three A's that I mentioned before you. The three A's are the three A's that I mentioned before you are aspirin, apixaban, and atorvastatin are three molecules which are used in transient ischemic attack. The star mark for point number two highlights that it would not be prescribed to everybody, but in those patients where you are able to document presence of atrial fibrillation, which is one of the leading causes of stroke, is where oral anticlotting like apixaban would be used. If he specifically mentions rheumatic heart disease, then it is warfarin, but otherwise for all patients, it is apixaban to be used. Now, because a patient with transient ischemic attack, where the cutoff of symptoms is 24 hours, यहाँ पे आई वांट टू मेक इट वेरी क्लियर बिफोर यू कि ये कोई गारंटी नहीं है कि 24 आवर्स में होगा. इट इज गोना बी 25 भी हो सकता है, 26 भी हो सकता है. बेसिक पॉइंटर रेजोल्यूशन ऑफ सिम्टम्स होना चाहिए. स्ट्रोक में कभी भी रेजोल्यूशन ऑफ सिम्टम्स नहीं होता है. सो ट्रांजिएंट इस्केमिक अटैक कब बोलेंगे? व्हेन देयर इज रेजोल्यूशन ऑफ सिम्टम्स. जो एग्जाम में क्वेश्चन था लास्ट जनवरी, उसमें रेजोल्यूशन ऑफ सिम्टम्स हुआ था ओवर 48 आवर्स. So lot of people answered that a stroke, which is not correct. Even lot of apps are giving a wrong answer there, and they are saying it is cardioembolic stroke in a patient. पहले तो cardioembolic मतलब कहाँ से imagine कर लेंगे कि cardiembolic हो गया patient को, right? And second is that stroke में अपने आप से ठीक थोड़ी ना होता है. Stroke will always cause some kind of deficit. No, it can be face deviation, arm deviation. So the main aspect for TIA is resolution of symptoms. 24 की जगह 25 घंटे में होगा तो ये नहीं है ना कि स्ट्रोक बोल देंगे. ये कोई मतलब ऐसे लक्ष्मण रेखा नहीं बनाया ना आपने कि भाई एक लाइन मैंने खींच दिया और बस इसके बाद में जो भी होगा तो उसको स्ट्रोक बोल देंगे. सो इट्स नॉट लाइक दैट. इट इज रेजोल्यूशन ऑफ सिम्टम्स दैट मस्ट अकर. तो द कोर एस्पेक्ट इज इफ ही सेज सिम्टम्स आर परसिस्टिंग फॉर मोर देन 24 आवर्स, देन इट इज स्ट्रोक. But if it is an improvement, then improvement can take 24 hours, it can take 22 hours, it can take 1 hour. Majority cases improvement will occur in 1 hour, but it can be longer also. Okay, जी. Acute ischemic stroke के लिए the cutoff to be remembered is the finding of acute ischemic stroke that you what you will get is hypodensity. The AIS का जो finding होता that would be hypodensity that would be seen initially. तो dense MCA sign है, फिर loss of gray matter white matter differentiation है, but then subsequently hypodensity will occur. लेकिन इसको finding को आने में usually about 6 hours लग जाते हैं. और अगर hyperdensity होगा तो then it would be ischemic stroke. In the first 6 hours, okay, in the first 6 hours for management of these patients, what we will do is thrombolysis. The only aspect to be remembered is कि thrombolysis के contraindications देख लेना. It's thrombolysis. The medicine that would be used in this case either is gonna be L-teplase given or it is gonna be tenecteplase. और उसके बाद में, well, like tenecteplase can be given as an infusion and tenecteplase can be given as a bolus directly in the IV line, and L-teplase can be given in the form of infusion. यहाँ पे बस ये देख लेना कि कॉन्ट्राइंडिकेशंस टू थ्रोम्बोलाइसिस ना हो, और मैं दो ही हाईलाइट कर रहा हूँ जो कि वो क्वेश्चन में डालता है. One can be BP can be more than 185 by 110 millimeter of mercury. Then your answer will be lower the BP first, then do thrombolysis. We will not do thrombolysis if BP is elevated. Second is bleeding diathesis. There are many more, but at least two that you need to remember for your exam is contraindications to thrombolysis are systolic blood pressure more than 185 by 110. Second is bleeding diathesis. You first have to lower BP and then do thrombolysis. And if he says ideally, within how much time thrombolysis should be done? So ideally the answer is 4.5 hours for window period. If he says upper limit, then answer is 6 hours. And if patient comes after 6 hours, please comment in the chat box. You guys been silent for a while. In a patient of AIS who's having like the case presentation would be most of the time contralateral face deviation. He will always say that this guy with atherosclerotic risk factors is having a contralateral face deviation. There is a presence of arm weakness in this guy. Along with the face deviation, arm weakness, there is speech deficits that could be occurring. So considering that face deviation, arm weakness, which has occurred in an individual, he's like a 65-year-old guy. He's having hypertension, he's having diabetes, all atherosclerotic risk factors, but he came after the window period of 6 hours. Then what will you do? Then the answer would be given as thrombectomy. Yes, guys, it's a simple, straightforward answer. It is thrombectomy, which is also written as EVT, that is endovascular therapy. So, very good. I think I got very correct answers there with respect to the aspects that I've said within 6 hours and 6 to 24 hours. Great. Yes, surgery within 14 hours is a big surgery in the previous 48 hours is a contraindication. But the core aspects are like at least two that should be remembered are the ones that I've highlighted at the moment. Next is the spot diagnosis. So I can expect you guys to comment on this one. You can notice that there is a very classical star of death appearance present here. So the diagnosis of this condition will be given as subarachnoid hemorrhage. Yes, thrombectomy is 6 to 24 hours. The star of death is for subarachnoid hemorrhage. The second feature that is present in the non-contrast CT head of this patient is blood in the sylvian fissure. Yes, guys. There can be presence of blood in the sylvian fissure with star of death, which is a classical manifestation that I've highlighted. And then he has asked, what is the next best investigation for this person? Then after non-contrast CT scan. Non-contrast CT scan was first done. If he says, what is the next best investigation to be done after a CT scan? Then answer would be given as cerebral angiography. The logic behind doing the cerebral angiography is to identify the site of berry aneurysm in this patient. The logic behind doing this is cerebral angiography. The treatment of choice for this is coiling. TOC of this condition, very good, is endovascular coiling. The cause of death in this person would be answered as vasospasm, that is of the surrounding blood vessels. Wherever the berry will burst in the surrounding area, wherever the berry is gonna burst in the surrounding areas, or the feeder vessel per se, if the berry will burst, the feeder vessel will exhibit a protective vasospasm. So that is the treatment. The treatment is not to be answered. Nimodipine is not available IV, guys. It is to be given orally. It is given by NG tube because patient's GCS can be low. So the treatment of choice for this patient is endovascular coiling. Don't answer drugs there. It is nimodipine that is answered as drug of choice. And why do we give nimodipine is because nimodipine is given to prevent the vasospasm in the patient. And the key pickup points in the MCQ would be presence of nuchal rigidity. There is no other brain hemorrhage in which nuchal rigidity will be given. There is no other brain hemorrhage in which nuchal rigidity is given. The only brain hemorrhage in which nuchal rigidity is given is the one that I have currently mentioned before you. Second, obviously, he can mention phrases like worst headache of my life, etc. But then at this moment, what I want you to remember is the keywords that I've highlighted, that is nuchal rigidity along with worst headache of my life. Actually, worst headache यार can be like हम लोग भी तो कई बार बोलते हैं ना इतना सिर दर्द कभी नहीं हुआ. So it's a very non-specific term that would be answered. Guys, thunderclap headache is not a answer to be given. Uh, Labetalol is not to be used, doctor. It is nimodipine. Na? It has a selective action on the blood vessels of the brain. No, I mean, why are we using nimodipine? is क्योंकि brain के blood vessels पे असर करती है ना. Thunderclap headache is subarachnoid hemorrhage or subdural hemorrhage. It is subarachnoid hemorrhage, na? It is thunderclap headache, subarachnoid hemorrhage, but thunderclap headache तो can occur in brain hemorrhage also, ना? Like किसी का intracranial hemorrhage हो गया, तो उसमें भी thunderclap headache का मतलब क्या होता है? Headache peaking within 1 minute. थंडरक्लैप हेडेक का मतलब क्या होता है? हेडेक पिकिंग इन 1 मिनट. जैसे मैं आपसे भी बात कर रहा हूँ, सडनली मैं अपना सिर पकड़ के बैठ जाऊँ, तो दैट इज व्हाट इज कॉल्ड एज थंडरक्लैप हेडेक. एंड दैट कैन अकर इन माइग्रेन ऑल्सो, दैट कैन अकर इन ब्रेन इन्फॉक्शन ऑल्सो. सो थंडरक्लैप हेडेक इज नॉट द बेस्ट वर्ड फॉर डायग्नोसिस, गाइस. यही बताने की कोशिश कर रहा हूँ. थंडरक्लैप हेडेक कैन बी अ प्रेजेंट. किसी को माइग्रेन का अटैक हो गया, मान लो कोई स्टूडेंट है, पेपर दे रहा है, पेपर के बीच में उसे माइग्रेन का अटैक चल रहा है, वो कह रहा है सर सडनली सिर में दर्द हो गया, मुझसे क्वेश्चन सॉल्व नहीं हो रहे थे, तो दैट इज थंडरक्लैप हेडेक अगेन. सो द की वर्ड इन द क्वेश्चन इज नॉट थंडरक्लैप, इट इज न्यूकल रिजिडिटी दैट इज टू बी यूज्ड, क्योंकि बाकी किसी ब्रेन हैमरेज में न्यूकल रिजिडिटी नहीं होता. The next patient is having lucid interval, that is consciousness between two periods of unconsciousness, and the CT scan in this patient is given. I'm waiting for your answers. Quick comments in the chat box, and I think this is one of the very easy and the spot questions that can be given to you. So let me know regarding what is the what is the type of bleed that is present in this case. Yes, guys. Lucid interval is given, and then you can see that there is a bleed also given in this particular case. So what are you gonna be focusing on that? Okay, guys, the answer is not extradural hemorrhage. भाई देखो तो सही क्वेश्चन को. जल्दबाजी क्यों कर रहे हो? Is it biconvex? No man, it is not biconvex, it is concavo-convex. Lucid interval दोनों में होता है बच्चे. I've explained this so many times that lucid interval is present in both extradural and subdural hemorrhage. Don't solve the question on extradural hemorrhage. That is the commonest mistake that people are doing, and that is why we're doing this session. That extradural hemorrhage is not डायग्नोज बाय लूसिड इंटरवल. लूसिड इंटरवल दोनों में होता है यार, एक्स्ट्राड्यूरल में भी होता है और सबड्यूरल में भी होता है. द डायग्नोसिस ऑफ दिस पेशेंट वुड बी acute because the bleed is white and the patient is having a concavo-convex bleeding, so it would be called as the acute subdural hemorrhage. In contrast, the same patient, if it is not treated, then you can notice it is becoming black area because the blood is getting reabsorbed. So if he will give you a similar kind of image and he says, what is your diagnosis? Then answer would be given as chronic subdural hemorrhage. So lucid interval is not to be used as a point for identification. It is the CT scan that would be used for identification. And in these patients, if there is neurological deficit present, then we will have to do a burr hole in these patients. The next case is of a person who's having a road traffic accident, like his car was jumping the red light. And when his car was jumping the red light, one car came and slammed into him. And then you can see multiple small bleeds in the brain. You can see multiple punctuate hemorrhages. The CT scan in this particular patient is showing multiple punctuate hemorrhages at various areas in the brain. Considering that there was a road traffic accident, there is a radiological finding of multiple punctuate hemorrhages present. Yes, the answer would be given as, waiting for answers from majority of people, multiple punctuate hyperdensities present at the junction of the gray matter and the white matter. That tells me that this is not a case where there is like an intracerebral hemorrhage, because these are multiple small injuries. The answer would be given as diffuse axonal injury, and it is conservative management in this case. I mean, we will have to put the patient on a ventilator. It is uh, uh, securing the airways of paramount importance. Positive pressure ventilation, control of pressure in the brain would be recommended for these patients. So we might have to do a ventriculostomy as well. And this is DAI. And in this condition, it is also possibility that CT scan can be normal also. Like if he specifically says non-contrast CT head is normal after an accident like this, then yes, it can be diffuse axonal injury in the patient as well. So very standard, straightforward CT scan that I have mentioned. And then is obviously the extradural hemorrhage that you guys are talking about. And that is where they would be like the source of bleeding would be middle meningeal artery. You can quickly comment on the treatment or choice of this condition. The person is having epidural hemorrhage. There is no posturing as of now. The CT scan shows a hematoma, and there is no posturing at the moment. Like if posturing is there, I'll obviously do a burr hole. But then the main treatment for this person would be, I mean, how would you ease off the pressure in the brain? And you can notice that there is like a subperiosteal bleed in this person. Yes. No, guys, will not do a burr hole initially. No, the main treatment for this guy would be that we will be doing a craniotomy in this person. That is a decompressive hemicraniectomy. And after a craniotomy, the second thing that we will be doing is ligation of the bleeder. So for any particular case where there is gonna be a situation of a epidural hemorrhage, there is no posturing at the moment, then there is no rush to do a craniotomy in a patient, or there is no rush for a burr hole surgery. Then what we can do is a craniotomy, and or we can do a decompressive hemicraniectomy. Please comment on the next CT scan, please. This that I have mentioned. I mean, don't answer hemorrhagic stroke. That is understandable. Can you tell me the type of bleeding that is present here? The following non-contrast CT scan, what is the type of bleed that is shown here? Yes, guys. Quick answers, please. ये ऐसा भी करते हैं, रेसिपी भी करते हैं. Yes, your answer would be given as intracerebral hemorrhage. So what you can see in this case is a non-contrast CT scan that is showing a intracerebral hemorrhage. भाई अगर आप खुद से यार CT scan करोगे तो 1 घंटा लगेगा. What we are doing is relatively faster here so that you can remember the main core aspects. And the reason for this is, yes, hypertensive bleeding is one of the leading causes here. और यहाँ पे अगर hypertensive crisis है, if the BP of the patient is grossly elevated and he says that what will you use to lower the BP, Then I've explained to you that this time it would be given as nicardipine and not to be mixed up with nimodipine. Drug toxicity that could be present here is like apixaban toxicity, or it can be dabigatran toxicity. Yes, the most common site of this is putamen. Drug toxicities can be apixaban or dabigatran toxicity. Quick answers there. Drug of choice for apixaban toxicity. Antidote for warfarin toxicity with intracranial hemorrhage. Dabigatran toxicity and warfarin toxicity with brain hemorrhage. Waiting for answers in this case. Yeah, we can use, okay, amphetamine abuse can contribute to situation. First is apixaban toxicity. Idarusuzumab is answer for dabigatran ना बच्चे फर्स्ट पहले वाला आंसर करो ना व्हाट इज द बेस्ट ड्रग फॉर apixaban toxicity क्विक आंसर्स ये तो फार्मा में पढ़ाते हैं यार इतनी बार पढ़े हुए तुम लोग यस it would be andexanet alpha okay fine moving to the second one the answer would be given as idarusuzumab and then is warfarin toxicity with brain hemorrhage waiting for answers once again treatment for warfarin toxicity with brain hemorrhage yes guys. Very good, very good. Treatment for warfarin toxicity and Dixonate alpha is cool. I am waiting for remaining people to comment on this one. Very good. Okay, okay. Vitamin K is coming up. Let's look at remaining people. Yes, it would be answered by you as prothrombin complex concentrate. So your answer would be given as 4-factor PCC. PCC stands for prothrombin complex concentrate. PCC stands for prothrombin complex concentrate. Very good. So these are like drug toxicities which can contribute to development of brain hemorrhage. Yes, guys, you can pick up in this particular case. Yes, vitamin K, prothrombin complex concentrate would be a better answer. Our next case is having cryptococcal meningitis. Please tell me the investigation choice. Comment in the chat box between 1 versus 2. Yes, guys. Cryptococcal meningitis or cryptococcal neoformans, comment between 1 versus 2. हाँ भाई आंसर्स बताने ना cryptococcal meningitis what is the investigational choice in this case no बच्चे it's not neurocysticercosis neurocysticercosis I'll show you the CT scan in a while okay what is the best test 1 versus 2 बोल दो ना यार बस आगे चलते हैं yes the main test for diagnosis in this case would be answered as CSF ELISA for cryptococcal antigen is the investigational choice आगे चलते हैं what is the drug of choice please comment from the 4 options D O C please. Yes, now the drug of choice guys. Indian preparation is not the best way. It is CSF ELISA or cryptococcal antigen. If this is not in the options, the second best answer as asked in your paper was lateral flow assay. He will always mention a AIDS positive patient and then he will say that he's having fever with nuchal rigidity. So as such, what I can say is cryptococcal meningitis will never be a challenge for you from the diagnostics perspective and the treatment part also. The treatment part would be that we will be giving this patient. Yes, we are going to be giving liposomal amphotericin B with 5-flucytosine. And if he says what is given for prevention, like he's already had it, no, his CD4 count was lesser. Then for prevention of cryptococcal meningitis, what drug would be used? So that he does not have it again. You have already treated this guy for a couple of weeks with intravenous liposomal amphotericin B and 5-flucytosine. What drug would be given for prevention of cryptococcal meningitis? The answer would be given as fluconazole. India Inc. is only a screening test for this condition. It is not the investigational choice. Lateral flow assay के बाद में आता है यहाँ पर इंडिया इंक प्रिपरेशन इंडिया इंक डायग्नोसिस के लिए क्योंकि अगर फंगल काउंट लो होगा ना तो इंडिया इंक फॉल्स नेगेटिव हो जाएगा तो इंडिया इंक इज द लीस्ट एक्यूरेट मेथड फॉर डायग्नोसिस नो बच्चे इट्स नॉट कोट्रामोक्साजोल इट इज नॉट कोट्रामोक्साजोल कोट्रामोक्साजोल इज आंसर फॉर जो कोट्रामोक्साजोल आप बोल रहे हो ट्राइमेथोप्रेम सल्फोमिथॉक्साजोल दैट इज आंसर फॉर न्यूमोसिस्टिस जिरोवेसी जो प्रिवेंशन बोल रहे हो ना इट इज फ्लूकोनाजोल यार फंगस है ना trimethoprim sulfamethoxazole would be answered by U5 prophylaxis for pneumocystis jirovecii जब तक CD4 काउंट है ना क्रिप्टोकोकल मेनिंजाइटिस में, जब तक CD4 काउंट कंटिन्यूसली 100 से ऊपर नहीं रहता है फॉर 3 मंथ्स, तब तक हम फ्लूकोनाजोल चालू रखेंगे. In a patient of cryptococcal meningitis, once he is recovered, to prevent the infection from occurring again, we are gonna give fluconazole prophylaxis. That would be till the CD4 count is more than 100 for 3 consecutive months. Cotrimoxazole would be answered for pneumocystis jirovecii. Okay, Ji. Quick recap here for normal, like normal CSF would be having anywhere between 0 to 4 lymphocytes. The sugar in the CSF will be two-thirds of the blood sugar, that is 0.6. The protein values will be in a range of 15 to 45 milligram. The opening pressure is gonna be like 15 to 180. And the color of the CSF will be totally clear. The unit that I mentioned in this case, 50 to 180, that would be in millimeters. This would be in millimeters of water, millimeters of water. For bacterial meningitis, you would be having lymphocytes, you will be having neutrophils. The number of these could be like 1,000 to 10,000 neutrophils. Never use the color of the CSF for diagnosis. वो तो turbid CSF होगा ही होगा, लेकिन the sugar values in this case would be low. The proteins would be elevated and opening pressure would also be elevated because there is like infection. So antibodies will cause proteins to go up. The CSF will block the flow. The pus will block the flow of CSF. So pressure will increase in acute bacterial meningitis. Can you comment in the chat box what cells would be seen in the CSF in tubercular meningitis? The usual case would be of a malnourished child. Usually he'll like begin with a PEM grade 3 child. He's having irritability, fever for 1 month, low grade fever, vomiting. He'll talk about poor oral intake, altered sensorium in the few couple of months. Yes, guys, what would be the cells that would be present here? Your answer would be that this would be lymphocytes that would be present in this case. So in case they give you lymphocytes in the CSF, the first thought process of yours would always be tubercular meningitis, and the sugar will be less, proteins will be super elevated, gross elevation of proteins would be present, and this would be clotting in the test tube. That's called as a cobweb coagulum. Even if that cobweb coagulum is not given, the protein in this case would be in grams. The protein value will be given in grams only because there's a super increased amount of proteins present. The pressure will increase and then the color will be either cloudy or will be straw colored. So as such, I can say that color is never diagnostic, but then it is the cells and the proteins that would help in identification. In viral meningitis, again, you can be having up to 100 lymphocytes per cubic millimeter. But as far as sugar is concerned, the sugar values will be normal. Viruses would not be metabolizing sugar, so sugar values would be normal, proteins would be elevated, the opening pressure would be elevated, and the color can be either normal, clear, or it can be cloudy also. So the point is viral meningitis sometimes can be having a clear CSF as well, but then as I said, color is never used for diagnosis. But one thing that you need to pay attention to is that the sugar values would be normal for viral meningitis. Then Guillain-Barré syndrome report will be one where everything would be normal, but proteins in the patient will be grossly elevated. So that's again an important point to be remembered. In Guillain-Barré syndrome, even if cells are given, the number of cells given would be like less than 50 cells. Even if cells are slightly elevated, they would be like less than 50 cells present, but it is proteins that will show a substantial elevation in GBS. That would be called as albuminocytological dissociation. Subarachnoid hemorrhage में वो बोलते हैं RBCs in the CSF. Rest of the things would be normal. Pressure obviously is increased, but there would be RBCs present in the CSF. So this table is again a high yield topic, and I think that tubercular meningitis is the one which is to be given a priority. अब ये वाली जो image आप देख रहे हो, this is neurocystic cirrhosis, guys. The next one that you're seeing is the one where the starry sky appearance is present. जो पहली वाली image है उसको बोलते हैं rice grain calcification. This image that is present is called as rice grain calcification. And the second one that you are seeing here is the starry sky appearance where the eccentric scolex would be present. The MRI in this case में जो lesion होगा वो ऐसे होगा, black spot होगी और black spot के अंदर में बाहर वाली साइड पे eccentric scolex present होगा. So it's a starry sky appearance with the rice grain calcification. Investigation of choice or imaging modality of choice in this case would be a contrast MRI. Contrast MRI में आप बोलोगे gadolinium enhanced MRI in the patient. Do not answer plain CT scan. Do not answer a plain MRI, gadolinium enhanced MRI. Then he'll say कि lumbar puncture में क्या करोगे, तो आपका आंसर होगा CSF immunoblot for neurocystic sarcosis antigen. So both have to be done. It is both lumbar puncture showing neurocysticercosis antigen with gadolinium-based MRI that will used for identification in MRI, especially the finding that you will notice will be what I've shown is the eccentric scolex. फर्स्ट लाइन ड्रग बोल दो फटाफट से फॉर न्यूरोसिस्टिसरकोसिस गाइस. Yes, first line treatment, first line drug for this condition would be answered by you as steroids, Dexona. It is dexamethasone that will be used in the patient initial treatment में. And subsequently Dexona के बाद में जो treatment algorithm है उसमें हम यूज करते हैं albendazole. और क्योंकि इसको सीजर्स हो रहे हैं तो सब्सिक्वेंटली डिपेंडिंग ऑन द टाइप ऑफ सीजर्स लाइक इफ इट इज जीटीसीएस देन इट इज सोडियम वैल्पोरेट दैट विल बी इंट्रोड्यूस्ड इन द पेशेंट. सो इट इज डेक्सोना देन इज albendazole and then sodium valproate. Once valproate is given, it would be given for almost 2 years. And then gradually, if the patient remains seizure free, then sodium valproate will be discontinued. But why are we giving dexamethasone is to decrease the cerebral edema? क्योंकि यहाँ पे you will notice कि जहाँ जहाँ पर भी there is gonna be like worm present, there is gonna be a cerebral edema component. So to reduce the cerebral edema component, I mean, why are we giving dexamethasone? That is to downgrade the swelling around wherever the lesions are present. So to downgrade the cerebral edema component, that is why steroids are being used. The next image that I'm showing you is showing IcePack test, which is a screening test for diagnosis of myasthenia gravis. Again, a topic that is always asked in the exam, MG, myasthenia gravis. The pickup points in the question will always be D's. इस सवाल में हमेशा D लिखा होगा. The D will be that a male more than 50 or a female less than like a young female, maybe in her 20s, she is coming with double vision, diplopia. Then he will also say speech issues, that is dysarthria, because vocal cords will also get tired. Even the tongue will get tired, so there would be dysphagia. एंड बिकॉज डायफ्राम का इन्वॉल्वमेंट हो जाएगा तो पेशेंट को सांस लेने में भी दिक्कत होगी. सो देयर वुड बी प्रेजेंस ऑफ डिस्निया. सो एवरी टाइम यू आर रीडिंग अबाउट अ यंग फीमेल इन अ 20s और you are reading about a man who's after 50s, like you know that Amitabh Bachchan was identified with myasthenia gravis. So the D's will be given in a question along with the special thing diurnal variation that again begins with D. जो सिम्टम्स होंगे वो सिम्टम्स इवनिंग में वर्सन हो जाते हैं. बाय डायर्नल वेरिएशन आई मीन द सिम्टम्स इन द पेशेंट विल टेंड टू इंक्रीज इन द इवनिंग आवर्स. दैट इज अगेन अ डायर्नल वेरिएशन. और इसमें रिफ्लेक्सेस नॉर्मल होते हैं इन स्पाइट ऑफ मसल वीकनेस. दिस इज द ओनली कंडीशन इन न्यूरोलॉजी वेयर you will read about diurnal variation of symptoms which are worse in evening with normal reflexes and still saying muscle weakness, because as we discussed in the starting of CNS, either it's gonna be muscle weakness present or there could be no muscle weakness. But यहाँ पे muscle weakness के साथ में reflexes normal होंगे. Lower motor में reflexes absent हो गए थे, upper motor में brisk हो गए थे, but यहाँ पे reflexes normal होते हैं. So all those D's have to be remembered. Last time in the paper there was a question on investigation of choice for this condition, तो आप मेरी help कर दो. Waiting for your comments. What is the investigation of choice for myasthenia gravis? Yes, examination finding is ptosis ना. Symptom तो सारे D वाले होंगे ना. He'll describe that asymmetrical ptosis. As you can see ना, one eye में ptosis ज़्यादा है as compared to the other eye. So it is the asymmetrical ptosis that is present. Yeah. The investigation of choice for this condition would be answered as single fiber. It is not heterophonium test. It is single fiber electromyography, which is the best test for diagnosis of this condition. If SFEMG is not given, then the answer would be given as repetitive nerve stimulation test. Let me do a screening test for this condition, please. Screening test. Edrophonium is not used for initial evaluation of myasthenia gravis patients nowadays. No, it is a single fiber electromyography and repetitive nerve stimulation test. If edrophonium was also given, that's not the answer, man. It is single fiber EMG that would be answered. Yes, guys, screening test for this condition. Quick answers, please. Screening would be answered as IcePack test, no? What you can see here, the screening test is IcePack test. Investigation choices single fiber electromyography. And then there's one more MCQ that says what is the most specific test, not sensitive. Sensitive is obviously IcePack, but it says most specific test for diagnosis of myasthenia gravis. Then the specific का जो answer होगा, that would be answered by you as the antibody.
that is anti-acetylcholine receptor blocking antibody that would be present in this condition is the specific test. So three questions. Screening is ice pack, and specific is anti-acetylcholine receptor blocking antibody, and then it's going to be single fiber electromyography. Treatment of choice for this patient would be thymectomy, that's agreed, which would be answered for the generalized variety of myasthenia gravis. Not for ocular myasthenia gravis, only for the generalized variety, we'll be using thymectomy. For the treatment part, we'll be using two drugs. One is going to be pyridostigmine, and along with pyridostigmine, the second molecule that we'll be using is steroids. But because steroids can contribute to Cushing syndrome manifestations, that is why steroid-sparing agents can be used here as well. That is like azathioprine or mycophenolate, or like backup drugs which would be used. Because this is autoimmune disorder, that is why we need to use these molecules at the moment. It is pyridostigmine with steroids. एंड थाइमेक्टमी से फायदा सिर्फ यही होता है कि जो स्टेरॉइड्स की रिक्वायरमेंट होती है ना वो कम हो जाती है. आई मीन वाई thymectomy is not curative, guys. I repeat this once again. Don't be under impression that thymectomy will be curative. The advantage of doing a thymectomy is that the need for medicines in these patients will reduce because thymus hyperplasia is the usual problem in these patients. Okay. Moving ahead, subsequently is GBS. Antibody that is seen in Guillain-Barré syndrome would be anti-GM1 antibody. As far as the progression of the disease is concerned, it would be ascending symmetrical flaccid paralysis. So I would like you to remember a mnemonic by the name of FAME, FAME, to remember the manifestations of this patient. Yeah, we can do a anti-musk antibody. Adrophonium बच्चे तब करते हैं when all the above tests are negative ना. Like adrophonium is done in, the statement I've said is adrophonium test is done in difficult to diagnose cases when all the above test, antibody test is negative, both anti-acetylcholine, anti-musk antibody is negative, SFEMG is inconclusive, repetitive nerve stimulation is inconclusive, IcePack test is inconclusive. In those cases where like the standard tests are not working, that is when you will be using adrophonium test as a backup. Alphabet F will be for flaccid ascending symmetrical paralysis. That is one of the highlight of this condition in Guillain-Barré syndrome. Always when a question will come, he'll give you an inciting event. The initial event can be like viral fever, Zika fever, or it could be food poisoning with Campylobacter jejuni. So that would be the trigger given in the question कि Zika virus या Campylobacter jejuni की पहले वो viral fever या food poisoning का story बताएगा. उसके कुछ weeks के बाद में flaccid ascending symmetrical paralysis. Along with this, there would be a special finding for diagnosis, that is albuminocytological dissociation, or you might write cytological albuminological dissociation, which means that proteins are elevated and the cell count would be normal. M would be for monophasic phase. What I mean by monophasic phase is that the progression in this condition can be as fast as within 12 hours. And sometimes the progression can go as long as, I mean, the progression of the disease can be slow and it can be going over 28 days. And alphabet E will be electrodiagnostic tests that would be done in this condition. Please comment in the chat box what is the electrodiagnostic test that is done in Guillain-Barré syndrome, in which we will be having demyelination of the nerves and the spinal cord. Yes, guys. What is the electrodiagnostic test that would be used in this condition? Electrodiagnostic test for myasthenia gravis. Yeah, sclerosing media का तो अभी रोल नहीं ना यार. By the time the patient will come to us, there would be like no Campylobacter jejuni infection, no, because there would be usually a period of about 2 to 3 weeks in which he's gonna be fine, and then these manifestations will occur. Decremental response, I think, Shubham, you're giving for the previous question, that is myasthenia gravis. For Guillain-Barré syndrome, it's a demyelination ना. So what is the test you will be doing? आपका आंसर होगा सर nerve conduction velocity करेंगे ना. The electrodiagnostic test that you'll be doing is NCV, that is nerve conduction velocity, and that nerve conduction velocity in this case will be showing us slowed responses, no decremental. Decremental is only for myasthenia gravis, but यहाँ पे it would only be a slow reflexes that would be seen. So FAME is to remember the manifestations of GBS, and then the treatment of choice for this condition is intravenous immunoglobulins. By the condition is having demyelination ना, तो आपको लॉजिक लगाना है कि डीमाइलिनेशन नसों के ऊपर में इंसुलेशन होता है, और नसों के ऊपर जो इंसुलेशन होता है उसकी वजह से ही तो स्पीड से इम्पल्स फ्लो करता है ना। तो अगर डीमाइलिनेशन हो जाएगा तो हम एनसीबी कर लेंगे, तो डीमाइलिनेशन का एविडेंस हमारे पास में आ जाएगा। सो द टेस्ट वी गोना डू इन दिस केस इज नर्व कंडक्शन वेलोसिटी, एंड देन द ट्रीटमेंट ऑफ choice is intravenous immunoglobulins, or we can go ahead with the second treatment also, that is changing the plasma of the patient. So we can also go for plex, that is plasma exchange or plasmapheresis as we would say, and both treatments are equi-efficacious. But intravenous immunoglobulin will always be preferred over plasmapheresis because I would say the setup required for plasmapheresis would be much more technically demanding. No, so it is like IVIG is expensive. That's okay, but then from the comparison perspective, like IVIG is much more easier to administer. There's no role of steroids man in GBS. Bladder and bubble का sparing होता है, bladder and bubble का sparing would always be present. And the treatment of choice for this condition, if single best answer is given, IVIG is also given and plasmapheresis is also given, then the answer would be given as IVIG. Antibodies against antibodies, now वो anti GM1 antibodies को basically resolve कर देगा. The paralysis will occur from top to bottom, as I said. But at the same time, while the paralysis is occurring from top to bottom, the bladder and the bowel in this patient would be spared. The most common जो cranial nerve इसमें involved होती है Guillain-Barré syndrome में, comment कर देना. Most common cranial nerve involved in patients of GBS would be, then your answer would be given as facial diplegia. ये जो क्राइटेरिया है ना बच्चे, ये क्राइटेरिया को ब्राइटन क्राइटेरिया बोलते हैं ना. दिस दैट आई एक्सप्लेन टू यू is what is called as Brighton criteria for diagnosis of GBS. Brighton criteria में चार चीजें होती हैं. अल्फाबेट एफ से याद करना. फ्लासिडिटी होती है, असेंडिंग सिमेट्रिकल पैरालिसिस. ए से अल्बुमिनोसाइटोलॉजिकल डिसोसिएशन. एम से मोनोफेजिक फेज है डिजीज का प्रोग्रेशन का, दैट इज 12 hours to 28 days. एंड देन इज इलेक्ट्रोडायग्नोस्टिक टेस्ट, दैट इज गोना बी नर्व कंडक्शन वेलोसिटी. ओके जी, नेक्स्ट बात करेंगे फास्टिंग नॉर्मल ब्लड शुगर कितनी होती है, एंड ऑलवेज रूल आउट हाइपोकलीमिया एज अ कॉज ऑफ पैरालिसिस. ओके जी, आईवीआईजी विल क्लियर द हार्मफुल एंटीबॉडी ना, जो एंटी जीएमएन एंटीबॉडी डीमाइलिनेशन कर रही है तो हार्मफुल एंटीबॉडी को हटा देंगे. सो यू आर गोना बी एबल टू रिमूव द हार्मफुल एंटीबॉडी फ्रॉम द बॉडी ऑफ दिस पेशेंट. ओके जी, फास्टिंग जो वैल्यूज होती है नॉर्मल, आई थिंक यू आर अवेयर ऑफ दिस. नॉर्मल वैल्यूज वुड बी, all values would be given in milligram, right? All values would be given in milligram per deciliter. What we prefer is plasma glucose over blood glucose. And why we are preferring is plasma glucose is because the RBCs will not be present. So sugar affected नहीं होगी. Normal value would be less than 100 and then would be less than, हेल्प करो मेरी, 75 ग्राम ग्लूकोज के बाद में 2 घंटे के बाद आपने सैंपल लिया इसमें ना, 2 घंटे के बाद वाला जो सैंपल लिया उसमें वैल्यू शुड बी लेस देन, यस गैस क्विकली, 2 आवर्स के बाद में जो सैंपल लेंगे, पर 2 आवर्स के बाद जो सैंपल लेंगे उसको बोलेंगे क्या, फॉर डायग्नोसिस और डायबिटीज mellitus इन अ पेशेंट. Subsequently, when you are evaluating, yes, the value would be given as less than 140. और ये 2 घंटे के बाद जो सैंपल होता है उसको बोलते क्या है. You made him drink 75 gram of glucose, and after 75 gram of glucose, like after 2 hours, you are taking a sample now. So what is that sample called as? Yeah, we are doing a oral glucose tolerance test. That is understandable. But what is the test called as? ओरल ग्लूकोज टॉलरेंस इज अंडरस्टैंडेबल. मैं ये वैल्यू बोल रहा हूँ, 2 घंटे के बाद वाली जो वैल्यू होती है ना उसको क्या बोलते हैं, या वी कॉल इट अ 2 hour वैल्यू. दिस वैल्यू इज नॉट कॉल्ड एज पोस्ट प्रैंडियल. पोस्ट प्रैंडियल इज नॉट यूजफुल फॉर डायग्नोसिस. ये क्वेश्चन था आपके एग्जाम में कि विच वैल्यू इज नॉट यूजफुल फॉर डायग्नोसिस और डायबिटीज मेलिटस, तो आंसर है पोस्ट प्रैंडियल. पोस्ट प्रैंडियल वैल्यू इज नॉट यूजफुल फॉर डायग्नोसिस गाइस. जो दो घंटे बाद वाली वैल्यू होती है ना उसको पीपी वैल्यू नहीं बोलते हैं, उसको 2 hour वैल्यू बोलते हैं. पोस्ट प्रैंडियल जो वैल्यू होती है दैट इज बेसिकली यूज्ड फॉर मॉनिटरिंग और डायबिटीज. Postprandial value is used for monitoring of diabetes. It is used for follow-up of a patient. It is not useful for diagnosis. This was the question. Which value is not used for diagnosis of diabetes? Answer is fasting and 2 hour value is used, but postprandial value is not used. Then you'll come across patients जिनमें जो values रहेंगे वो between 100 to 125 हो सकते हैं. If the values between 100 to 125 in English, we will call it pre-diabetes. In English, we will call it pre-diabetes. Can I have the technical answer? If the value is between 100 to 125, you will call it impaired. So वो मेरे को fill up कर दो please. What will you say for values between 100 to 125? Yes, guys. We will call it I is impaired. आगे fill up कर दो. What will you say the technical word here? यस यस, वेटिंग वेटिंग वेटिंग। या इम्पेयर्ड के आगे बोलो ना, इम्पेयर्ड क्या बोलेंगे? इम्पेयर्ड ग्लूकोज टॉलरेंस, इम्पेयर्ड फास्टिंग ग्लूकोज। यस। हाँ जी, नहीं नहीं, इम्पेयर्ड यहाँ पे बोलेंगे बच्चे, IFG बोलेंगे ना, इट इज नॉट IGT, इट इज इम्पेयर्ड फास्टिंग ग्लूकोज दैट यू विल बी आंसरिंग, इट इज इम्पेयर्ड फास्टिंग, IFG इज इम्पेयर्ड फास्टिंग ग्लूकोज। If the values are between 140 to 199, तब आप बोलोगे इट इज इम्पेयर्ड ग्लूकोज टॉलरेंस। तो दोनों एस्पेक्ट उसने पूछे हुए हैं भाई, ग्लूकोज पिलाने के बाद में कर रहे हैं तो इम्पेयर्ड ग्लूकोज टॉलरेंस हो जाएगा, और ग्लूकोज से पहले है तो इम्पेयर्ड फास्टिंग ग्लूकोज हो जाएगा। And the cutoffs are anyway obvious before you, that is fasting should be more than 126 and 2-hour values should be more than 200 for diagnosis of diabetes. If only fasting is present, then you should take more than one fasting value so that you come on to the diagnosis. Guys, this is IFG. This is IFG and this is IGT, and both terms do not mean the same. One is impaired fasting glucose and second is impaired glucose tolerance. So one, you need to remember the values. Then he'll ask you the diagnosis of, he will give you a case of diabetic ketoacidosis. आजकल के जो MCQs होते हैं उसमें वो स्मॉल ब्रीदिंग और fruity odor in the breath नहीं देता है. I mean, if he wants to make it easy, he will mention regarding small breathing, which is acidotic hyperventilation, and he will also mention regarding the fruity odor in the breath. But you will notice that nowadays के जो MCQs हैं उसमें तो ये दोनों चीजें दी नहीं होती हैं. तो if small breathing is also not given and fruity odor of the breath is also not given, then how do you diagnose? Then you need to look for triad. ट्रायड और डायबिटिक कीटोएसिडोसिस में तीन चीजें होती हैं. वन वुड बी रैंडम ब्लड शुगर. आपने कमेंट करना है चैट बॉक्स में, रैंडम ब्लड शुगर कितने से ज्यादा हो कि हम बोलेंगे कि पेशेंट को डायबिटीज है, डायबिटिक कीटोएसिडोसिस है. सेकंड फीचर तो आसान है, यूरिन में कीटोन्स प्रेजेंट होंगे या ब्लड में कीटोन्स, कीटोनीमिया हो सकता है या कीटोनूरिया हो सकता है. और फिर बाइकार्बोनेट की वैल्यू ABG की रिपोर्ट में कितने से कम हो कि एसिडोसिस बोलेंगे. सो वेटिंग फॉर आंसर्स. डायबिटीज बोलने के लिए the random blood sugar value should be more than how much? Yes, guys. या ABG विल बी डन फर्स्ट, क्योंकि ट्रायड ही सेटिस्फाई नहीं हुआ ना. R3 आपने बोला कि विल यू फर्स्ट गिव फ्लूइड्स या फर्स्ट यू विल डू ABG. तो अगर ट्रायड ही सेटिस्फाई नहीं हुआ तो डायबिटिक कीटोएसिडोसिस तो बोल ही नहीं सकते. ये तीनों चीजें होनी चाहिए ना, D भी होना चाहिए, K भी होना चाहिए और बाइकार्बोनेट भी होना चाहिए. हम डायबिटिक कीटोएसिडोसिस का डायग्नोसिस बिना ABG तो बोल ही नहीं सकते ना. दैट इज वाई इन द MCQ द आंसर इज गिवन एज फर्स्ट ABG, बिकॉज अगर आपके पास एसिडोसिस की रिपोर्ट ही नहीं है तो फिर आप डायबिटिक कीटोएसिडोसिस तो बोल ही नहीं सकते ना. सो आई होप इट मेक्स इट क्लियर. इट इज रैंडम ब्लड शुगर मोर देन 250, यूरिन कीटोन शुड बी प्रेजेंट एंड कीटोन की जो वैल्यू है दैट शुड बी लेस देन 15 मिलीकुलेंट्स. जब तक आप इसको डेमोन्स्ट्रेट नहीं करते, विदाउट डेमोन्स्ट्रेटिंग बाइकार्बोनेट टू बी लेस देन 15, you cannot say acidosis, and if diagnosis is not made you can't give fluids. सो इफ ही गिव्स यू कि पहले ABG करेंगे या पहले फ्लूइड्स देंगे, तो पहले ABG करेंगे ना, बिकॉज विदाउट ABG यू विल नेवर नो. और ABG में एक और चीज देखनी है, पोटेशियम. Without ABG, you cannot treat the patient, because one, I cannot diagnose the case. I cannot say acidosis. Second, I need to check out the electrolyte value, because electrolyte value in all of these patients will be low. So करना क्या है इसमें? Quick voting here, ABCD में से select कर दो what is the best treatment for this patient. Waiting for your answers here. Yes, yes, you're right. You'll first get an ABG done because tried satisfy करना है ना यार. फर्स्ट D फिर K फिर A, तीनों तो satisfy होना चाहिए ना. डायबिटीज के लिए RBS हो गया 250 से ज्यादा, फिर यूरिन केटोन्स हो गया, फिर एसिडोसिस हो गया. सो इट्स फर्स्ट ABG. यस गाइस, वोटिंग वेटिंग फॉर योर आंसर्स. Okay, I have had one answer there. I'm waiting for more people to comment in this question. I think it's a very straightforward one, guys. यस. इसमें सबक्यूटेनियस इंसुलिन यूज नहीं करते हैं, हमें इंसुलिन ड्रिप देना होता है, तो इस वजह से सबक्यूटेनियस इंसुलिन तो आता नहीं है. और अभी जो स्टैट इंसुलिन, बोलस इंसुलिन होता है, वो भी अभी आजकल यूज नहीं करते हैं. तो इसमें करना क्या है कि वी विल फर्स्ट गिव IV फ्लूइड्स टू द पेशेंट, और उसके 1 घंटे के बाद में इंसुलिन इन्फ्यूजन देंगे. द करेक्ट आंसर फॉर दिस वन इज ऑप्शन नंबर A. Guys, just read it carefully. Subcutaneous insulin will not be used. It is like infusion which is to be given, right? So it is infusion of insulin after 1 hour of IV fluid. The trick in the question is he's just played with English. First you will give IV fluid to the patient. Agreed. But here he has just played with English here. The answer for this question is option number A. Like, what is the first line management? It is normal saline, or we can use ringer lactate, but normal saline is preferred. And along with that, we will give KCl because potassium is low due to GI losses. And insulin will also cause redistribution. There is no role of soda bicarbonate. How do you treat the acidosis of this condition? The answer is insulin drip. The treatment of metabolic acidosis in this patient is not soda bicarbonate, it is insulin, because insulin will allow sugar to go inside the muscles. So burning of fats will stop and ketone production will stop. So if he says, how do you handle acidosis here? No need of soda bicarbonate, insulin drip is sufficient. And don't give potassium, do not give insulin drip if potassium is less than 3.3. First stabilize the potassium values and then give insulin drip to the patient. So it is NS and KCl that would be recommended. Then is insulin drip, and then you need to hold insulin drip if serum potassium is less than 3.3. Quickly comment in the chat box, PYQ, what is the leading cause of death in diabetic ketoacidosis? Very good. Leading cause of death in diabetic ketoacidosis, options were dehydration, ARDS. So for children with DK, the cause of death is given as cerebral edema. Don't answer as dehydration. That's an error that is given in some apps. It is cerebral edema. That is like the main reason for death in this patient. Okay, cool. So diabetes, DK is a must know for you guys. Then is Cushing syndrome, that is always asked in the exam. And there are 4 causes for Cushing. Either it can be steroids. I'll write down the causes meanwhile. And you guys can comment on screening test for Cushing syndrome. One cause can be iatrogenic steroids. Cause number 2 can be, person can be having an endogenous cause of pituitary adenoma. If it is not a pituitary adenoma, it can be ectopic ACTH production by lung cancer. And if it is not ectopic ACTH production by lung cancer, then the fourth and last cause will be an autonomous cause by the name of adrenal adenoma. There are a total of only 4 causes that are to be remembered: steroids, pituitary adenoma, that is Cushing disease, ectopic ACTH, and adrenal adenoma. Screening test for Cushing syndrome, 24-hour urinary cortisol. 24-hour urinary cortisol के बाद में नेक्स्ट जो टेस्ट करते हैं, 24-hour यूरिनरी कॉर्टिसोल के बाद में अगला जो टेस्ट करते हैं इसके डायग्नोसिस के लिए, दैट वुड बी DOT टेस्ट. DOT मतलब डेक्सामेथासोन ओवरनाइट टेस्ट. ये सीक्वेंस याद कर लेना. DOT स्टैंड्स फॉर डेक्सामेथासोन ओवरनाइट टेस्ट, क्योंकि नॉर्मल आदमी को अगर डेक्सोना देंगे तो इट विल कॉज सप्रेशन ऑफ कॉर्टिसोल, लेकिन कुशिंग सिंड्रोम में तो क्योंकि वो पेशेंट में ट्यूमर्स हैं तो उस वजह से कॉर्टिसोल बनता रहेगा. सो डेक्सामेथासोन ओवरनाइट टेस्ट विल फेल टू सप्रेस बिकॉज इट्स ट्यूमर्स ना, लंग कैंसर, पिट्यूटरी एडेनोमा, एड्रिनल एडेनोमा. सो डेक्सामेथासोन ओवरनाइट टेस्ट विल फेल इन दिस कंडीशन. अगर ये 3 टेस्ट दिए हो तो इन्वेस्टिगेशन चॉइस बोलो. स्क्रीनिंग टेस्ट फॉर दिस कंडीशन इज द फर्स्ट वन. तो एक तो मैंने हटा दिया. कैन यू लेट मी डू द इन्वेस्टिगेशन चॉइस फॉर दिस कंडीशन? डेक्सामेथासोन ओवरनाइट टेस्ट एंड देन इज मिडनाइट सलाइवरी कॉर्टिसोल. लेट मी डू द इन्वेस्टिगेशन चॉइस. DOT का मतलब होता है डेक्सामेथासोन ओवरनाइट टेस्ट. नॉर्मली तो हम डेक्सामेथासोन से सप्रेस कर लेंगे कॉर्टिसोल को, ट्यूमर तो सप्रेस नहीं होगा. 1 2 3 में कमेंट कर दो. नो, द इन्वेस्टिगेशन चॉइस इज मिडनाइट सलाइवरी कॉर्टिसोल, क्योंकि कॉर्टिसोल के वैल्यूज रात को कम होते हैं ना. रात को 12 बजे कॉर्टिसोल के वैल्यूज लीस्ट होते हैं. सो DOT नहीं बोला यार. एक टैबलेट से आप थोड़ी ना डायग्नोसिस. डेक्सामेथासोन एक बार खिला के तो नहीं कर सकते ना. यू नीड टू चेक द हार्मोन. यू नीड टू चेक द हार्मोन. सो मिडनाइट सलाइवरी कॉर्टिसोल इज द बेस्ट टेस्ट फॉर डायग्नोसिस ऑफ दिस कंडीशन, क्योंकि कॉर्टिसोल की वैल्यू रात को 12 बजे सबसे कम होती है और कुशिंग सिंड्रोम में वो रात को बढ़ी हुई होगी. Then is asked regarding dexamethasone suppression test is ये जो हाई डोज डेक्सामेथासोन सप्रेशन टेस्ट होता है. हाई डोज डेक्सामेथासोन सप्रेशन टेस्ट इज नॉट यूज्ड फॉर डायग्नोसिस, इट इज यूज्ड फॉर etiological diagnosis. What I mean by etiological diagnosis is that it is used to differentiate between pituitary adenoma versus lung cancer. कि पिट्यूटरी एडेनोमा है या लंग कैंसर है, उसको डिफरेंशिएट करने के लिए हम हाई डोज डेक्सामेथासोन सप्रेशन टेस्ट को यूज करते हैं. तो ये डायग्नोसिस नहीं है, ये कॉज को पता लगाने के लिए. Highest dose dexamethasone suppression test is successful in pituitary adenoma. What I mean by successful is that there will be partial suppression, क्योंकि पिट्यूटरी है ना यार, तो फिजियोलॉजी को रिस्पॉन्ड करेगी. सो आप बोलोगे पार्शियल सप्रेशन ऑफ ACTH हो रहा है, पार्शियल सप्रेशन ऑफ ACTH इज अकरिंग. लेकिन लंग कैंसर में तो देर विल बी नो, द वर्ड इज नो सप्रेशन ऑफ ACTH विल अकर. सो ये पॉइंट याद रखना है दैट बोथ ऑफ दीज हैव बीन आस्क्ड इन डिफरेंट सेशंस इन द एग्जाम. एक बार वो पूछा कि डेक्सामेथासोन सप्रेशन टेस्ट विल, हाई डोज डेक्सामेथासोन विल नॉट बी एबल टू सप्रेस ACTH प्रोडक्शन, इट इज लंग कैंसर. लंग कैंसर को तो नहीं दबा सकते, लेकिन पिट्यूटरी तो एक नेचुरल साइट है. तो पार्शियल सप्रेशन ऑफ एसीटीएच कैन अकर। तो बेसिकली सिर्फ इतना डिफरेंस याद रखना है आपको कि कहाँ पे पार्शियल सप्रेशन होगा और कहाँ पे नो सप्रेशन होगा। तो लंग कैंसर तो दबने वालों में से है नहीं, वो तो बड़ा मस्त मौला है, अपनी मर्जी से काम करता है। दैट इज वाई लाइक वी से नो सप्रेशन। देन स्क्रीनिंग टेस्ट फॉर फियोक्रोमोसाइटोमा। Yes, guys, quick answers, please. What is screening test for pheochromocytoma? It's a 24-hour test only. Your answer would be given as 24-hour urinary fractionated metanephrine levels. वो बात देख लेना कि कई ऐप्स में उसने क्या करा है, यहाँ पे फ्री मेटानेफ्रिन लिख दिया। इट इज नॉट फ्री, इट इज फ्रैक्शनेटेड मेटानेफ्रिन लेवल्स विच इज टू बी आंसर्ड। 24-hour urinary fractionated metanephrine levels is the first best answer for this condition, followed by 24-hour urinary VMA, that is venyl mandelic acid। अगर दोनों दिए होंगे तो पहले fractionated metanephrine बोलना। If he says what is the investigational choice for pheochromocytoma, then it is plasma, and this time it will be free मेटानेफ्रिन वैल्यूज। सो जस्ट टेक केयर ऑफ द फैक्ट कि वो ऐसा ना हो कि क्वेश्चन में घुमा रहा उल्टा कर दे। इट इज फ्रैक्शनेटेड मेटानेफ्रिन एंड प्लाज्मा फ्री मेटानेफ्रिन वैल्यूज दैट वुड बी यूजफुल फॉर इवैल्यूएशन ऑफ दिस पेशेंट। अभी तो यार वीएमए तो न्यूरोब्लास्टोमा में यूज होता है ना, ये मैंने रूटीन में समझाया भी हुआ है। न्यूरोब्लास्टोमा के लिए फर्स्ट आंसर वीएमए होता है, बट फियोक्रोमासाइटोमा के लिए इट इज फ्रैक्शनेटेड मेटानेफ्रिन फॉलोड बाय वेनियल मेंडेलिक एसिड। अगर दोनों दिए होंगे तो इस सीक्वेंस में आंसर करके आना, एज आई हैव एक्सप्लेन्ड। एडिसन डिजीज का इन्वेस्टिगेशन चॉइस ए से चालू होता है, उसको बोलते हैं एसीटीएच स्टिमुलेशन टेस्ट। और कॉन सिंड्रोम के लिए जो टेस्ट यूज होता है, आप लोग हेल्प करो मेरी। व्हाट इज द टेस्ट फॉर डायग्नोसिस ऑफ कॉन्स? कॉन्स विल बी हैविंग हाइपरटेंशन विद हाइपोकैलेमिक अल्कोलोसिस, क्योंकि एल्डोस्टेरोन वैल्यूज वुड बी एलिवेटेड। इट इज हाइपरटेंशन विद हाइपोकैलेमिक अल्कोलोसिस। Yes, guys. What is the investigation choice? Yeah, we will be using phenoxybenzamine pre-operatively. You are right. Post-operatively, like we will continue with मतलब अगर residual hypertension है तो then we can still continue with alpha blockers. Yes, ACTS stimulation test. Con syndrome is gonna be answered as saline infusion. The main test that we will do is saline infusion test or salt loading test for Con syndrome. Carcinoid का बताओ। 5-HT derivatives will be breaking down. So the keyword in the MCQs of carcinoid will always be flushing episodes. Along with flushing, asthma manifestations can be given. And from the heart perspective, there can be valvular lesion. The valvular lesion name would be TIPS, that is transjugular intrahepatic portosystemic shunting. TIPS is transjugular intrahepatic portosystemic shunting. In the urine, we will check for hydroxyindole acetic acid levels. HIAA levels would be used in the patient. Yes, guys. Very good. So these are like, quick answers for like the routine investigations that I've talked about, various endocrine tests. And like, if you get this data right, then you are on the spot for, the endocrine perspective. I think one TIPS का full form होगा tricuspid insufficiency and pulmonic stenosis. That's the valvular lesion that is seen with carcinoid syndrome. Okay, जी. Next we'll talk about pneumothorax, and pneumothorax के लिए जो keyword होगा MCQ में, that will always say absent air entry. But along with this, there would also be a percussion finding given. The percussion finding in the question would be hyperresonant breath sounds, because there is air at positive pressure in the chest, so hyperresonant breath sounds would be present. The examination finding that can be given in the question is this puffiness around the eyes of this chap, that would be subcutaneous emphysema. टेंशन pneumothorax कब बोलना है? When the word blood pressure is crushing. The reason why blood pressure is crushing is कि यहाँ पर जो एयर है पॉजिटिव प्रेशर पे, वो ग्रेट वेन्स को दबा देगी। तो टेंशन pneumothorax में टेंशन इसलिए बोलते हैं क्योंकि सुपेरियर वेना केवा क्रश हो जाती है, इन्फीरियर वेना केवा क्रश हो जाती है, सो फिलिंग ऑफ ब्लड इन द हार्ट इज लेस। सो टेंशन pneumothorax में टेंशन वर्ड तब यूज करते हैं व्हेन द बीपी ऑफ द पेशेंट इज क्रशिंग और अनरिकॉर्डेबल, दैट इज ऑब्स्ट्रक्टिव शॉक इज अकरिंग इन द पेशेंट। यहाँ पे वो हमेशा केस देगा जहाँ पे यू विल बी एबल टू सी द इप्सिलेटरल कोलैप्स्ड लंग, एंड देन यू विल बी एबल टू सी लंग विच इज मोर ब्लैक देन नॉर्मल, दे वुड बी एब्सेंट वेस्कुलर मार्किंग्स। और यहाँ पे वो बोलेगा कि भाई फर्स्ट लाइन इंटरवेंशन क्या होगी, तो यहाँ पे होगा वो नीडल जो आप बोल रहे थे कि भाई वाइट बोर नीडल डालेंगे। दैट वुड बी इन द फिफ्थ इंटरकॉस्टल स्पेस, दैट वुड बी आंसर्ड फॉर टेंशन pneumothorax। बच्चों में वो सेकंड है, एडल्ट्स वाले में फिफ्थ इंटरकॉस्टल स्पेस है, तो वो वाइट बोर नीडल वाला कॉन्सेप्ट हो गया ATLS के गाइडलाइंस को फॉलो करते हुए। And the needle will be put where? So answer would be in the triangle of safety. It is needle. It would be a wide bore needle that would be described. The space would be fifth intercostal space. It would be mid axillary line in the triangle of safety where the needle will be put. और उसके बाद में द नेक्स्ट थिंग दैट ही विल आस्क यू इज कि इसका अगला स्टेप क्या होगा, तो फिर आप बोलना ट्यूब थोरैकोस्टोमी। एमसीक्यू में थोरैकोटोमी दिया हुआ था, एमसीक्यू में थोरैकोटोमी दिया हुआ था। It is thoracostomy that would be done in this patient. And once the chest tube has been put, then the next thing that you will do is connect it to a underwater seal drainage, that is UWST. So the main treatment for tension pneumothorax to be remembered is, and this is usually a common question that is asked, it's a wide bore needle followed by a tube thoracostomy in the triangle of safety, and this is connected with underwater seal drainage. UWST, the underwater seal drainage, how will it look like? That is what I have mentioned at the moment before you. The underwater seal drainage will help in evacuation of blood as well as air. उसमें ये जो column है उसमें intermittent bubbling होती रहती है, तो that intermittent bubbling is telling me that the person is recovering. Tension pneumothorax का most common cause बता दो. What is the most common cause of tension pneumothorax? ICD is intercostal drainage tube that would be put. What is the most common cause of tension pneumothorax? Spontaneous pneumothorax is when that bulla will burst. Na? Spontaneous is when the bulla of emphysema will burst. Deviation of trachea is not a very reliable finding in X-ray. Na? The trachea will agree, it will show a contralateral shift in the patient. Yeah, like I've shown a tracheal deviation, right? I've shown a tracheal deviation to the contralateral side. So that's true, but that would not be a very reliable finding on X-ray. Yes, guys. Leading cause is not trauma, guys. Answer is trauma भी लिखा होगा और barotrauma भी लिखा होगा. Leading cause is ventilator associated injury. It is barotrauma which is the leading cause. लीडिंग कॉज इज नॉट ट्रॉमा. बैरोट्रॉमा भी लिखा है और ट्रॉमा भी लिखा होगा, तो आप बोलना बैरोट्रॉमा. बैरोट्रॉमा मतलब वेंटिलेटर की जो सेटिंग्स है ना वो ठीक नहीं थी, सो दैट कैन कंट्रीब्यूट टू अ टेंशन pneumothorax in a patient. Then is obviously trauma. I mean, I agree to that. One an important cause would be obviously physical trauma, penetrating injury to the chest that can cause a open pneumothorax. But then the number one cause would be answered by you as barotrauma. That's a ventilator associated damage that would be present. Then he will give you regarding an X-ray of pleural effusion in which you can see the meniscus sign with blunting of the costophrenic angle. As you can see, यहाँ पे one is that meniscus sign, the curvature, the concavity that is coming up. And second, what you can also notice in the X-ray in this case is blunting of the costophrenic angle. So in this particular case, what I want to do is, I want to do a thoracocentesis. You can help me with the site. Which is the site for thoracocentesis? Second space, fifth space, seventh space, and eighth space. 2, 5, 7, 8. Quick comments in the chat box with respect to what is the site where you will be doing a thoracocentesis. 2, 7, 9, 10. 2, 7, 2, 5, 7, 8. 2, 5, 7, 8. Select one. Yeah, hydrothorax and pleural effusion would mean the same. Yeah, we'll be going as low as possible. So the preferred site in this case would be the eighth intercostal space. Can you help me with the line, please? It's the eighth intercostal space. Yes, what would be the line that you'll be using? We go as low as possible. Exactly. Our line would be, the technical answer would be, it is eighth intercostal space. And the site where you put the needle is midway between the posterior scapular line and the posterior axillary line and the scapular line. The technical word is not posterior scapular, it is posterior axillary line. It is between two lines, posterior axillary, and then would be the scapular line. If both are given in options, then first answer it as posterior axillary line. It is midway between the posterior axillary and the scapular line. The amount of fluid that can be removed is upper limit of 1500 ml per day because of the risk of re-expansion pulmonary edema. And the site for prospecting the injury to the neurovascular border would always be the upper border of the inferior rib because of the damage to the intercostal vessel. So upper border of the inferior rib is the site where we'll be putting the needle. It is upper border, like if I take up an intercostal space, हर rib के नीचे से blood vessel जाती है, so it is upper border of the inferior rib that would be used. The second X-ray which is given in this condition, where the straight line is present, is because कि यहाँ पे fluid भी और air भी है. So you will say hydropneumothorax because यहाँ पे water और air दोनों होते हैं, तो that meniscus sign is lost. That would be a straight line that you can see. तो एक में curvature है, एक में it would be like a straight line present, so that X-ray can help you in identification. Then the last thing on pleural effusion that they will ask you is regarding Light's criteria. Light's criteria are used to differentiate between, then your answer is transudate versus exudate. मैं फटाफट से लिख देता हूँ. Exudate में क्या होगा कि pleural fluid में जो प्रोटीन की मात्रा है in Light's criteria, what you need to remember is कि जो pleural fluid में प्रोटीन की मात्रा है that would be more than 0.5, and pleural fluid में जो LDH का comment है या amount है that would be more than 0.6 times the value of the serum protein and the serum LDH values. If they give you a question in which these values are turning out to be like more than, they go in favor of exudate. I'll just highlight the arrows here. If the values are given like this, the values are going to be on the higher side. That is more than 0.5, more than 0.6. That tells you there is fibrin. That means there is exudative effusion. The causes of that can be like TB or it can be lung cancer. But if it is transudate, then there would be less, and that would be usually like a congestive heart failure. So one I have mentioned regarding like pleural effusion, 3 must know MCQs, the site of thoracocentesis, the site from the perspective of neurovascular bundle, and the amount of fluid that can be removed. Okay, you guys can quickly comment now. What is the bacteria causing community acquired pneumonia? Yes, more would be an exudate. ओके, लेस में भी ई आता ना तो इसलिए उसको ऐसे निमोनिक मत बनाओ. मोर इज एक्सुडेट, आई एग्री टू दैट. बट वो लेस में भी एक्चुअली ई तो आ ही रहा ना, तो उसमें गलती हो जाती है. तो आई थिंक बेटर इज फाइब्रिन याद करो. दैट इज लाइक फाइब्रिन इन द फ्लूइड दैट क्लॉट्स ऑन स्टैंडिंग. बट इट्स अ गुड अटेम्प्ट डॉक्टर, आई मीन नॉट डिस्करेजिंग यू, इट्स अ गुड अटेम्प्ट. ओके, कम्युनिटी एक्वायर्ड निमोनिया एक्चुअली वो यार जो प्रॉम्प्ट्स है ना वो हमेशा ही थोड़े से प्लस माइनस से रहते हैं. यस, कम्युनिटी एक्वायर्ड निमोनिया वुड बी न्यूमोकोकस. वेंटिलेटर वाला बताओ. वेरी गुड. Community acquired pneumonia is pneumococcus. You can see a patch in the X-ray. This is a right upper zone consolidation. We will also be discussing auscultation finding here, like when you will auscultate this chap over this area, then what is the auscultatory finding? But before that, please comment regarding leading cause of ventilator associated pneumonia, VAP. Yes, answer would be Pseudomonas. Leading cause of VAP, that is ventilator associated pneumonia, would be answered by you as Pseudomonas. And after Pseudomonas, the next one would be Acinetobacter. Auscultation finding बोल दो फटाफट से. What is the auscultation finding that would be encountered in right upper zone consolidation? Yes, the main auscultation finding would be bronchial breathing. It is not crepitations, it is bronchial breathing, which is the main auscultation finding in community acquired pneumonia. Then can be cystic fibrosis, in which there can be like F508 mutation with deletion of phenylalanine. The problem would be on chromosome number 7. It is autosomal recessive. If it is a child with cystic fibrosis, then the leading cause would be answered by you as Staph aureus. And if it is a teenager and an older patient, then the answer would be given as Pseudomonas. In cystic fibrosis, if he mentions a teenager or an older child, then answer it as Pseudomonas. But initially, the infection that will come up would be mainly Staphylococcus aureus. It's a defective protein is CFTR, cystic fibrosis transmembrane receptor, that will be responsible for malfunctioning of the chloride channels. So this is a chloride channel defect, as was asked in one of the MCQs, and the highlight will be pneumonia with malabsorption syndrome. Pneumonia with malabsorption syndrome. Then is a curve score of 0. If curve score is 0, then you'll be doing OPD treatment. If it is 1 to 2, then you will be provided that the patient the score is 1, then or 1 or 2, then we'll be going ahead with hospitalization. And if it is more than 2, then it is again hospitalization, but this time it would be ICU based care that would be required for this patient. So one, they'll ask you regarding uh, if nothing mentioned for age group, yeah, then first answer would be Staphylococcus aureus. ओल्डर पेशेंट्स नो, जैसे मेडिसिन में जो पेशेंट आते हो तो ओल्डर पेशेंट ही होंगे ना, तो वहां पे मैंने सूडोमोनास बता रखा है. बट इफ ही स्पेसिफाइज नो, जैसे कि अगर स्पेसिफाई कर दो तो अच्छी बात है. कुछ भी नहीं बोला तो स्टैफ ऑरिस बोलना कि बच्चे ज्यादा कॉमन होते हैं, बच्चे बच्चे ज्यादा कॉमन है. बाकी अडल्ट वाले जो केस आएंगे दे वुड बी लाइक सूडोमोनास. ओके, If the curve score of the patient is between 0, then it is an OPD-based treatment. If it is going to be 1 to 2, then it is hospitalization. If it is like more than 2, in those circumstances, it is ICU-based care. So antibiotic बता दो यार, curve score of 0 है patient का. Like in the question, the curve score is 0. So what antibiotics would you be giving for no comorbidity risk factors for antibiotic resistance? Quick comments here. Antibiotics that are given for community acquired pneumonia comorbidities. Yes, guys. भाई ये वाला जो सवाल है ये तो मस्ट नो वाला है ना? हाँ जी, यहाँ पे हमारा आंसर होगा अमोक्सिसिलिन. और अमोक्सिसिलिन के साथ में सेकंड जो देते हैं दैट इज मैक्रोलाइड, सो इट इज एजिथ्रोमाइसिन. So if there are no comorbidities or there is no risk factors for antibiotics, then two antibiotics would be given, amoxicillin with azithromycin. But if it is gonna be like with comorbidities, then it is amoxicillin. Along with this amoxicillin, we will be giving then augmentin. That augmentin that we would be using is like clavulanic acid. And along with this is azithromycin. So one, you need to just get the hang of the fact that macrolides have to be used because you need to give cover for atypical organism. And then the slight difference would be एक में amoxi और एक में amoxi with clavulanic acid है. But if the score given in the question will turn out to be 2, like suppose is giving you a score of 2, like man is like more than 65 years of age. And at the same time, he also says that the respiratory rate of the patient is like 36 per minute. So that makes it more than 30. I'll just write down the criteria also quickly. In those circumstances, you can comment on the antibiotics. Nowadays, we can also use CRB score. CRB would be that urea values will not be given, only respiratory rate would be given. बिकॉज मोस्ट ऑफ द टाइम जो रिपोर्ट होती है ना ब्लड यूरिया नाइट्रोजन की, उसको आने में टाइम लगता है. सो दैट विल कॉज अ डिले इन डायग्नोसिस. सो ही कैन से द वर्ड curb 65 score also. Like I'll just write it once again. One is obviously that curb 65. Second can be CRB score also. CRB is the confusion and the respiratory rate, the blood pressure values. And like if this guy is going into uremia, that basically means or elevated blood urea nitrogen. I can say that not exactly uremia, azotemia, but blood urea nitrogen is getting elevated. That tells you there is sepsis in the patient. हाँ एंटीबायोटिक बोल दो ना यार, क्या लिखेंगे? हाँ जी, तो यहाँ पे हमारा आंसर हो जाएगा आईवी फ्लोरोक्विनोलोन्स. आईवी फ्लोरोक्विनोलोन्स में क्या लिखेंगे? तो इट वुड बी लेवोफ्लॉक्सासिन. दैट वुड बी यूजुअली गिवन इन द पेशेंट. तो मोस्ट ऑफ द टाइम जो क्वेश्चन आता है उसमें इट वुड बी रेस्पिरेटरी फ्लोरोक्विनोन्स क्विनोलोन्स लाइक लेवोफ्लॉक्सासिन और मॉक्सीफ्लॉक्सासिन और जेमेफ्लॉक्सासिन. दैट वुड बी गिवन. बाकी इफ देयर इज रिस्क फैक्टर्स फॉर स्टाफ ऑरियस प्रेजेंट, like the person is hospitalized and then is having this pneumonia, then if risk factors for staph aureus are present, then we will add in this case linezolid. And if there is risk factors for pseudomonas, yes, ivacaftor is used for cystic fibrosis, yes. And if it is pseudomonas, then what antibiotic will be added, guys? Yeah, LMG is a good one. Pseudomonas के लिए क्या देंगे भी? Yeah, video will be available all the time. Pseudomonas, yes, guys. Antibiotic to be given in the patient, yes, guys. It would be meropenem. एंटीबायोटिक ये याद कर लेना यार, एंटीबायोटिक का चॉइस फॉर सूडोमोनास. हाँ पेप्टाज भी करते हैं बच्चे, बट दैट वुड बी लाइक देन इट वुड बी आंसर्ड एज मीरोपेनम एंड देन इज पिप्रासिलिन एंड टैजोबैक्टम. वो कैलकुलेशन में मत पढ़ना. मैंने बोला यार कि आजकल तो कर्ब 65 स्कोर को रिकमेंड कर रहा है ना. वो कहता है कि भाई आपको सीआरबी, जब CURB की जरूरत ही नहीं, आप CRB से इंटरप्रिटेशन कर लो. बिकॉज BUN की जो वैल्यू होती है उसको आइडेंटिफाई होने में या रेज होने में टाइम होता है. इवन जो लास्ट टाइम क्वेश्चन आया था उसमें सीरम क्रिएटिनिन दे रखा था. देयर वाज नो मेंशन ऑफ BUN. सो इट कैन बी कर्ब 65 एंड CRB स्कोर. दे हैव द सेम इंटरप्रिटेशंस. Both of them would be having almost similar interpretations. Okay, next is organism specific pointers in Legionella pneumophila. That would be SIDH का association होगा. So only MCQ for exam जिसमें person में इलेक्ट्रोलाइट इम्बैलेंस, निमोनिया के पेशेंट में इलेक्ट्रोलाइट इम्बैलेंस दे रखे थे और सीजर्स दे रखा था, दैट वुड बी लीगेनल्ला न्यूमोफिला. सफ्टाजिडिम नो इट्स नॉट यूज्ड ना, बिकॉज आजकल तो एमडीआर हो गया ना. सूडोमोनास मोस्ट ऑफ द टाइम जो आईसीयू में होगा वो तो एमडीआर है ना. क्योंकि हम तो आईसीयू बेस्ड केयर की बात कर रहे हैं, तो आईसीयू में तो सुडोमोनास एमडीआर होगा ना, तो देन इट इज नॉट सफ्टाजिडीन, इट इज मीरोपेनम दैट वुड बी यूज्ड. फर्स्ट आंसर इज मीरोपेनम, देन इज पिप्टास दैट वुड बी यूज्ड. Yes. The only question of your exam in which there is mention of hyponatremia in the question, that would be answered as Legionella pneumophila. The leading cause of nosocomial pneumonia is Staph aureus. आपने comment करना chat box में. You've been silent for a while. Yes, guys, hit the comment box. Staph aureus के radiological finding क्या है? You can notice that small ये छोटे छोटे cavities बन रहे हैं lung में. So like, small cystic cavities that can be seen in the right lung field and even in the left upper zone. So what is the radiological finding of Staph aureus pneumonia? Quickly, guys. Yeah, euvolemic hyponatremia. That's a good one. Legionella pneumophila. Yes, guys, radiological finding. Good one. Staph aureus की जो radiological finding होती है उसका नाम होता है न्यूमैटोसील. और इसके मैनेजमेंट के लिए हम लिनेसोलेड यूज करेंगे, बिकॉज न्यूमेटोसील को अगर मैनेज नहीं करेंगे तो देन व्हाट विल हैपन इज दीज न्यूमेटोसिल्स विल यूनाइट विद ईच अदर टू फॉर्म अ बिग कैविटी फिल्ड विद पस, and that big cavity that is filled with pus would then be technically called as lung abscess. So one of the important causes for lung abscess again is gonna be Staphylococcus aureus, where in the X-ray you'll be able to see the pus at the bottom and air at the top, so it would be called as a air fluid level. I mean, the radiological finding which is present here for lung abscess would be answered by you as a air fluid level. Then is Klebsiella pneumoniae, where you can notice a radiological finding that is called as bulging fissure sign. The radiological finding here would be called as bulging fissure sign. And along with bulging fissure sign, the hint given in the question can be that alcoholic is having red currant jelly sputum, and that helps you narrow down to a cause of necrotizing pneumonia, that is Klebsiella pneumonia. Anytime alcoholic with pneumonia, it is always going to be answered as Klebsiella. न्यूमैटोसील्स विल बी लाइक छोटा छोटा ना, दो मल्टीपल दिख रहे हैं ना, फिर वो यूनाइट करके, क्योंकि एब्सेस में तो एब्सेस में न्यूमैटोसील तो सिर्फ एक छोटा कैविटी होता है विच वुड बी नॉट हैविंग एनी पास, देयर वुड बी नो एयर फ्लूइड लेवल ना. न्यूमैटोसील को और एब्सेस को डिफरेंशिएट कैसे करते हैं, जैसे जो इस एक्सरे में दिखाई दे रहा है, इन द एक्सरे व्हाट यू कैन सी इन दिस पर्टिकुलर केस इज कि दो आपको छोटे कैविटीज दिखाई दे रहे हैं ना, दैट इज व्हाट इज टेक्निकली कॉल्ड एज अ न्यूमैटोसील. और फिर वो यूनाइट कर जाएंगे, तो आप देख रहे हो नीचे जो है लंग एब्सेस में. तो मतलब यार द पॉइंट इज, मतलब वी आर डूइंग दिस यूट्यूब सेशंस primarily to sensitize you to the core aspects, and it's good that you putting up that queries, because उससे थोड़ा सा it will become relatively easier for you when you are revising. देखो मतलब you guys can revise it yourself also, but at the same time what is the paramount thing is what I have currently explained to you. What I want you to remember is that pneumatoceles would be not having a air fluid level, but lung abscess would be having a lung abscess, would be having a air fluid level. Okay, cool. So let's move on to the next one, anaerobic lung abscesses. This would be mainly with respect to aspiration. इस सवाल में जो हिंट दिया होगा ना, वो लिखा होगा कोमाटोज पेशेंट. उसमें माइक्रो एस्पिरेशन और सलाइवा हो गया, या तो बोलेगा कोमाटोज या पार्किंसन डिजीज या अल्जाइमर डिजीज पेशेंट, या कोई भी न्यूरो डिजेनरेटिव डिसऑर्डर है, या पेशेंट जो है उसका जीसीएस जो है 8 से नीचे है. इन सारी चीजों में कॉमन चीज क्या होती है कि चाहे वो कोमाटोस बोले, पार्किंसन बोले, अल्जाइमर बोले या जीसीएस लेस देन 8 बोले, उन सारे के सारे पेशेंट्स में एक कॉमन चीज होती है, एंड दैट इज कि एयरवे रिफ्लेक्सेस जो होते हैं पेशेंट के, वो एयरवे रिफ्लेक्सेस सप्रेस्ड होते हैं. एंड बिकॉज दीज एयरवे रिफ्लेक्सेस आर सप्रेस्ड, so that is why micro aspiration of saliva can occur in a patient. So every time any of these three scenarios are given, and then he says person is having a development of abscess or patient is having pneumonia followed by a necrotizing pneumonia contributing to an abscess, then it is always anaerobes that are responsible. Or यहाँ पे it is not metronidazole, it would be clindamycin that would be given in the patient. It is clindamycin that would be used in this case. बाकी एक क्विक रिवीजन कर लेते हैं. यस, रिस्क ऑफ माइक्रो एस्पिरेशन इज देयर. Percussion note in pneumonia will always be dull. In pleural effusion, it will always be stony dull. And in pneumothorax, it will always be hyperresonant. It would be hyperresonant. So one you need to remember regarding The percussion note that would help you in identifying this dull, stony dull, and hyperresonant. Air entry pneumonia will be normal. The trachea in the patient would be central. There would be no tracheal shift. Trachea will be central. प्लूरल एफ्यूजन में कॉन्ट्रालेटरल शिफ्ट होगा, इधर भी कॉन्ट्रालेटरल शिफ्ट होगा. दोनों में डिस्टेंट ब्रेथ साउंड्स लिखा हो सकता है, बट द डिफरेंशिएशन बिटवीन द टू कैन बी मेड ऑन द बेसिस ऑफ परकशन नोट इन बोथ एमसीक्यूज. न्यूमोथोरैक्स में अगर वो खुद ही बोल देगा ना एब्सेंट एयर एंट्री, तब तो आपके लिए इजी हो जाएगा. In pneumothorax, if the whole lung is gone and he says absent air entry, then it is a piece of cake for you. But lots of time he will give you questions जिसमें वो distant, क्योंकि लंग का कुछ हिस्सा collapse किया, बाकी लंग तो काम कर रहा है. तो आवाज क्योंकि दूर से आ रही है, क्योंकि बीच में छाती में हवा भर गई है, तो आप बोलोगे distant breath sound. बट हाइपर रेजोनेंट परकशन नोट के बेसिस पे आप आइडेंटिफाई कर पाओगे. Let's attempt a question here. Yes, guys, quick inputs here for this particular question. 25-year-old guy had a bike accident. He's admitted for polytrauma. And then on the third day, he's having respiratory distress. SpO2 कम हो गया, and then he's wasting your time with vitals. मतलब obviously not wasting time, मतलब आपका time consume कर रहा है. BP is low. That's a cause of concern. Prominent neck veins are there, and you have to select between pulmonary embolism and fat embolism. So yes, guys. Let me know whatever you think is the most appropriate approach for this particular question. Yes. Okay, very good. I'm waiting for more answers, more comments. I'll just wait a few more seconds. You can notice that person is had a bike accident. That's a very good hint in the question. And post bike accident, he is having hospitalization for polytrauma along with breathing difficulty. So what you have to understand is कि क्योंकि उसका बाइक एक्सीडेंट हुआ होगा और उसके बाद इमोबिलाइजेशन हो गया, तो क्योंकि पेशेंट चल फिर नहीं सकता, तो उसकी वजह से उसको डीप वेन थ्रोम्बोसिस हो गया होगा. और डीप वेन थ्रोम्बोसिस का जो क्लॉट है, वो क्लॉट यहाँ से टूट के देन इट वुड हैव गॉन टू द लंग्स ऑफ द पेशेंट कॉजिंग पल्मोनरी एम्बोलिज्म. The correct answer for this one is option number A, and it is not fat embolism. A lot of guys have picked it up correctly. Fat embolism is not the answer because there is no GERD criteria given here. GERD criteria में क्या होता है? GERD criteria would mention that the X-ray of the patient. In GERD criteria, there would be breathing difficulty in the patient. So he should mention SpO2 is low. That is given in the question. But along with that, there should be coma, or at least the GCS of the patient should be described to be low. There is no mention of any unconsciousness. There is no mention of low GCS in a patient, no coma described. And most importantly, there is no mention of any petechiae. फैट एम्बोलिज्म में पेटिके होते हैं दैट स्टार्ट फ्रॉम द एक्सिला. सो वो तो दे नहीं रखा इस क्वेश्चन में. सो द पॉइंट इज दैट व्हेन यू से GERD criteria, then the point to be remembered is lung involvement, brain involvement, and petechiae. These are like the major criteria which are not given. इसलिए answer is not fat embolism. Helping you in the question will always be a clot also, will also be an image also. I initially did not disclose that image because I just wanted you to solve that clinically. But now you can see CTPA, that is CT pulmonary angiography, is showing a big clot bang in the middle of the pulmonary artery. ये जो आगे दिख रही है ये ascending aorta है, पीछे जो दिख रही है ये descending aorta है, ये vertebra हो गया. And then what you can notice is a big clot bang in the middle of the pulmonary artery. That would be CTPA, that is CT pulmonary angiography, which is gonna be the investigational choice for this condition. Which is investigational choice of this condition. Very good, guys. Let me help me out with the first investigation or screening test for this condition. First investigation. First investigation to be done in this case or a screening test that would be answered by you as D-dimer assay. D-dimer assay would mean that there would be D-dimer assay would basically mean that there would be an increased clotting tendency present in this case. See, because this is a hypercoagulable state, no? So that is why. Okay, fine, guys. D-dimer is a good one. Then he's asked, what is the non-invasive test to be done in this case to identify the cause? I think this was last January. He said non-invasive test to identify the cause. Then the answer would be given as Doppler of the extremities. It is Doppler of the legs that would be done in this case, Doppler of the extremities that would be done so that we can identify the clots. And then the investigational choices, what I've already said, that is CTPA, that is CT pulmonary angiography, that will be used for identification of this condition. Let me know the treatment of choice for this condition, guys. What is the treatment of choice? Yeah, duplex is a good answer, guys. What is the treatment of choice for massive pulmonary embolism? Very good. Doppler is non-invasive. That would let you know. And then CT pulmonary angiography would be done subsequently to demonstrate a thrombus. Very good. Waiting for your answers. Treatment of choice for massive pulmonary embolism. Very good. Very good. The correct answer for this one is what most guys have answered correctly. There's a big clot bang in the middle of the pulmonary artery. So yeah, use yes, inoxa and L-teplase is the main treatment for this guy. Enoxaparin subcutaneously, L-teplase would be used. And if he says plain pulmonary embolism, submassive pulmonary embolism, then it is plain enoxaparin that would be used in this condition. So for pulmonary embolism, it is enoxaparin subcut. But if it's gonna be massive pulmonary embolism, a big clot, then you're gonna give enoxaparin to the patient. And a lot of these questions would help you by mentioning clinical sign of deep vein thrombosis, that is Homan sign. Homan sign का मतलब होता है you will do an ankle dorsiflexion and that will cause calf pain in the patient. Another hint in the question was crushing of BP because there's blockage of the pulmonary artery. No, so no blood is going to lungs. So BP on the left side will also begin to fall. Main test for answer is CTPA, man. The investigation choice. ये तो यार जो डॉपलर है वो तो सिर्फ आपको डीप वेन थ्रोम्बोसिस बता रहा है ना, दैट इज नॉट डायग्नोसिंग पल्मरी एम्बोलिज्म. इफ ही सेज व्हाट इज द इन्वेस्टिगेशन चॉइस ऑफ पल्मरी एम्बोलिज्म, देन इट इज सीटीपीए. ही इज आस्किंग इसकी एटियोलॉजी के लिए क्या करेंगे, नॉन इन्वेसिव टेस्ट टू आइडेंटिफाई द कॉज. तो एटियोलॉजी की क्यों हुआ, यू नो द पेशेंट का रिलेटिव बोल रहा है भाई क्यों हुआ, देन इट इज डीप वेन थ्रोम्बोसिस. द इन्वेस्टिगेशन चॉइस इन दैट कंडीशन वुड बी आंसर्ड एज सीटीपीए for diagnostic purposes. And the echo findings in this condition, again a radiology MCQ of your exam, that is called as McConnell sign, because person will be having right ventricular failure where the clot in the pulmonary artery will cause obstruction, and therefore the pressure will the rise of pressure in the pulmonary artery will contribute to right ventricle failure. Now attempt this question again for the second time and you will realize how the answer will change. A 25-year-old guy had a bike accident, is admitted for polytrauma, and on day 3 he develops distress and becomes unconscious and unresponsive because now he's mentioning CNS findings. He's also telling you about vitals which are pretty decent, 100 with a blood pressure of 110/70, but petechiae are given in a question. Now the answer will change. Now you are noticing that the GURD criteria are being satisfied because lung problem is also there. CNS problem, like he's talking about the lung involvement here. He's talking about CNS involvement in this condition and he's showing appearance of petechiae. So a combination of this would help you identify that what we are dealing with is a case of fat embolism. So in these questions, always take care between pulmonary embolism is and fat embolism is always asked in the exam, guys. So I hope that you'll be able to get these facts right here, because this is one of the common scenarios of sudden onset respiratory distress that would be given. I mean, every time he talks about respiratory distress second, third day, pulmonary embolism, fat embolism में GWAD criteria लगाना, वरना उसके बिना में क्वेश्चन में हमेशा error of judgment हो जाता. Okay जी. Quick look, next one. You can notice proteins are urine में. So what we're discussing next is causes of nephrotic syndrome. मुझे mention कर देना what is the leading cause of nephrotic syndrome with respect to newborn babies. Leading cause of nephrotic syndrome in a newborn baby. Yes, guys. Child का तो मैं लिख देता हूँ. Answer would be given as minimal chain disease. That I don't think so will cause a problem in anybody. But if he says what is the leading cause in a neonate, then the answer would be given as Finnish variety of nephrotic syndrome, that is called as congenital nephrotic syndrome. बच्चे न्यूबॉर्न बच्चे का ना आप मिनिमल चेन डिजीज मत बोलना. For newborn baby, answer is congenital nephrotic syndrome, that is called as Finnish variety of nephrotic syndrome, जिसमें वो genetic mutations पूछता है. That is NPHS1 gene का mutation, which is gonna be coding for a protein by the name of nephrin. And second, there would be a problem of NPHS2 gene, that is podosin. The defect of these that I mentioned before you, NPHS1 gene and NPHS2 gene, the defects of nephrin and podocin are the ones which are responsible for the Finnish variety of nephrotic syndrome. तो जो बच्चे में है जन्म से वो फिनिश वैरायटी है, बच्चे में आंसर अगर चाइल्ड बोलेगा फिर मिनिमल चेन डिजीज बोलना, वरना NPHS1 और NPHS2 के हिसाब से बोलना। एडल्ट्स में बताओ व्हाट इज द लीडिंग कॉज ऑफ नेफ्रोटिक सिंड्रोम इन एडल्ट पॉपुलेशन। मिनिमल चेन डिजीज की लाइट माइक्रोस्कोपी फाइंडिंग भी बोल देना। व्हाट इज द लाइट माइक्रोस्कोपी फाइंडिंग ऑफ मिनिमल चेन डिजीज प्लीज। वेटिंग वेटिंग वेटिंग। लाइट माइक्रोस्कोपी फाइंडिंग इन मिनिमल, ऑप्शन दे देता हूँ, नॉर्मल एंड फूड प्रोसेसेस का लॉस। एक सिलेक्ट कर देना, नॉर्मल और एक हो गया फूड प्रोसेसेस का लॉस्ट। ओके ओके चलो अभी आते हैं, थोड़ा चैट डिलेड आता है मेरे पास शायद, तो इस वजह से। ओके हाँ, लाइट माइक्रोस्कोपी इन दिस कंडीशन विल बी नॉर्मल, तभी तो उसको मिनिमल चेन डिजीज बोलते हैं। लाइट माइक्रोस्कोप की जो फाइंडिंग होती है वो नॉर्मल होती है। इफेसमेंट नहीं बोलना है बच्चे, दैट इज आंसर फॉर इलेक्ट्रॉन माइक्रोस्कोपी। इफ ही सेज इलेक्ट्रॉन माइक्रोस्कोपी में क्या होगा, तो इलेक्ट्रॉन माइक्रोस्कोपी के लिए फिर आंसर करके आना, इट इज इफेसमेंट of the food processes of the podocytes. So for question, check out if it is gonna be light microscopy, then answer is normal. And if it says effacement of the food processes of podocytes, only then the answer would be given as like, I mean, the food processes to be answered for electron microscopy. Then is focal segmental glomerulosclerosis. इसका भी इलेक्ट्रॉन माइक्रोस्कोपी मुझे बताओ, व्हाट वुड बी द इलेक्ट्रॉन माइक्रोस्कोपी फाइंडिंग इन फोकल सेगमेंटल ग्लोमेरुलोस्क्लेरोसिस। EM is electron microscopy findings of FSGS. Yes, even in this case, he will talk about effacement or detachment of food processes of podocytes. So food processes of podocytes can be given in MCQs of both minimal chain disease as well as adults, but then you need to check out the age group in a patient, and there would be like presence of specifically nephrotic range proteinuria, where the amount of proteins in this case would be more than 3.5 grams. Yeah, they can be detachment, it can be effacement, they can be like swelling, ballooning of the food processes. So, I mean, different terms pathology people would be using, but the main point is food processes would be described. If he says what is the leading cause of focal segmental glomerulosclerosis, then it is HIV associated nephropathy. That was like the fourth question in the series. What is the leading cause of nephrotic in geriatric population? Then answer would be given as MGN. MGN would be called as membranous glomerulopathy. MGN stands for membranous glomerulopathy. That's the leading cause of nephrotic from geriatric population. And the reason why it occurs is because of an antibody that is called as anti-PLA2, PLAR antibody, that is phospholipase A2 receptor antibody. इलेक्ट्रॉन माइक्रोस्कोपी फाइंडिंग बोलते हैं ना मेम्ब्रेनस ग्लोमेरुलोपैथी का। वेरी गुड, एमजीएन का इलेक्ट्रॉन माइक्रोस्कोपी बोलना। यस गाइस, मेम्ब्रेनस ग्लोमेरुलोपैथी, electron microscopy finding to be commented quickly. Your answer would be spikes and electron dense deposits. These electron dense deposits would be in the basement membrane. And along with this, you'll also notice basement membrane spikes. So spike, like they might say spike and dome pattern, but like, yeah, you get electron dense deposits. And then along with this, basement membrane spikes would be present in MG, and that is membranous glomerulopathy. जितने भी किडनी के डिजीज है ना यार, उन सब की ना अभी बैठ के ना स्पाइक एंड डोम अपीयरेंस, मतलब इनमें करना क्या कि सबका ना ईएम का फंडिंग लिख लेना एक बार अपने से खुद की हैंडराइटिंग से, तो दैट विल मेक इट रिलेटिवली इजियर फॉर यू। किसी ने ट्राइम ट्रैक कमेंट किया था यार, वो तो एमपीजीएन के लिए होता है ना, मेम्ब्रेनो प्रोलिफरेटिव ग्लोमेरुलोनेफ्राइटिस, उसमें होता है वो ट्राइम ट्रैक अपीयरेंस। एमजीएन में तो इट इज गोना बी लाइक स्पाइक एंड डोम अपीयरेंस, एज पीपल हैव आंसर्ड वेरी वेरी नाइसली। Yeah, primary is idiopathic. Agreed, doctor. Primary would answer would be answered as idiopathic. And if he says secondary, very good input there. And if he says secondary, then it is HIV associated nephropathy. But if he says the word primary, then primary is idiopathic. But primary MGN would be answered as anti-PLAR antibody. True, doc. That's a point well taken. Leading cause of glomerulonephritis, yes, comment in the chat box whether it is Burgess disease or is it PSGN, post streptococcal glomerulonephritis. For completion, I can add another option, MPGN. So select between three, Berger, PSGN, and MPGN, leading cause of nephritic syndrome. That is glomerulonephritis. Yes, guys. Okay, leading cause of glomerulonephritis would be answered as no, it is not PSGN. It is leading cause of glomerulonephritis is Burgess disease. It is called as immunoglobulin A nephropathy. It is not PSGN, guys. The leading cause of glomerulonephritis in the world is Burgess disease. उसको immunoglobulin A nephropathy बोलते हैं. थोड़ा देख के पढ़ो. Leading cause of glomerulonephritis PSGN नहीं होता. Leading cause of hematuria बताओ. Yes, guys. Subsequently, the chat gave the correct answer there. Okay, what is the leading cause of hematuria? Blood in the urine coming in an individual, nothing else given. Leading cause of hematuria. Then answer would be given as kidney stones. And most of the time, the kidney stone that is present is calcium oxalate stone. And you can give a urine microscopic finding also of the same. That would be presence of these crystals. These would be called as envelope-shaped crystals. The number one cause of hematuria is kidney stones. That would be calcium oxalate stones with envelope-shaped crystals, as you can see. Then he has also asked regarding a bacteria that can contribute to development of stones, that is called as Proteus mirabilis. It's a urea splitter organism, and this will cause stones which are so big that they'll take the shape of the kidney. That is true white stone. ये इतना बड़ा स्टोन होगा कि एक्सरे में एक बड़ा सा व्हाइट शेड होगा अदरक के जैसे. जिंजर नहीं होता जैसे, वैसे अदरक के जैसे बड़ा सा व्हाइट शेडो मिलेगा एक्सरे में. एंड ये से कि ये स्टोन क्यों बना, तो आंसर है प्रोटियस मिराबिलिस. एंड इसमें जो स्टोन होता है, इसका जो क्रिस्टल होता है वो कॉफिन लेड अपीयरेंस होता है. You can see here that the crystal that would be present in this case would be an envelope shaped crystal. The X-ray will show a white color का stone, something like a अदरक के जैसे appearance होगा, like ginger basically, protuberance is present. Yeah, staghorn calculus, true white stone. Those are the technical terms that are used for it. Then if he talks about a smoker and he also talks about a query abdominal lump, then the first thought of process of yours would be workup for renal cell carcinoma. So hematuria in a smoker and lump abdomen, then we'll think in terms of possibility of renal cell carcinoma. That's triple phosphate, magnesium ammonium phosphate. If he says what is the leading cause of hematuria on recurrent basis, बार बार hematuria हो रहा है, खांसी जुकाम के बाद में स्पेशली बढ़ जाता है, then it is Burgess disease. Burgess disease में कभी renal failure नहीं होगा. Usually in Burgess disease you have is a good prognosis. You will not have oliguria. You will not have hypertension. But if he says कि patient को पहले तो पायोडर्मा या sore throat हुआ, और पायोडर्मा और sore throat के 2 से 4 वीक्स के बाद में पेशेंट का यूरिन का कलर चेंज हो गया, हेमचूरिया या कोला कलर्ड यूरिन. पर्सन का बीपी बढ़ गया, हेडेक हो रहा है उसको, तो हाइपरटेंशन, क्योंकि जीएफआर कम हो जाएगा तो रैस एक्टिवेट हो जाएगा और उसको यूरिन कम आना शुरू हो गया, ओलिगुरिया एंड यूरिया. इफ यू गेट दीज थिंग्स टुगेदर देन इट इज पीएसटी एंड दैट इज पोस्ट स्ट्रेप्टोकोकल ग्लोमेरुलोनेफ्राइटिस. सो पीएसटीएन में पकड़ने का तरीका क्या है? ही विल ऑलवेज से C3 levels are less. Another hint in the question for PSTN would be that he will talk about biopsy finding. Biopsy में light microscopy में तो लिखा होगा increased cellularity. He will say increased cellularity because there is neutrophilic infiltration. But then he will talk about immunofluorescence finding. That immunofluorescence finding is one of the keywords in the question, that is Tariska appearance. And then he will ask about antibody also. आप लोग मेरी help कर देना. This is seen after streptococcal infection. So which antibody will be present in the case? Yes, guys. Antibody that would be present in this case. Yeah, it is PSTN, post streptococcal glomerulonephritis. So what is the antibody that would be seen in this case? PSTN would be also written as PIGN, that is post-infectious glomerulonephritis. The presentation would be after a couple of weeks, never after days. अगर वो days में बोल रहा है, then it is gonna be always Burgess. Burgess में 48 hours के अंदर ही, इनफैक्ट days भी नहीं, hours में ही बोलेगा. तो Burgess में तो hours के अंदर में ही हेमचूरिया स्टार्ट हो जाता है. But in PSTN, it would be like couple of weeks, about 2 weeks onwards. Yes, the antibody that is present here is called as anti-DNA ACE antibody. It is not ASO antibody. ASO antibody is for rheumatic fever. And here the answer is not to be given as an ASO. No, guys, it is not ASO. It is anti-DNase and anti-hyaluronidase antibody, as somebody answered. Don't answer ASO. ASO एंटीबॉडी जो होती है उसको मैं अलग कलर से मेंशन कर रहा हूँ. ASO antibody is used in identification of rheumatic fever, and what I'm talking about is PSG, and that is post-infectious glomerulonephritis. This is always asked in the exam. Three things will be there. He'll describe it as a cola color urine. लास्ट टाइम का जो जनवरी का पेपर था उसमें कोला कलर नहीं लिखा था. उसने बोला था कि पेशेंट ने यूरिन का सैंपल पास किया है, सो इट वाज डिस्क्राइब्ड एज, क्योंकि फ्रेशली पास्ड यूरिन है ना, तो आरबीसीज बर्स्ट नहीं करेंगे. So it was described as smoky urine. In lot of MCQs, he may not say the word cola color urine because freshly passed urine sample will be having, there would be no destruction of RBCs. So it would be called as smoky urine, and then later on the cola color urine would be present in the case. And then there would be hypertension because GFR is less, because this is complement mediated damage to the glomerulus. So because of the damage to the glomerulus, what is going to happen in this case is that there would be low GFR that will cause RAS activation, तभी BP बढ़ जाएगा, and the kidney in the person will fail, so oliguria, anuria will be described. तो ये तीनों चीजें जब हो, that is hematuria, hypertension, oliguria, that is PSGN, also called as PIGN in the MCQ. PIGN would be post-infectious glomerulonephritis. नेफ्रोटिक एंड नेफ्राइटिक थोड़ा अच्छे से कर लेना, इलेक्ट्रॉन माइक्रोस्कोपी फाइंडिंग्स प्रैक्टिस कर लेना. आई नाउ टॉक अबाउट हेपेटाइटिस बी. हेपेटाइटिस बी का ड्रग ऑफ चॉइस मेंशन कर दो व्हाइल आई एम वर्किंग आउट अ रिपोर्ट बिफोर यू in which the security system is missing. Antibody against surface antigen is the security system. वो रिपोर्ट में दे रहा है IgM क्लास ऑफ एंटीबॉडी टू द कोर एंटीजन एंड सरफेस एंटीजन. तो जब दो चीजें एक साथ होती हैं तो हम उसको बोलेंगे acute hepatitis B. Waiting for your comments here. What is the drug of choice for management of hepatitis B here? Yes, guys. Very good. The drug of choice for management of hepatitis B is also used in HIV management, that is tenofovir. Another one that we can use is entecavir for management of these patients. एंटीबॉडी अगेंस्ट द सरफेस एंटीजन, ये एस वाली जो एंटीबॉडी होती है ये सिक्योरिटी सिस्टम होती है. ये जो सिक्योरिटी सिस्टम वाली एंटीबॉडी होती है इसको हम सीरो कन्वर्जन एंटीबॉडी बोलते हैं. जो एंटीबॉडी के सरफेस एंटीजन है, दिस इज कॉल्ड एज सिक्योरिटी सिस्टम, एंड द सिक्योरिटी सिस्टम इज व्हाट इज कॉल्ड एज सीरो कन्वर्जन एंटीबॉडी. एंड ओके, दैट TLD इज फॉर एड्स मैनेजमेंट ना. इट इज द, अभी तो हम इसकी बात कर रहे हैं एक्यूट हेपेटाइटिस बी की. And along with this, E antigen is also present. So because E antigen is present, you will say that the person is highly infectious. Acute hepatitis B, high infectivity is what I have explained in the first representation before you. For acute hep B, you need two things to be present: surface antigen as well as antibody to the core antigen. But if they give you a report in which you notice that surface antigen भी है, security system सोया हुआ है, सिक्योरिटी सिस्टम अभी जागा नहीं है, एंड इट इज IgG क्लास ऑफ एंटीबॉडी विच इज प्रेजेंट. तो क्योंकि अब यहाँ पे ये IgM IgG में कन्वर्ट हो गई है और सिक्योरिटी सिस्टम सोया हुआ है, दैट इज व्हेन वी विल से दिस इज क्रॉनिक हेपेटाइटिस बी. सो क्रॉनिक हेप बी के लिए भी दो चीजें होनी चाहिए. I'll just put pointers there. You need two things for identification of acute and chronic. And if I say surface antigen is positive, it is still gonna be answered as highly infectious. So second report is chronic hep B highly infectious. अब मैं आपको रिपोर्ट दे रहा हूँ और आपने मुझे आंसर बोलना है. यहाँ पे सब कुछ नेगेटिव है, सिर्फ IgG क्लास ऑफ एंटीबॉडी प्रेजेंट है, एवरीथिंग एल्स इज नेगेटिव. सरफेस एंटीजन इज नेगेटिव, एंटीबॉडी अगेंस्ट सरफेस एंटीजन इज नेगेटिव, IgG एंटीबॉडी इज द ओनली वन प्रेजेंट, एंड देन यू कैन नोटिस इवन द E एंटीजन इज प्रेजेंट. सो वेटिंग फॉर आंसर्स. इसको क्या बोलेंगे, मैं ऑप्शंस बोल रहा हूँ. ऑप्शंस आर window period, then I can say remote infection, and then I can say vaccinated individual. Please select one. Is it vaccinated individual? Is it a remote infection? Or is it window period? Yes. In this particular case, because IgG class of antibody is alone present, so we will say this is a remote infection. Patient had infection long time back and now everything is clear, but IgG class of antibody is present. But suppose I give you a report in which only IgM class of antibody is present. If it is only IgM class of antibody is present, that is where I'll say that the patient is lying in the window period. If only IgM class of antibody is present, then I will be saying that patient is in window period. The technical word for that would be gap period, where only IgM class of antibody is present. And the last permutation combination is, which I think everybody knows, so I don't need to say that, that is vaccinated. So it's very simple and straightforward, guys. First, try to handle these three questions that I mentioned at the moment before you. जहाँ पे अगर वो सिंगल रिपोर्ट देता है आईजीजी की, तो बोलना रिमोट इन्फेक्शन में। जैसे आपको कोविड हुआ 2021 में, तो आज 2025 में भी हो सकता है ना, आप में एंटीबॉडी टू कोविड प्रेजेंट हो, तो रिमोट इन्फेक्शन हो गया। आईजीएम हो गया गैप पीरियड। और अगर अगर सिर्फ सिर्फ सिक्योरिटी सिस्टम है, इफ ओनली द सिक्योरिटी सिस्टम इज प्रेजेंट, देन यू विल से दैट द पर्सन इज हैविंग presence of I mean that is a vaccinated individual. So that is step one, to get those negative वाला questions right in comparison to acute and chronic hep B. And mostly क्योंकि patients treatment लेते तो उन्हें ascites हो जाता है. So ये said, for detection of minimal ascites, puddle sign can detect more than how much ml of fluid, then your answer would be more than 100 ml. अल्ट्रासाउंड से तो हम उससे भी कम पता लगा सकते हैं, बट पडल साइन विल बी वेर यू कैन डिटेक्ट एज लिटल एज अबाउट 100 ml of fluid present in the peritoneal cavity of this patient. The investigational choice for this would be an ultrasound abdomen. Then he has asked, what is the first line management? Answer is salt restricted diet. After that, we will be giving aldosterone antagonist to the patient, that is eplerenone and spironolactone, either of the two, plus furosemide. Plus furosemide. That's the point to be remembered. It is with furosemide. And if it is medically refractory ascites, if he specifically says it is a medically refractory ascites, and he says that, what would he do? You can comment in the chat box quickly. What is the treatment for medically refractory ascites? Yes, guys. Your answer would be given as, you will remove the fluid in the peritoneal cavity. That would be a large volume paracentesis. So for medically refractory ascites, the intervention that is done is large volume paracentesis, where substantial amount of fluid in the peritoneal cavity is removed. And along with this, we will also be giving salt-free albumin. Do not answer low volume paracentesis here. Do not answer low volume. It is large volume paracentesis which is to be answered. It is LVP. It is large volume paracentesis, guys. Yeah, tapping. That is, tapping would be a little unofficial word. The technical word would be large volume paracentesis. And then he's given this image. You can see these dilated images. This is caput medusae. I mean, he did not say it is caput medusae. वो बोला ये क्या signify करता है? तो आपका आंसर होगा portal hypertension. This image shows presence of dilated veins around the umbilicus. That is caput medusae. इनमें जो फ्लो ब्लड होता है, दैट वुड बी ऑलवेज अवे फ्रॉम द अम्बिलिकस. यू कैन सी द फ्लो ऑफ ब्लड इन दिस केस वुड ऑलवेज बी अवे फ्रॉम द अम्बिलिकस. पोर्टल हाइपरटेंशन की डेफिनेशन अभी देख लेते हैं, बट विल कंपेयर दिस विद द सेकंड इमेज वेयर यू कैन नोटिस स्पाइडर नेवियाई. स्पाइडर नेवियाई को कहाँ पे देखते हैं? तो इट इज नॉट अराउंड द अम्बिलिकस, इट इज ओवर द शोल्डर्स ऑफ द पेशेंट. Superior vena cava distribution. Yeah, initially they would be like shifting dullness. If the fluid is less, then they would be fluid thrill present in a patient. But if the fluid is very large, then you may not be able to even get that shifting dullness. No, then if the fluid is very large in amount, you may not be able to get a shifting dullness present, and not even a fluid thrill. The location where spider nevi will be checked would be superior vena cava distribution on the shoulder. The hormone responsible for development of spider nevi is estrogen. और spider nevi जो है ये क्या इंडिकेट करता है? तो it basically indicates compensated liver cirrhosis. मैंने दो इमेज बेस्ड क्वेश्चंस बोले. स्पाइडर नेवियाई क्या सिग्निफाई करता है? सो इट इंडिकेट्स लिवर सेल फेलियर, इट इंडिकेट्स कॉम्पेंसेटेड लिवर सिरोसिस. लेकिन पोर्टल हाइपरटेंशन हो गया मतलब डीकॉम्पेंसेटेड सिरोसिस. तो दो इमेजेस हैं. अगर अगर वो अम्बिलिकस का फोटोग्राफ दे रहा है, डायलेटेड वेन्स है, कैपिट वुडूस है, देन यू विल से डीकॉम्पेंसेटेड सिरोसिस. इफ यू जस्ट से स्पाइडर नेवियाई, देन आवर आंसर either you can write spider neviae or you can write the word spider angioma. Both mean the same only. It can be spider neviae or it can be spider angioma. Any of the two can be described in the question. Diagnostic criteria for portal hypertension. Yes, guys, quickly, like, yeah, but can be present in, no, not pancreatitis, doctor, not, absolutely not in pancreatitis. Yeah, can be seen in pregnancy. That's true. Okay, what is the diagnostic criteria for portal hypertension? Then the value would be answered as more than 5 millimeter of mercury, more than 5 millimeter of mercury. And if he says bleeding will occur at, then answer would be given as value more than 10 millimeters of mercury. Quickly comment in the chat box what is gonna be best for prevention of bleeding esophageal varices. Best for prevention of bleeding esophageal varices. Yeah, 5 and 12 values are there. Quickly comment in the chat box, best for management of prevention of bleeding esophageal varices. या कलन साइन इज प्रेजेंट हो, उसको तो टर्न करेगा तभी होगा ना, कलन साइन जो है या ग्रे टर्नर साइन वो पैंक्रेटाइटिस के फीचर है ना. यस, मोर देन 12 बेस्ट फॉर प्रिवेंशन ऑफ ब्लीडिंग वेराइसिस गाइस. Okay, so we will answer first as EVL, that is endovascular ligation. EVL is the best way for prevention. हम ब्लड वेसल्स को लाइगेट कर देंगे, जो जो esophageal varices हैं, they'll be ligated. But if a person is not ready for the procedure, then I can be using nadolol in the patient, or I can use propranolol. If he says what is the drug of choice for this patient, then the drug of choice should be answered as one is somatostatin, that is octreotide, which can be given as an infusion. But for the you need an infusion pump in the hospital. Lots of time at peripheries when we are working, we will not have an infusion pump. So then I can be using terlipressin also, that can be given as a bolus shot. So it is just that depending on the facilities available, any of the two can be used. And if he says what is the first line management for bleeding esophageal varices, then first line management would be answered as massive blood transfusion. It is massive transfusion where we will be using 6 units of packed RBCs. I'll just write it as PRBC. That is 6 units of packed RBCs would be given. 6 units of fresh frozen plasma would be given, and 6 units of platelet-rich plasma would be given to the patient. So massive transfusion would be the first line intervention that would be done. We'll obviously give fluids to the patient, but the main treatment would be massive transfusion till the blood pressure comes up and we are able to prevent the triad of death. No, I mean the triad of death में क्या क्या आता है, चलो फटाफट से बोलो. What is the triad of death? Yes, triad of death would be, it would be acidosis. Acidosis के सिवा क्या होता है सर? अगर किसी को ब्लीडिंग हो जाए ना, तो ब्लीडिंग से क्या होता है, ब्लड लॉस होगा, शरीर से खून निकल जाएगा ना, तो बॉडी का टेम्परेचर कम हो जाता है. और बॉडी का टेम्परेचर कम होता है तो क्लॉटिंग नहीं होती ना, तो एसिडोसिस होता है, क्योंकि सर्कुलेटरी फेलियर हो गया तो एसिडोसिस. और क्योंकि शरीर से खून निकल गया तो बॉडी की गर्मी निकल गई तो हाइपोथर्मिया. और अगर हाइपोथर्मिया होता है तो हाइपोथर्मिया की वजह से क्लॉटिंग फैक्टर क्लॉट नहीं करते हैं तो कोएगुलोपैथी होती है, उसको हम ट्राइड ऑफ डेथ बोलते हैं. ट्राइड ऑफ डेथ इज ऑलवेज सीन विद ब्लीडिंग. इसमें एसिडोसिस है, हाइपोथर्मिया और कोएगुलोपैथी है. मैं रिपीट कर रहा हूँ इसको, मतलब इसके लिए निमोनिक वोमोनिक की जरूरत नहीं, लॉजिकली सोचना. बॉडी से ब्लड निकल रहा है तो सर्कुलेटरी फेलियर हो गया तो मेटाबॉलिक एसिडोसिस. और क्योंकि शरीर से ब्लड निकल गया तो खून, मतलब टेम्परेचर फॉल करेगा ना, बिकॉज ब्लड इज वार्म, सो पर्सन विल हैव हाइपोथर्मिया. और हाइपोथर्मिया से क्या होता है कि क्लॉटिंग सिस्टम बॉडी का ना ठीक से काम नहीं करता है, सो दैट कॉजेज ब्लीडिंग मैनिफेस्टेशंस, जिसको हम कोएगुलोपैथी बोलते हैं. चलो नेक्स्ट एक इमेज बेस्ड क्वेश्चन है, जहां पे आप नोटिस कर रहे हैं कि इस पेशेंट के फोरहेड पे और चीक्स पे ये कोमेडोन्स प्रेजेंट है. कोमेडोन्स के साथ साथ में आप लॉट ऑफ एरिथीमा और रेडनेस भी देख रहे हैं. तो आपने डायग्नोसिस मेंशन करना है. That the question mentioned, this lady has come to the hospital. You can notice a lot of comedones. You can notice a lot of erythema on the face of this patient. So what would be the clinical diagnosis in this particular case? Yes, guys. Yeah, ascites is metabolic alkalosis. That's a good one. Quick answers, guys. Spot diagnosis, please. No, no, guys. This would be answered as acne rosacea. If it is comedones, तो acne हो गया ना, और साथ में erythema भी है. So this would be answered as acne rosacea, because comedones तो SLE के रैश में होते नहीं है ना. ये जो SLE की रैश है उसमें तो बटरफ्लाई कॉन्फ़िगरेशन तो होगा, लेकिन उसमें फिर कोई कोमेडोन्स नहीं होते. नेजोलेबियल एरिया की जो होती है स्पेरिंग प्रेजेंट होती है. यू गेट स्पेरिंग ऑफ द नेजोलेबियल फोल्ड्स इन द पेशेंट. आप यहाँ नोटिस कर रहे हैं नेजोलेबियल फोल्ड्स का जो एरिया है उसमें तो मतलब ज्यादा रेडनेस प्रेजेंट नहीं है. सो ये वाला जो इसके साथ में प्रेजेंट है, दिस इज ओके. आई मीन दिस इज वेयर आई विल से that the person is gonna be having, यहाँ पे जो आप नोटिस कर रहे हो, that is what I can say as a malar rash. मेलास्मा में जो रैश होगी यार वो तो ब्राउनिश होगी ना. Like if they give a image in which, like they give a image in which you notice that the rash which is present is brownish. Like I don't have a brown color, so I'm trying to show a blackish brownish rash present. That is one that I will answer as melasma. But this is not melasma, no. This would be answered as acne rosacea, and then it's gonna be the malar rash of SLE. Okay, I'll do fast firing here. If he says screening test for this condition, SLE, then entry level criteria or entry level diagnostic criteria, it is antinuclear antibody. This is the most sensitive test. It is the screening test for diagnosis of this condition. Anti-Smith antibody is the most specific one, so that everybody knows. And double-stranded DNA is to monitor the severity of the disease. Like it is used to evaluate, like the disease can be having a waxing and a waning course. So if you want to monitor the course, if you want to monitor the disease, whether it is improving or whether it is worsening, then double-stranded DNA is used. But for diagnosis, it is ANA mainly and anti-Smith antibody is specific. एंटी रो रुलाने वाली एंटीबॉडी मतलब इट विल बी रिस्पॉन्सिबल फॉर कॉजिंग फोटोसेंसिटिविटी. इट इज द रैश. एंड साथ में जो उसने पूछा हुआ है, इट कैन ऑल्सो बी ट्रांसमिटेड फ्रॉम मदर टू बेबी एंड देयरफॉर इट कैन कॉज डेवलपमेंट ऑफ न्यूनेटल ल्यूपस. यू कैन कमेंट इन द चैट बॉक्स प्रेजेंटेशन ऑफ न्यूनेटल ल्यूपस क्या होगा. एंटी स्टोन वुड बी द ड्रग इंड्यूस एसएलई, राइट. दैट निमोनिक ऑफ शिप यू नो, तो वो मैं डिस्कस नहीं कर रहा, वो आपको पता है. न्यूनेटल लूपस का प्रेजेंटेशन बता दो. आई मीन व्हाट विल द बेबी डेवलप. न्यूनेटल लूपस का प्रेजेंटेशन क्या होगा, बच्चे को क्या होगा. यस, इट आंसर वुड बी गिवन एज कंप्लीट हार्ट ब्लॉक. कंप्लीट हार्ट ब्लॉक मतलब उसका जो एवी नोड है वो डिस्ट्रॉय हो जाएगा बाय एंटी रो एंटीबॉडी, सो द बेबी विल बी हैविंग ब्रैडिकार्डिया एट बर्थ. फिर एंटी फॉस्फोलिपिड एंटीबॉडी विल बी रिस्पॉन्सिबल फॉर रिकरेंट अबॉर्शंस and bad obstetric history in these patients. That would be antiphospholipid antibody syndrome, for which low dose aspirin would be required and heparin plan if she plans to conceive. But antiphospholipid antibody syndrome को एक बार obstetric से देखना, because we can आंसर तो मैंने बोल ही दिया कि लो डोज एस्पिरिन जिंदगी भर चलेगा एंटीफॉस्फोलिपिड एंटीबॉडी सिंड्रोम में, और हेपरिन देना है उसको फर्स्ट ट्राइमेस्टर में जब वो कंसीव करेगी, क्योंकि यूट्राइन आर्टरी में यहाँ क्लॉट बन जाते हैं, तो क्लॉट को बनने से रोकने के लिए इस वाई हेपरिन वुड बी गिवन. एंटी-एरिथ्रोसाइट एंटीबॉडी वुड बी ऑटोइम्यून हेमोलिटिक अनीमिया. उसके बाद में एंटीप्लेटलेट एंटीबॉडी है, तो उसमें तो थ्रोम्बोसाइटोपेनिया कर देगी, ब्लीड्स कर देगी. सो ही कैन मेंशन अबाउट epistaxis, he can talk about पटिके, bleeds, purpuras in these patients. Anti-neuronal antibodies will contribute to lupus cerebritis. आप लोग मेंशन करो अगले वाले के लिए. Anti-ribosomal P antibody will be responsible for which manifestation in SLE? क्लिनिकल मैनिफेस्टेशंस आप लोगों को आता है, उसमें ज्यादा ना जाने की जरूरत नहीं है. बट देन एंटी राइबोसोमल पी एंटीबॉडी, यस गाइस क्विकली, क्योंकि मोस्ट ऑफ द टाइम तो यही होता है कि भाई हम कहते हैं हमने एसएलई पढ़ लिया और एसएलई की एंटीबॉडीज जो हैं वो हमें आती नहीं है. सो वेटिंग फॉर योर आंसर्स गाइस, बिना नोट से देखे मुझे बताना विच एंटीबॉडी इज यूज्ड फॉर, आई मीन व्हाट एंटीबॉडी मैनिफेस्टेशंस विल इट अकर. एब्सोल्युटली, दिस वुड बी रिस्पॉन्सिबल फॉर, this would be primarily responsible for neuropsychiatric manifestations. And the neuropsychiatric manifestations in these patients can either be in the form of depression, or instead of depression, another one that will come to your attention, instead of depression would be psychosis. So these antibodies are like a must know ना. बाकी तो ऐसे लिखे फीचर में दिक्कत नहीं होती है, photosensitivity, rash, that's never a problem. If he says what is the most common body system involved in SLE? Yes, guys, can you let me know? Is it skin? Is it joints? Is it मैं लिख देता हूँ. What is the most common body system that is involved in SLE? Is it skin? Is it joints? Is it blood, that is RBCs? Or is it gonna be, let me say, heart involvement? So cardiac. So what is the most common involvement seen in SLE? Most common body organ involved in SLE. The most common organ involved in patients of SLE would be answered as joints. Most of the time जो patients आते हैं हमारे पास में, उनकी जो main complaint होती है वो musculoskeletal pain होती है. So the question will always begin with a female who's having like low grade fever that is on off and on. हल्के बुखार के साथ में उसको joints में pain रहता है. This would be mostly large joints like the knee joint. सबसे जो most common organ involved in SLE है, that is not the skin, guys. The most common organ involved in SLE would be answered as joints. So most of the time the patient will present with joint pain, and then she will start talking about her skin involvement. That is like when she goes out in the sunlight तो उसको photosensitivity है, और उसका जो hemoglobin है वो कम होता जा रहा है in spite of taking iron supplements, because it is an autoimmune hemolytic anemia. So gradually the question will evolve, but the commonest organ involved is the joints. And if he says what is the most common cause of death in SLE? Then the leading cause of death should be answered as kidney involvement. That would be answered by you as lupus nephritis. The number one cause of death in SLE would be answered as lupus nephritis. Okay, very good. I had very good answers there. Leading cause of death is lupus nephritis. That's if the diagnosis is not made, then death will occur. Na? So most common organ involved is joints, then is the skin, and the organ involvement contributing to death is lupus nephritis. इसकी light microscopy finding बोल दो और इसकी immunofluorescence बोल दो quickly. Light microscopy findings. Yes, guys. हाँ सेलेना गोमेज एग्जाम में तो नहीं आएगी ना. लाइट माइक्रोस्कोपी फाइंडिंग बताओ भाई. Yes, wire loop lesions. The light microscopy findings in this case would be wire loop lesions. And if it talks about immunofluorescence in a patient, then immunofluorescence finding in this would be called as a full house effect. Immunofluorescence findings should always be summarized in half a page so that you get them right. Next question is on dry eyes and dry mouth. This lady with dry eyes and dry mouth has been identified with S-Jogren syndrome. वो खुद ही बोला S-Jogren syndrome हम suspect कर रहे हैं patient में. So yeah, full house. And there are like 6 classes, but then the commonest one is the 4th class. So I get your point, Saurabh. Okay. A dry eyes and dry mouth, dry vagina in a woman, and she has been identified with S-Jogren. And he said that what is the test to be done in this particular case? This is one autoimmune disorder जहाँ पे हमारा जो आंसर रहेगा that would not be given as a antibody test but would be given as like no, that's what I'm trying to say. Antibody is not the answer here. In this particular case, it is a minor salivary gland biopsy. So we will be taking a sample from inside the lip of the patient. This is one autoimmune disorder where antibody, because anti-Ro antibody तो दोनों में होता है ना बच्चे. Anti-Ro antibody is found in SLE also, and anti-Ro antibody is found in this one also. So it is minor salivary gland biopsy. It is minor salivary gland biopsy that is used. दो ऑटोइम्यून डिसऑर्डर जहां पे बायोप्सी आंसर करना होता है, एक होता है डर्मेटोमायोसाइटिस और पॉलीमायोसाइटिस जहां पे मसल बायोप्सी करेंगे. टू ऑटोइम्यून डिसऑर्डर्स वेयर बायोप्सी इज टू बी आंसर्ड इज डर्मेटोमायोसाइटिस एंड पॉलीमायोसाइटिस. में डर्मेटोमायोसाइटिस लिख दिया तो आई डोंट नीड टू राइट पॉलीमायोसाइटिस. एंड सेकंड वेयर द बायोप्सी वुड बी एन आंसर वुड बी एस-जॉगरन सिंड्रोम. डर्मेटोमायोसाइटिस में मसल बायोप्सी करेंगे and muscle biopsy in both dermato and polymyositis. And S-Jogren is where we'll go ahead for a salivary antibody. So antibody is not specific ना. Lupus anticoagulant LA तो बोल रहे हैं, वो एंटी फॉस्फोलिपिड तो हो गई. तो दैट इज अगेन फाउंड इन SLE ना. ओके जी. उसके बाद में है स्क्लेरोडर्मा. तो स्क्लेरोडर्मा में स्क्रीनिंग टेस्ट बता दो पहले मुझे. स्क्रीनिंग टेस्ट फॉर स्क्लेरोडर्मा. पेशेंट विल बी हैविंग रेनॉल्ड्स फिनोमेनन. द की फीचर वुड बी रेनॉल्ड्स की ठंडे पानी में हाथ डाला. स्क्लेरोडर्मा का मतलब है फाइब्रोसिस बिलो द स्किन. सो देयर वुड बी लाइक रेनॉल्ड्स फिनोमेनन. एंड ही सेज कि भाई स्क्रीनिंग टेस्ट इसका क्या होगा. सो यस, स्क्रीनिंग टेस्ट वुड बी आंसर्ड बाय यूएस. यस, एंटी न्यूक्लियर एंटीबॉडी. अब इन्वेस्टिगेशन चॉइस बोल दो जो कीवर्ड है. He'll talk about like loss of creases ना. हमारे जो IP joints होते हैं, interphalangeal joints, उनका loss हो जाएगा. Sclerodactyly, they would be like very tight skin, tightening of the skin, Raynaud's phenomenon. So those are like very characteristic. बच्चे स्क्लेरोडर्मा के लिए जो एंटीबॉडी होगी उसका नाम होगा एंटी टोपोइसोमरेस एंटीबॉडी. It is anti-topoisomerase antibody, which is the main test for diagnosis of scleroderma. हाँ, anti-SCL70 is a very good answer, but वो थोड़ा सा easy हो जाएगा ना आपके लिए. तो he may not write anti-SCL antibody, it is topoisomerase antibody. इसका जो छोटा भाई होता है ना crest, वहां पे यूज करना ये वाला तरीका कि वो C से ना, C से crest syndrome है तो anti-centromere antibody would be answered there. It is anti-centromere antibody. मिक्स कनेक्टिव टिश्यू डिसऑर्डर की एंटीबॉडी बतानी है मुझे. यहाँ पे क्वेश्चन में SLE में मैलर रैश और फोटो सेंसिटिविटी बताएगा. देन ही विल टेल यू फीचर्स ऑफ स्क्लेरोडर्मा, दैट इज स्क्लेरोडैक्टाइली, रेनॉल्ड्स फिनोमेनन. And then he might mention features of even polymyositis and even rheumatoid arthritis. So if you get a question in which multiple autoimmune disorder के manifestations are given together, then you call it mixed connective tissue disorder, MCTD. And the question can be solved with simply by one antibody that is called as anti-U1 ribonucleoprotein antibody. And I'm writing this in bold to say that this should not be confused with anti-ribosomal P antibody, which I was discussing earlier in SLE for neuropsychiatric manifestation. Here the answer would be given as U1 RNP, that is ribonucleoprotein antibody. भाई जो मैंने एंटीबॉडीज बताई ना लूपस के लिए, उनको याद कर लेना, जो स्पेसिफिकली मैंने अभी अभी हाईलाइट करी हैं. एंड वी आर ऑलमोस्ट ऑन द लास्ट फ्यू स्लाइड्स हेयर. यहाँ पे मुझे डायग्नोसिस मत बताना, वो मुझे पता है, मुझे कॉज बता देना. व्हाट इज द कॉज ऑफ दिस कंडीशन? Options are autoimmunity, Chagas disease, lung cancer. What is the most common cause for bird beak defect on barium swallow? That is Achalasia cardia. Is it autoimmunity? Is it lung cancer contributing to this? Is it esophageal cancer that is contributing to it? Or is it Chagas disease which is contributing to it? The image is that of Achalasia cardia. We can see that bird beak defect, which you can see. So it's very classical. The question was like, what is the cause behind it? Waiting for your quick answers. 1, 2, 3, 4 में voting कर देना. It is U1 RMP antibody, no? The most common cause is autoimmunity, guys. It is not Chagas disease. Now, the most common cause for achalasia cardia should be answered as autoimmune destruction, and this autoimmune destruction will be causing loss of that nitrinergic neurons, which will cause loss of inhibitory control. तो इससे क्या होगा कि दो चीजें हो जाएंगी. एक तो ए पेरिस्टालसिस हो जाएगा. ऑटोइम्यूनिटी से क्या होगा कि जो इनहिबिटरी न्यूरॉन्स हैं, जो इनहिबिटरी सर्किट है ऑयरबैक प्लेक्सस का, वो डैमेज हो जाएगा. तो अगर मोटिलिटी नहीं होगी तो ए पेरिस्टालसिस और लोअर इसोफेजल स्फिंक्टर की जो टोन है वो बढ़ जाती है, तो खाना नीचे नहीं जाता है, तभी पेशेंट कहता है कि खाना फंस जाता है. सो मोस्ट कॉमन कॉजेस लाइक इंक्रीज इन द टोन ऑफ द स्फिंक्टर. चागस डिजीज जो है ना, उसमें तीन चीजें होती हैं. चागस में तो हार्ट की भी इन्वॉल्वमेंट होती है. वी हैव अ मेगा हार्ट, and then we have is a megacolon, and then we have is a mega esophagus. So Chagas disease इसलिए नहीं बोल सकते कि उसमें like you will not be having an isolated involvement of only the esophagus. No, even the heart and the colon would be involved, but by-side patient का only complaint is esophageal involvement. So it is HLS cardia, in which we do a laparoscopic Heller's myotomy with partial fundoplication. The next image, what you can see is again a barium swallow with an irregular filling defect. So we will think in terms of query squamous cell cancer of the esophagus. The question of last time exam was that what is the investigational choice for diagnosis of this condition? Waiting for your answers. Main test for whenever you're suspecting carcinoma esophagus, solid का जो खाना है वो नीचे नहीं जाएगा. Dysphagia will be more for solids as compared to liquids. Yes. हाँ, उसने पूछा, टेस्ट पूछा ना कि कैंसर इसोफेगस का डायग्नोसिस कैसे करेंगे. यस. इसको एप्पल कोर नहीं बोलते. एप्पल कोर जो होता है वो कोलॉन कैंसर में होता है. इसको एप्पल कोर नहीं बोलते हैं. एप्पल कोर इज फॉर कोलॉन कैंसर. आंसर वुड बी गिवन एज अपर जी एंडोस्कोपी. And along with this, we'll be doing a punch biopsy. Now, in the MCQ, we may not say the word punch biopsy, we may just say biopsy, but upper G endoscopy would be done in this case for diagnosis of this condition. फिर है diffuse esophageal spasm, DES, जिसमें corkscrew appearance है. इसका cause मुझे बता दो. He said, what is the cause for development of this corkscrew appearance in diffuse esophageal spasm, in which there is a dysmotility of the esophagus and the pressures are substantially increased. You can see segmental contractions. There would be chest pain occurring in this patient also. इसमें रैट टेल नहीं है ना. स्क्वेमस सेल कैंसर में रैट टेल नहीं होता. यही तो बता रहा हूँ कि रैट टेल जो होता है तो अडेनोकार्सिनोमा में होता है ना. दिस इज नॉट अ रैट टेल अपीयरेंस, बिकॉज रैट टेल इज व्हाट इज सीन इन अडेनोकार्सिनोमा. ही विल गिव यू द इमेज ऑफ स्क्वेमस सेल कार्सिनोमा व्हिच इज मोर कॉमन. डिफ्यूज इसोफेजियल स्पैज्म का कॉज क्या है यार? हाँ, इन्वेस्टिगेशन चॉइस भी बोल देना और कॉज बोल देना. कॉज इज इडियोपैथिक. ओके. And the investigational choice for this condition would be answered as high resolution esophageal manometry. It is high resolution esophageal manometry which is used for the discussion, which is used for this condition. Yes, guys. First question on the slide, please. Alcoholic is having multiple episodes. Well, I'll just correct the spelling here. This is esophageal manometry. For diagnosis, manometry will be helpful two times. One for diffuse esophageal spasm and second for HLS cardia, where the tone will be increased. Okay, guys, last slide for today. Alcoholic is having multiple episodes of vomiting followed by chest pain and subcutaneous emphysema. What is the diagnosis in this case? Yes, the answer would be 2, that is Boyer-Haave syndrome, because macular striate is getting satisfied in this question. Macular striate would be vomiting, and there is chest pain, and there is subcutaneous emphysema. Moving to the next question. multiple episodes of coffee grounds vomitus, blood pressure is low, and the spleen is enlarged. Yes, we are sorted for Boyraf syndrome. Let's move to the next one. Yeah, Maculars is satisfied. Yeah. In this case, there is coffee grounds vomitus. That means the blood has spent some time in contact with acid. The blood pressure is low because the blood pressure in the patient is low. And at the same time, there is gonna be splenomegaly that is present. तो ऐसे case में तो portal hypertension होगी because splenomegaly is one of the early findings that is seen in patients of portal hypertension. So the answer for this would be given as bleeding esophageal varices. The answer for this one would be 3. कभी भी डाउट होना मैलोरी वीएस में और पोर्टल हाइपरटेंशन में तो हमेशा बीपी देख लेना। अगर बीपी की वैल्यू अनरिकॉर्डेबल आएगी तो उसको बोलना ब्लीडिंग वेराइसिस, और अगर बीपी की वैल्यू मतलब रिकॉर्डेबल है तो फिर वो मैलोरी वीएस होगा। तो इसका जो अगला क्वेश्चन आप देख रहे हो उसमें क्या है कि वाइटल्स आर स्टेबल बिकॉज नॉन लाइफ थ्रेटनिंग ब्लीड है। तो अगर नॉन लाइफ थ्रेटनिंग ब्लीड होगा दैट इज व्हेन यू विल से इट इज मैलोरी वीएस इन अ पेशेंट। सो आई हैव गिवन ऑल द 3 सिचुएशंस। बीपी कभी भी अनरिकॉर्डेबल हो रहा है और स्प्लीनोमेगैली प्रेजेंट है, या फिर वो कैप अगर आसान करेगा तो you'll say caput medusa pedal edema, but otherwise these are the issues which are to be remembered. तो एप्पल कोर सिर्फ कार्सिनोमा किताब से पढ़ो, बेलियन लव से पढ़ो। तो बेलियन लव में एप्पल कोर नहीं लिखा होता है, वो कोलॉन कैंसर में लिखा होता है ना। किताब से पढ़ना होता है, टेक्स्ट बुक से पढ़ना होता है। अल्कोहलिक विद बिंज ड्रिंकिंग से नहीं सॉल्व होगा यार, वाइटल्स आर स्टेबल ना, दैट इज व्हाई यू विल बी एबल टू से इट इज मैलोरीवियस इन अ पेशेंट। सो इट्स नॉट अबाउट ब्राइट वेट ब्राइट रेड। ब्राइट रेड सभी में होगा, ऑल 3 विल बी हैविंग ब्राइट रेड ब्लीडिंग। Even bleeding varices will be having bright red bleeding. It is not bright red bleeding can be present even in portal hypertension. First episode of vomiting will be red and subsequently it will be coffee grounds in color because blood will spend some time with spend some time with acid. So don't use bright red blood for diagnosis. It is the vitals that would tell you. It is evidence of portal hypertension that is tell you. And next is alcoholic with severe abdominal pain, and then you can notice gas under the diaphragm. So since there is gas under the diaphragm, this is perforation peritonitis. You have to tell me the cause. The question was उसने पूरा ऐसा description दिया, alcoholic को severe abdominal pain हो रहा है, X-ray was showing gas under the diaphragm. He said, what is the cause? The question is not what is present. We can obviously identify perforation peritonitis. He says like what is the cause in this case. So that's the fourth and the last question on yes. Yes, answer would be PUD, that is peptic ulcer disease, is the reason why there is a perforation peritonitis in this individual. And in this case, we need to do exploratory laparotomy, and after a laparotomy, Graham's patch laga denge. That Graham's patch is the one which we will be, Graham's patch is that omental patch that would be using. So guys, this is my email ID, marwahmedicine@gmail.com, and it was really nice interacting with you guys today. So I think it was a longish discussion, but it should be worth the effort. And thank you so much for joining with me. And I wish you the not duodenal artery, man. It's not duodenal artery. This is not a gastroduodenal artery. ये तो anterior duodenal ulcer था ना, तो वो perforate कर गया. तो it's not a bleeding that's happening, man. At the moment, it's not a posterior duodenal ulcer. It's an anterior duodenal ulcer that perforated. So thank you guys. It was really nice interacting with you. You can join my Telegram group. Telegram group is given in the description of this video. And in case you don't get it, you can just send me a mail to me. I took a session yesterday also, guys, to explain this to you that you need to just keep on practicing questions. What we have done in previous 3 hours is discuss multiple topics, and I had very good inputs here. So I think you guys are pretty confident and raring to go. बस ये है कि अभी थोड़ा अपना स्लीप रिदम ठीक कर लेना, स्लीप वेल एंड ट्राई टू डू एज मेनी क्वेश्चंस एज यू कैन, एंड यू वुड बी डूइंग ग्रेट इन योर करियर्स। आई मीन देयर इज नथिंग टू वरी यार। मतलब टेंशन करने से अच्छा ये काम करेंगे ना, काम ये है कि भाई क्वेश्चन करेंगे, गलत हो जाएगा कोई बात नहीं, फिर भी करते रहेंगे। सो दैट इज द परसिस्टेंस इज द की। सो थैंक यू सो मच गाइस। आप लाइटिंग का सब लाइटिंग का असर है। ओके, थैंक यू गाइस, टेक केयर, बाय बाय, गॉड ब्लेस यू।